Thank you, Mr. President-elect. Good morning, everyone. You're most welcome yet again to our third day of the 2025 Annual Scientific Conference, Surgical Landscape Exhibition, the Charazi Memorial Lecture, which is one of the main events of today, and the AGM. You're welcome. Esteemed delegates, keynote speakers, and all guest speakers, protocol observed, you're most welcome again. Thank you so much for your sacrifice in time and resources that you pour into this organization. The scientific committee is not present, but I was to request them to join me on the platform. I think we have Professor Moses Galkande and Dr. Kakongulu, Dr. Chigonya, Ms. Alenyo, Dr. Flavia is in absentia. She will come. Honestly, for myself, I'll never stop saying that I'm so humbled working with this amazing team, tireless and fast forward thinkers. Your dedication towards ensuring that we deliver high-level scientific conferences that foster healthy multidisciplinary discussions, collaborations, among others, are impeccable. I can attest that ASAO is so proud to have you. This is a wealth of knowledge, and ladies and gentlemen, please, can you give a round of applause to them? This year, we really focused on the surgical education and how we can improve our surgical education to holistically improve patient care. And if you saw through our themes, we've tried to bring out things like innovation. What does it mean to work with other disciplines? What you've heard through these conferences, collaboration, collaboration, collaboration. If we are not together, if the disciplines are not united, if you're sitting in this room and you don't have the urologists, you don't have the nurses, you don't have the pathologists, you saw what Dr. Kakuba shared yesterday. It was basically practical experiences. So if we don't have that, we can't proceed. So we really want to focus on that. Key things like leadership in surgery, that is something that will be coming out a lot this year as well. Patient relations and community engagements, advocacy. You've heard the minister, the PAs all have told us, if we don't drum our drums, if you don't say enough what we do, no one will ever know, and they will never help us. So we hope that through this conference, we are all encouraged and motivated to do this and hopefully improve surgical care in this country. Yeah, I think I'll stop there. I was told to be brief, but thank you so much. We are honored to have all of you and our guest speakers. I don't know if someone from the scientific committee wants to say something, but thank you so much.
Thank you, Dr. Christine Namugenyi. Did you introduce yourself?
Oh, I'm sorry. I'm Dr. Christine Namugenyi. Yes, I've been the chair with my co-chair for the scientific committee. I think we've done it for the last 3 years. And I'm also the Association of Surgeons of Uganda General Secretary. Thank you.
Thank you, and thank you for being smart in that tan suit. So I would like to invite Mr. Epodoy, Joseph, Senior Consultant Urologist from Soroti Regional Referral Hospital, to come and take over the next session. He will invite the President to reintroduce our guest speaker.
Good morning, ladies and gentlemen. I'm so delighted to be in front here, in front of my respected teachers. I have my colleagues and everybody in the surgical fraternity. It's really very difficult to put off time amidst our busy schedules to come here for 72 hours. It's a great honor, it's a great pleasure. Every year this happens once. I really urge the colleagues, friends who have not been here last year, the last 3 years, that they are missing a lot. It's not about looking at people. It's not about eating good food. It's not about taking drinks, but issues of networking, meeting the big people in the country. The minister herself was here. How many people meet the minister? The PS was here. And we also learn from our elders. We also learn from history. We also learn from international faculty. And this is the purpose of these unions. It's really meeting people, connecting from Soroti. I cannot meet Professor Galukande. I meet him once a year. So Dr. Cotino, the guest speaker, I meet him once every 10 years. So thank you very much. I don't want to be another boring character here. The president of ASO, you're welcome. Kindly come over to the podium. I remain Dr. Joseph Epodoi from Soroti Regional Referral Hospital. Enjoy the day. Thank you very much. You're welcome, sir.
Good morning, ladies and gentlemen. You're very welcome to Day 3. And it's been an exciting past 2 days. There's a number of things that have stood out. We've gotten traction on NSOPs. The Permanent Secretary is pledged to receive our document in a month. Mukas has given us advice on how not to do it. We appreciate that. The minister has called us to keep knocking at her door for support for the association. Acknowledgement has been made that the work the association is doing is on behalf of the Minister of Health. So it's been great. My next task is to invite Dr. Alex Cotino to give us a keynote. I'd call Dr. Cotino a friend. I am trying to remember when we first met, but it must be over a decade ago. It's been great knowing you, and thank you for accepting our invitation. Dr. Cotino has practiced medicine and public health for over 4 decades, not only in Uganda, but on the continent. He's been involved a lot with the HIV/AIDS epidemic since 1982, when the first cases emerged, and has provided care and treatment services directed to HIV-positive people as a physician, as well as designed and led large-scale HIV prevention, care and treatment programs in more than 3 countries. He was also ED for TASO. This is an organization that supported or supports HIV work, where he built on the work of his predecessors to scale up care and treatment to over 100,000 Ugandans who are HIV positive. From 2007 till 2014, he was ED of IDI, Infectious Disease Institute, at Makerere in Kampala, where he led teams that scaled up care and treatment, providing access to over 100,000 HIV positive people in 8 districts in Uganda. And also a well-established male circumcision program, which reached out to over 140,000 young men over a 3-year period. And I was lucky to, he sucked me in, and I created a team that contributed 60,000 to that 140,000. In addition, between 2013 and 2018, IDI led this, the Saving Mothers Giving Life initiative in a population of over 800,000 in Western Uganda. And the intervention was able to reduce maternal mortality by 41% over 3 years and 44% over 60 months. He served as chair of the board of International Partnership for Microbiocides, based in Washington, D.C., and as a chair of the board of the International AIDS Vaccine Initiative, based in New York. Also, Dr. Coutinho served on the interim board for Global Fund in 2001 and served as vice chair of TRP in the Global Fund. His passion in global health, as well as leadership development and mentoring, is an articulate and compelling speaker, like you're going to discover, who has addressed many large-scale global health meetings with keynote addresses and presentations. And is lately supporting development of leadership management and governance skills. And Dr. Coutinho, we shall ask you to come some more to tell us issues of leadership in healthcare. Join me to welcome Dr. Alex Coutinho.
Right. Good morning, colleagues. Good morning, ladies and gentlemen. Thank you for the introduction, Moses. It's always a privilege to get these opportunities to speak, because the introductions are the kind that you would have listened to on your funeral, except you won't be there. So I get a preamble of what people might say. I also want to declare conflict of interest. Moses is my personal surgeon. He has looked into my abdomen, he has looked up my colon and other places, and I could not say no when he invited me to give this keynote address. But of course, it's a great honor to speak at the Associations of Surgeons of Uganda, and an even bigger honor to be asked to give the Chalwazi Memorial Lecture. Professor Chalwazi was my teacher in medical school in 1981 when I was a third-year medical student, and then later in 1982 when I was at the Cancer Institute. He would come to consult on solid tumors because I was working in the solid tumor, so I know him personally, and I will share a bit of what I know during the course of this talk. I've always wanted to be a surgeon. Now, those who are more senior in this room would remember me as a physiologist, because I used to be a physiologist at Makerere between 84 and 89. And part of my responsibility was to train future surgeons who are doing physiology as part of that. Those of you who know me later know me as a public health physician. But very few of you know that for 12 years I worked in Swaziland in a frontline hospital as one of 2 doctors, and was forced to become a rural obstetrician and a rural surgeon. I had actually been accepted into a surgical program in South Africa, but that's another story. But that frontline experience, sometimes learning how to do surgery out of a textbook, reminded me that perhaps my education at an undergraduate level could have been more practical in teaching me essential skills. But I've always wanted to be a surgeon. Even at the age of 55, Moses is the one who discouraged me. I wanted to join Coxexa program and reinvent my life. As it was, I ended up specializing in emergency medicine before I did public health. And so for 12 years, practiced emergency medicine, including surgery. What changed my life is that 30 years ago, I was moving into a position of leadership, and I was working for the private sector. And as part of that move, you had to go through a psychometric evaluation to see your suitability for leadership and management. The private sector does these things the right way. And I had a psychometric evaluation for 2 days, doing various tests and simulations. And at the end, the psychologist, had a PhD in psychology, called me and said, Dr. Coutinho, all your tests show that you have great potential as a leader. Of course, I was very happy. And then he said, but there is a gap. There is a gap you need to address. And he said, that gap is that you believe that the world rotates around you, that you are the center of the universe and everybody else has to rotate around what you think and what you want to do. Now, I'm not known for taking negative feedback well, as most of us probably are. So I pushed back. I said, really? He says, no, relax, don't worry. Most doctors are like that, especially surgeons and emergency medicine. Because the way we are trained is that we have to make life-saving decisions rapidly, sometimes without consulting, and we can often get into this habit of believing that the world rotates around us. And he said, if you want to become a leader, this must change. So if you remember nothing else about the Chalwazi Memorial Lecture this year, please remember this when you are reflecting on yourself, that to be the perfect surgeon, you can drive it as an individual. To be a leader, the world cannot rotate around you. You must be part of the team that drives towards that leadership. And so today, as I talk about Professor Sebastian Chalwazi, I'm going to be talking about leadership and a little bit about the work that I'm currently doing to build leadership capacity for health in Africa. So today, we are here to honor the man, the surgeon, the leader, and the legacy. I remember the first time that I met Professor Sebastian Chalwazi. He was one of those few surgeons that would encourage you to come as medical students into the theater and watch him operate. I can't remember what the operation was about. I definitely did not learn any surgery at all by crowding around the great man and his team. What I learned was the power of leadership, the power that he had in inspiring people, in building trust in his team to tackle some of the most complicated surgeries that he undertook. In those days, people used to say that the recovery rate of the kind of surgeries that Professor Chalwazi undertook was less than 50%, compared to other surgeons whose recovery rates were 80 or 90%. And they underestimated the kind of challenges that he took on. And this indeed was his mantle as a leader. And as I said in my first slide, leadership is a transformative gift. Transforms you. It's a gift to those that you lead well, because you can also lead badly. So it's a gift. All of us can remember good leaders, and we remember them with respect. But it is also a gift that you as a leader need to use with care and humility. And if you do your leadership work well, you build your legacy. And I want to thank the Association of Surgeons for sustaining the legacy of Professor Chalwazi through this memorial lecture. But yes, indeed, let's give a clap. But a legacy is not a lecture. It is an accumulation. It is built as a result of an accumulation of deliberate acts and a bit of good luck. And I will come back to that in terms of what I see particularly as the legacy of Professor Chalwazi. So for the last 10 years, I have transitioned. Well, I transitioned from being a frontline emergency doctor 30 years ago when I moved into leadership. But for the last 10 years, I have transitioned into building capacity for public health leaders. And that work has taken me to many places in Africa and many programs, the most prominent one being the Kofi Annan Global Health Leadership Program, where for the last 5 years, I lead a team that in turn selects some of the best public health leaders in Africa and takes them to the next level. And I'll say more about that later. But people often ask me, so what makes a good leader, generically? What makes a good leader? Whether you're a surgeon, or whether you are in IT, or whether you're in politics. What makes a good leader? And my answer is that leadership is both very simple, but also very complex. And that's because primarily leadership is about a vision. Leaders must have a vision. If you don't have a vision, where are you leading people to? Professor Chalwazi had a vision to conquer cancer, solid tumors in particular, a vision to establish the Uganda Cancer Institute, a vision to establish Uganda Matters University, among others. So you need a vision. But you can only accomplish a vision through people, to bringing together people and inspiring them. And that's the hard part. Leading people is the most complicated part of leadership, although it can be the simplest. And then, of course, leadership is about results. If you are leading and you're not getting results, then why are you leading? So, vision, people, results. But I have a few anecdotes, and I will read them and then show you the slide so that you can focus on each statement. First is that leadership is most visible when it is absent. I'll say that again. Leadership is most visible when it is absent. When you have good leadership, you take it for granted. Things are happening, things are working. You can even deride the leadership, make jokes about it, but it's there. It's only when the leadership is absent that you feel the gap, you feel the vacuum, and realize how important leadership is. Because leadership is the missing salt that makes all food taste better. I was writing this and then remembering I'm hypertensive, so maybe salt isn't too good for me. But it is the missing salt. Anything good can only be made better by good leadership. And I talked about vision because leadership is not just about your vision. Leadership is about providing a vision that helps others to see better. And leadership challenges the status quo so that a better future can be imagined by all. Leadership is not just about keeping things exactly the same as they've always been. Leadership should challenge and say, things may look good, but how can they be better? And leadership builds teams, it builds disciples, and it inspires so that collectively the team can achieve what no single person can do. You as surgeons, you know that even though you are the top of the food chain in terms of carrying out surgery, you would not be able to do what you do without a whole team, whether that be the anesthetists, the theater nurses, the perfusionists, the intensive care unit, all the way down to those who procure your sutures and drugs and needle forceps and all the other things that are required for surgery. But leadership is also pioneering. It takes risks. It exhibits courage. It's about staying calm. It's about making decisions. And it's also about accepting responsibility. A leader who is too afraid to make decisions is not a leader in my eyes. I think Professor Chalwazi exemplified, and let me repeat them, and benchmark them against yourself. Taking risks, exhibiting courage, but staying calm, making decisions and accepting responsibility. Unfortunately, leadership is also a lonely place, very lonely. And yet, it's an important space. Some of my loneliest times have been when I have had to take difficult leadership decisions. Last month, part of my role in leadership development is I run a program called the Ministerial Executive Leadership Program, which is to support ministers of health build their leadership skills. And in February, I had 35 ministers of health in Addis Ababa who were talking about leadership. And I said, it's ironic that some of the best leadership lessons are given when you're in nursery school, when you are 4 or 5 years old. And of course, the leaders looked at me a bit weirdly, as some of you might be looking at me, wondering, what are those leadership lessons you learn that you are 4 or 5? And unfortunately, most of us forget those lessons, especially when we are appointed leaders, especially. So I will, again, this is a takeaway for you. 4 words, just 4 or 5. How can you forget 4 or 5 words? The first word is to learn again to say please. Please is a very important leadership lesson, because please builds partnerships and it builds your teams. The second is thank you. Because thank you is an appreciation, a recognition, and this builds your team. It inspires your team. And I'm sure now you know what the third is, which is I am sorry. Taking responsibility when you have made a mistake or your team has made a mistake. Because these give you the humility to be a servant leader. And Professor Chalwazi was all of those. My recollection of him was he was not shy to say, please, thank you, and I'm sorry. And that, to me, is really what makes a good leader. And I captured that on that slide, which I will share if you want to go back and read that. But if you are then to ask me, okay, so how do you actually train leaders? Because you see, there is a theory that leaders are born, and then there is another that leaders are made. And the truth is somewhere in between. Yes, some people have more propensity to gravitate towards leadership. But every person, every single person has the ability to become a leader. Everybody. Among my 75 Kofi Annan fellows, I can see those who are extroverts and those who are introverts. Some of the introverts have always said, how can I be a leader if I am an introvert? And there's a whole book written about that called Quiet Leadership. So I will just give you, the Kofi Annan program is a one-year program. So in a 30-minute talk, what can I say? I'm just going to give you Leadership 101. There are 4 things that you need to master and you will become a leader. I didn't say they were easy, but there are 4 things. First, you must learn to lead yourself. Then you must learn how to lead others. Then you must take responsibility to lead institutions. And then you must provide thought leadership. These are the 4. Not very hard. But the devil is in the details. Because to lead yourself, you must understand who you are. You must know what motivates you. You must know what demotivates you. You need to know what others think of you. And you need to know what you need to do to make a better you. Which means that you need to open yourself up to get feedback from others. When we do our leadership training, we do this through psychometric evaluations and 360-degree appraisals that allow you to see sometimes things that you block out about yourself. And to lead yourself, you need introspection. You need to constantly check yourself. And you need humility, because without humility, you will not believe what others are telling you. But I've also put a word there that people get surprised. You need to be able to forgive yourself. Sometimes you find out things about yourself that you don't like and maybe cannot change. And then you have to realize, okay, I need to forgive this part of me because there is many other things that are good within me, and move on as a leader. So you lead yourself. Leading others requires a diverse set of management and leadership skills, most of which can be taught. The hardest one to teach is how to listen and learn. It's amazing how many leaders like the sound of their voice. And when you are in meetings, the meeting is dominated. There is very little time on the agenda to say, okay, I have said my piece. Can I now listen to your feedback? Or the leader has created a toxic environment that no one will ever talk and give them feedback. Again, the Professor Chalwazi that I remember had mastered the skill of being able to listen and learn. And we learn from those who are more experienced, we learn from those who are less experienced, and learning never stops. And then, as Dr. Simon was telling me, he's having to learn how to lead an institution. Lead a department of surgery, a hospital, TASO, IDI. And here you need new skills. You need to understand governance, legal issues, diplomacy, networking, partnerships, finance, HR, a lot of skills. And these you have to learn deliberately. Either that, or you hire people who really know these skills, but be prepared to take their advice. Because you cannot lead an institution without these key skills. And finally, and most important, is thought leadership. As a leader, your primary job description is to drive the vision, mission, and strategy of whatever organization you're in. And for that, you need to give yourself time and space to think. When I was ED at IDI, I used to go to work at 6 in the morning, mainly to escape traffic jams. But also, the time from 6 to 8 a.m., I was usually alone in my office, which allowed me to deal with a lot of stuff. And by the time my staff came in, my desk was completely empty, and sometimes my feet were on another chair thinking. And my staff would come in and say, "ED, hey, today you have no work." I would say, "No, I have plenty of work." He said, "But your desk is empty." And I said, "My job is not to sign paperwork, although it's part of my job. My main job is to think. It's to think about this organization, how to sustain it, how to grow it, and what the future will bring." And sometimes, and I'm sure as surgeons, you don't have the time to think. Your work is so intensely focused that if Dr. Galukande was taking out my appendix, I would not expect him to be thinking about where he's going to raise money for the Association of Surgeons. I want him to focus only on my appendix. But you have to find that time to think. Thinking is such an essential part of being a leader. So, since I was invited here under the auspices that I am part of the Kofi Annan program, let me talk a little about it. It targets senior public health leaders across all of Africa. We are about to graduate the 4th cohort, and the 5th will begin in June. We have 74 Kofi Annan fellows drawn from over 10,000 applicants and 32 African countries. And that to me is a tragedy. We've had 10,000, of whom 5,000 probably need leadership capacity building. The other 5,000 were just trying. But we could only take 74. It's a 12-month fellowship, and it involves formal training, coaching, mentoring, country learning visits, and a leadership challenge project. We've had a couple of surgeons. One is called Professor Ada Agazi, professor of ophthalmology and head of department in Nigeria. Her 12-month journey led her to have a seminal moment to realize that just doing cataract surgery and what do they call the surgery for presbyosmas, something surgery, in one hospital was not going to change the landscape of blindness in Nigeria. And so she has launched a movement to address blindness in Nigeria, because as she pointed out, blindness affects at least 2 people. The blind person, and usually a young child who is given the task to lead that blind person. And it's usually a young girl, which takes that young girl out of school. And her year in Kofi Annan is completely transformed her leadership and the way she's tackling blindness. And you don't need a master's in public health to be a public health leader. What you need is a mindset shift to think beyond the individual patient and think about the population as a whole. And I will talk a little bit more about that. So, was Professor Chalwazi a thought leader? Remember, I said thought leadership is probably the highest level of leadership. And I have a few examples here, and I'm sure others could add about his thought leadership. He pioneered the surgical management of solid tumors when cancer was not yet globally recognized as a significant non-communicable disease. These days you will hear NCDs, NCDs. He also recognized that oncology and cancer management is multidisciplinary, and pioneered the establishment of the Uganda Cancer Institute with others. He also recognized that Makerere University would never be enough, or Makerere Medical School, for a growing population, and pioneered the establishment of Uganda Matters University. But above all, he changed the career course of hundreds of medical students to take up surgery as a career. Because for many of us, people will come and tell you, oh, Dr. Coutinho, you are my mentor. And I say, when did I mentor you? Oh, you mentor me from a distance just by seeing what you do. And Dr. Chalwazi, in that way, was a mentor to very many. And I believe to Moses as well. And you need to know that all of you here are mentors, even when you don't know that you are mentors. Because people are watching you, they see what you do, they are inspired by you. And so for sure, he was a thought leader. So, what thought leadership does surgery in Uganda need today? Because now let me come to the association and its objectives. Perhaps the greatest shift required in thought leadership is to see surgery and surgical conditions as a public health emergency that requires public health leadership skills to resolve. I gave that its own slide because that's a take-home message. And I heard words about advocacy and how the profession needs to advocate about itself. It's not just about advocating about the profession, it's advocating about the key role that the profession and allied professions play. As I was researching for this talk, I came across a figure that I couldn't believe. I had to cross-check it. That annually there are 16 million deaths that could have been prevented that are caused by surgical and obstetric conditions. 16 million. More than for HIV, TB, and malaria. But if you see the attention paid to global surgery or the resources that are available, they're a tiny, tiny fraction. So what are these public health leadership skills? Well, first, you begin with epidemiology and the creation of the evidence to make an evidence-based case. You need economics, health economics, both to determine the impact in QALYs and DALYs, but also to create an investment case for investing in surgery. You need policy development skills because bureaucrats and politicians will be moved by policy, not just by advocacy. Advocacy needs to be translated to policy. You need advocacy skills, of course. You need resource mobilization skills. Now, that does not mean that surgeons must become public health, because we need all of you in theater and other places. But it means that the Association of Surgeons must partner with the Association of Public Health, for instance, if there is such an association. Not just in Uganda, but globally. Because this is where traction will be obtained. And these words, public health emergency, is because 90% of the population of sub-Saharan Africa has little or no access to surgical care. I've talked about 16 million, and if you go back to 2015, there was a Lancet Commission on Global Surgery. And if you read it today, very little has changed. In fact, I would assert that that Lancet 2015 commission should be essential reading for all politicians working in the area of health, all policymakers, all healthcare workers, and of course, all surgeons, because it lays out the case for why there is a surgical crisis. And the 2015 World Health Assembly resolved the inclusion of global surgery within primary health care as a crucial component of universal health coverage. Yet progress in this direction is sorely lacking. Now, this is a slide, but let me tell you a real personal example of what happens when you don't have access to surgical care vis-a-vis when you have access. I have a 38-year-old son who came to visit me from South Africa last year. And when he came, he enjoyed Uganda a lot. But one morning, he had come home at 4 a.m. As I said, he was enjoying Uganda a lot. At 8 a.m., he wakes me and says, "Dad, I'm not feeling so well. I have tummy ache." So I cross over, check him. "What did you eat?" Thought it was a gastro. Then at midday, he says, "The pain is getting worse." So I go check him again and diagnose acute appendicitis. He had classic referral pain, rebound tenderness over McBurney's point, and I call Moses. Luckily, it was a Friday, and it was his clinic day. So not the time frame, it was 12 noon. I call Moses, says, "Yes, bring him in." I brought him in, did an ultrasound, did a white blood cell count. At 2 o'clock, he saw him, diagnosed, confirmed my diagnosis. I like that. He confirmed my diagnosis. And within another couple of hours, that appendix was out. And Moses told me, if we had waited another 2 hours, that appendix was going to rupture because his whole appendix, which was now 6 inches long, was full of pus. And I don't need to tell you the post-operative outcome of a simple, nothing is simple appendectomy, and one with peritonitis. But that's because I lived in Kampala. I had access to a hospital. I had access to a surgeon who was a friend. And the system was set up to rapidly respond. It didn't say, "Okay, we'll do him tomorrow morning." My son could have died easily. So for me, it's really personal. Because if for 90% of our population, they don't have the privilege that I have or that you have, then we need to have better thought leadership of what to do. And there are many things. I put a long list, but I know that I've spoken longer than I should. And you can read these things. How do we increase coverage? How do we invest in training and skilling surgeons? How should our academic institutions change? How do we get our countries to put more money into surgical services? How do we engage the private sector? How do we make sure there's health insurance? Coxeca, for instance, if you read its case study, has really shown how thought leadership can change the training of surgeons. And there can be no universal health coverage if the surgical gap is not closed. So, my closing thoughts. I'm trying to create a legacy too, even as I honor the legacy of Professor Chalwazi. My legacy is to train 1,000 public health leaders by 2030. That's a journey I began 10 years ago. So far, I'm at 647. So God willing, inshallah, I stay alive till I am 71 and able to achieve the 1,000. That's what I would want to be remembered for. Professor Sebastian Chalwazi has a legacy that lives on 33 years later through his life, his work, his dreams, the institutions he founded, and his multi-generational surgical students and practitioners. I leave you, each of you, with this question. What is your leadership legacy goal? Thank you.
Thank you very much, Dr. Alex Coutinho, for those kind remarks. You can now really see the difference between a leader, a trainer of leaders, a mentor of leaders, and me, just an ordinary surgeon. In this Chalwazi Memorial Lecture today, we have really learned a wealth of information, how to be a leader. The world should not just rotate around you, but you need to build teams around you so that you can make your objectives known. We have heard about transformative leadership, and we have heard that to build a legacy, it takes small bits of acts and good luck as well. And a leader needs a vision, people, and results. A leader is visible when leadership is absent. We have all heard about that. This was the first time I conceptualized that. I used to think that when the leader is absent, then there's a vacuum and chaos and anarchy. We all saw Leadership 101, which was clearly exemplified there, the 4 tenets of Leadership 101, and the issue of finding time to think. Most of the time, we get time to do things, but we have seen why it's important to find time to think. And the late Professor Chalwazi was a thought leader and mentor as well, thinking about making the Cancer Institute, putting the Cancer Institute in place, Uganda Matters University, and the training of surgeons. And we also the Kofi Annan Leadership Institute. I don't know how many are going to enroll this year or next year in this house. Thank you very much. I invite the President of the Association of Surgeons. We have a small leadership package for Dr. Alex Coutinho. Sir, you're a very great mentor of future leaders. Thank you very much. You're welcome, sir.
It's good manners just to thank you.
I will treasure this. Does this make me an honorary surgeon?
Welcome, sir. Thank you very much. Come to Soroti again. Yes, thank you for me. I will.
Or photo.
The photo.
You want down?
Yes, I think so. Thank you very much for that wonderful ceremony. I know we have the family around. We'll shortly get time to introduce you. According to the program, we have a presentation by the Executive Director of Nakasero Hospital, Dr. Luzige Simon. Sir, you're welcome. We all know that in Nakasero Hospital, just by hearing the name, Nakasero is Nakasero. It's not a Soroti, it's not a Bulambuli in Uganda. It's one of the first state-of-the-art hospitals in this country. And Dr. Luzige, you are too smart, sir. And you will always give the state-of-the-art speech. You're welcome.
Thank you. Thank you so much. Thank you. Good morning, colleagues, and ladies and gentlemen. You're most welcome. Thank you so much for this opportunity. It's really a big honor to step just from Dr. Coutinho's space here. I can feel the vibes. I'm very privileged to be here, and I'm also very privileged to be given this opportunity on this very important occasion. So I'm Dr. Simon Luzige. I'm an internal medicine physician, specific interest in pulmonology. And until Dr. Coutinho spoke here, I was doubting whether I made the right move to try and shift from being a purely clinical doctor into leadership and management. So I think I'm on the right track. So thank you for giving me feel happy about myself, because somebody might have said, what are you doing in leadership? But I'm really very happy and honored for those thoughts. So before I start, I also like to share my experience and myself. This position I'm holding today as the Chief Executive Officer or the Chief Enabling Officer of Nakasero Hospital, taking into the leadership role. I just help people to do their job as a leader. So I prefer calling myself as the Chief Enabling Officer rather than the Chief Executive Officer. So this journey started way back. If I look and reflect, I was privileged to work around very great men as a student, as an intern, and later on as a medical officer and head of the health sub-district of Maokota South in Impigi. And then later on, Mulago Hospital as the deputy clinical director in the Division of Medicine. And then, of course, later on where I am now. But in this journey, I had a very personal friend, may he so rest in peace, Professor Ignatius Kakande. Is the person who gave me my first job in Nkozi Hospital. I was his intern in Zambia. He booked me 8 months before I completed my internship, and he told me I have a job if I continue being a good doctor. After the last day of my shift in Zambia Hospital, I was sent an ambulance to take me to Nkozi Hospital. So I don't remember having no job. My job was pre-planned. Professor Kakande, the late, took me in his car to the office of the Cardinal in Rubaga and gave me a letter signed by the Cardinal. My first appointment letter was signed by the Cardinal. I remember that morning. And of course, after my journey to Nkozi, the rest is history. But while at Nkozi, I gained interest in leadership. Because as a medical officer, I was also charged with the duty to be the head of the health sub-district. We were very privileged, again, because of our work ethics. At that time, the DG, Professor Maswa, and others chose our health sub-district as one of the model health sub-districts, again, because of what we have been doing. So it was one of the private, not-for-profit hospital that was given the opportunity to head a health sub-district. And so we worked around very great men, Professor Maswa, the likes of Dr. Chionga, the likes of the Zarambas, Chavagus. Those all mentored me because we used to have frequent visits in the field. They used to visit us. I had occasion to attend so many meetings here with the Ministry of Health. So for me, that gave me a lot of appetite. In fact, Professor was so shocked when he heard that I'd gone to do internal medicine after, but I calmed him down. I said, no, I'll continue doing my work. And I remained in medical practice, did internal medicine, and even with internal medicine, I kept my side of wanting and participating to lead. So I deliberately intended and always made it an intention to step out and try to see if I can, and that's why I have that slide. It's a very important statement. I always tell myself what made me always step out, but it's something which I would like to encourage all of us. And that's one of the most difficult steps. People talking about how do I move out to try and help or offer myself for service. And so the intention to accept responsibility that Dr. Coutinho was speaking about, this is a step you have to make out among the many people in the team. You have to always be prepared and also have to train our colleagues to always step out and provide themselves. So I'm really honored to be here in that capacity as the CEO. And so next. Okay, so I can do it myself. Good. So I'm also here in the capacity as the CEO. So let me talk briefly about Nakasero Hospital. Nakasero Hospital is one of the private institutions in this country. We are honored to be associated, as you said, with a very interesting attribute. We here to support the means of health. Nakasero Hospital currently is a 107-bed capacity hospital. And for you surgeons, we have 4 theaters, 2 currently working and 2 coming up in the new wing that you see there, the western wing. And then the old facility, the eastern wing, currently has 2 theaters, and I think by the end of April, the other 2 theaters in the western wing will be operational. 2 modular theaters there, new theaters. We have, imagine we have a staff complement of 780 full-time staff. 780 full-time staff. If we add on the others, we come to about 840. And on top of that, we have 150 plus visiting specialists and consultants. So I'm talking about a staff complement of about 900 staff. Now, managing such an institution is not easy, but it takes courage, takes commitment, and I'm very privileged to lead that team. With me is my chief surgeon. I normally prefer calling him the chief cutter, Dr. Kumu Gabriel, and I would like to declare that I intentionally work with him because in my succession planning is one of them that I would like to see hopefully can replace me or come and help me. So I don't want to be a lifelong CEO, so I'm being very deliberate. I have 3, and Dr. Kum is leading the pack in terms of potential. So Dr. Kum, don't let me down because in you I trust, as in Wenger, the Arsenal fans trusted. So, so that's Nakasero. So just about our healthcare space in Uganda, in my opinion, and the way we look at it from Nakasero, the key insights we see that drives and gives us a lot of thoughts or things to think about is the high disease burden we all know, constrained funding, both from the public, but also patients who come and visit us who have to get out of, pay out of pocket, and then the insurance companies who are very price sensitive, very fragile infrastructure, very fragile infrastructure. You can just look at both from the facilities, the systems, the referral systems, prevalent shortages in human capital, very prevalent. And this is one thing that I've seen every time we mention it in our public-private partnership meetings, brings a lot of bad blood between us, the private and government. Government is willing to share so many things, but it is not willing to share these people issues. So, and yet, the 150 plus I was talking about, most of them, if not all, are employees of public institutions in one way or another. So how do we share that? This is one thing that, again, shows you the prevalent shortages of human capital in our system. And of course, the culture and the health beliefs of our population is also impacting and influences a lot the way we operate. And the fact that there's a lot of medical tourism, it also speaks a lot. People are moving out of our country to go and get healthcare in Kenya, Turkey, India. What does that speak about us? Is it an issue of confidence? Is it the issue of they have better services? You know, you live here and then you go to Nairobi Hospital and then you meet Professor Lule. So what's the issue? That shows you that Ugandans have the capacity. Most of the colleagues that are being sought after in Nairobi, Aga Khan, are Ugandans. So what's the issue? The key opportunities from our perspective that gives us the drive, when you look at the funding issue, for us in private, there's a very big opportunity. There's massive private investments. Increased interest in private equity and venture capital investments in healthcare space. Right now, Nakasero Hospital is the majority shareholder of a company called HHI, which owns about 64% of the shareholding. And then the other 36 is the local investors, predominantly our colleagues, the doctors, who founded the hospital. I'm sure similar space you see in CCare, IHK, Professor Moses Garukande knows that. So there is a massive interest, TMR hospital, massive interest in private equity and venture capital investment. So of course that gives us some opportunity to improve our facilities and get money other than looking at our patients primarily as a source of revenue to save and then build a better infrastructure. There is potential to leverage on IT, and specifically of interest is the artificial intelligence in the delivery of healthcare and medical training. So this is something that we are trying to work around. For example, e-learning platforms using artificial intelligence to train. And then, of course, benchmark and collaboration has been the key issue in our space. Why leadership matters for us is the fact, I'm sure Dr. Coutinho has already mentioned about this, leadership is the capacity to translate vision into reality. And this becomes very important because as a leader, you have to know, you have to go the way, you have to be ready to walk through the way, and you have to be ready to show. And this is where issue of mentorship and training comes. I won't repeat that because that has already been emphasized by the presentation of the keynote speaker. For me, in this particular day, the late Professor Chalwazi reminds me of one very important person in our internal medicine field, and that is Sir William Osler. Those pictures show you similar characters. These are people who were so passionate about medical training and capacity building. And to me, every time I hear about the late Professor Chalwazi, we joined medical school 1 year after his passing on. And the whole corridor, the 5 years we're in medical school, every time you're in the surgery department, that was the issue. Professor Chalwazi, what would he say? What would they have done? And that inspired us a lot. And we look at, for us, internal medicine, Sir William Osler, similar pictures, similar inspirations for us in the field. So, as Nakasero, a lot of lessons learned in terms of capacity building. We are deliberate about capacity building for leadership. I came in, my job, I was there as the head of medical services, grew through the ranks to become the CEO. And I have promised myself the next CEO should also come from within. And that's why I have a succession plan. And performance management is based on the balanced scorecard. And this discussion around personal development is a key performance indicator for all of us in the institution. Personal development is a must. It's like the way surgeons said the examination of the abdomen is not complete until you do a PR, isn't it? Is that adage still holds? Appraisal of a staff is not complete until you have a conversation around personal development. as a method of training people in this issue of leadership. And leadership is a key aspect of personal development, intentional as an institution. So management positions, we again encourage internal promotions. And for us to be able to do that, we need to have done some work to prepare people for these positions. And succession planning is a mandatory for all management positions. So I have people in my succession plan. Dr. Kuma, as the head of surgery, has people in this. So this is part of the issue we're trying to do. And of course, it's a big issue, requires a lot of commitment from the board and the shareholders, and of course, management. The biggest challenge, as Dr. Coutinho said, is the issue of people. Some people are not willing to take the responsibility. The mindset issue is a big one. So we are trying to lead through by example, and hopefully people will take away the fear and step out of the crowd to be able to take up the challenge that comes with leadership. And so we do a lot of succession planning as part of an important issue. So, for example, right now, out of the 46 key management positions in the hospital, 35 have clearly delineated succession plans. So if I decide to leave today, or if the board decides to fire me today, I do not expect to find a gap. If it happened, then I would have failed in my position, because I've been in that position for now 5 years, surely. I should be able to be comfortable and say that somebody will be willing to take up that. And so that is a very big issue. And leadership training is a must. So we expect 48 hours of training per annum for all management positions, people who hold management, both middle level and senior management. And that's a key performance indicator for us. So current initiatives, as I've said, are those ones. But for just to summarize and to conclude, I believe from our experience at Nakasero, as an individuals, we request, and I'm going to request here that we need to step out and step forward. Remember the first slide, we need to step forward. And as Dr. Coutinho said, people are watching us. So if we step forward, the likelihood that people whom we are leading will also be gaining traction to step forward is going to increase. Let's show intention, okay? And let's be mentors and coaches of our colleagues. And of course, network and participate in fireside chats whenever you have an opportunity. And that's what motivated me to come and have this talk. The other thing is, as an institution, inculcate leadership training in personal development. And we can share that, how we've done it, and benchmark and collaborate to learn insights and lessons and challenges from other colleagues and institutions. As a nation, I think I like the minister's remarks yesterday. I think we need to align policies to meet the changing landscape. As a profession now, and as a society, as an association, I think advocacy should be embedded in training, leadership training. I like yesterday Professor Chamanya clearly said how we need to inculcate leadership training in our training institutions and medical students. Some of us used to observe our teachers. We used to observe our heads of department. There was no deliberate training unless somebody like me was willing to come out. So I hope this can be inculcated in our training. Thank you so much for this. Thank you, sir.
Thank you.
Thank you. Welcome, sir.
Thank you very much, Dr. Luzige, for those insights. One thing I've learned today is that much as I have a better body mass index than him, he has a higher brain mass index than me. So all of them are BMI. But I think Professor Galukande can now go into the nitty-gritty of that. Without much ado, in the next program, I'm not in position to invite the family now, unless I call the president of the association himself to do that. Professor Galukande, kindly come over to invite the Chalwazi family. They're already in the house. You're welcome.
Thank you again, Dr. Luzige, for that wonderful talk. The family of the late Professor Chalwazi, So it's an honor to have you. Thank you for coming, being with us. At least we expect to see at least once a year. Please come up and introduce yourself and say something to us. Yes.
Sorry, I have a sore throat this morning, but my name is Edward Charazi. I'm the eldest member of the family. Most of you don't know me, but I know some of the doctors, at least by appearance here. I spent most of my time, I did my studies in Italy, Milan, northern Italy, where I spent more than 25 years. I speak fluent Italian. I speak fluent French, and I speak also Polish language, because I had the opportunity to go to Poland, and I did a course of 3 months in something. So I can say French, Italian, and Polish, and of course Uganda. And I don't want to add much to what Dr. Alex Coutinho said. I think all in all, that is how the Professor Sebastian was. But let me add something also. The late professor led an exemplary ethical life, and somehow he managed to balance his role as a surgeon with the responsibility to serve his country. I remember him for at least there are certain factors that were deeply, let me say, embedded in his DNA. 1, time factor. 2, honesty. 3, the truth. He used to tell us all the time, the truth. You know, he was a very religious man. So he said, the truth shall always set you what? Free. And I think we grew up along those lines. Thank you very much.
Okay, to add on that, on behalf of the family, we thank the organizers 33 years later for organizing this memory and honoring our father, our grandfather. Thank you so much. Oh, my name is Fiona Bishanga, a granddaughter.
Hello, how are you? My name is Peace Nabunya. I am the granddaughter of Professor Sebastian Chalwazi. I am very honored to be here to celebrate his life, his work, and all his achievements. And I did not meet the man, but every ounce of my life, I have been told of how great he has been, and even had people speak to me about who he was. And that is truly inspirational, and I hope I'm even half the man that he was. Thank you so much.
Thank you very much, the family, for those kind remarks.
And what the family did not say is that Professor Chalwazi has a grandchild who is a medical doctor in the United States who is now doing her residency. 3 who are in the medical field. So he is contributing to health around the world.
we shall quickly take, together with the president, a picture with the family. Thank you.
We're doing a picture?
You look like how I remember your dad. Really? Absolutely, when you walked. The one in Canada.
Four languages.
Five languages. English.
English also.
Thank you very much. We had one item left which we have deliberately skipped. We'll get back to it later. The surgeons normally have term limits. My term is expired and I don't want to be here again. Thank you very much. Enjoy.
Thank you once again. So we've finished the Professor Charazi Memorial Lecture. Next on our agenda was to give an obituary for the late Professor Ignatius Kakande by Professor Francis Omaswa. He sent his apologies. He might be coming today, but might come later. So he will give that. But if we all may, we can turn to our abstract books towards the end. Somewhere here, we can refer to that, and his eulogy is there, and all the great achievements. And as the Association of Surgeons of Uganda, we truly, truly mourn a legend. So I would like us to still observe a moment of silence for him. Then we will have the lecture when Professor Maswa comes. Thank you. At this juncture, without wasting any more time, kindly allow me to invite the chairs for the next session. That is Professor Fred Kitia. Professor Kitia is a recently retired neurosurgeon, but he's not a tired man. He's still serving, just as you know, our healthcare system. He's served as the head of neurosurgery department, Barara University. They've done amazing things. They're doing amazing things. We are yet to hear his achievements. They've done pituitary tumors. If you all didn't hear about that, it's something groundbreaking in Uganda. So we celebrate that achievement and so many things. And Dr. Setabi Eden Michael, who's the finance secretary for the Association of Surgeons of Uganda, as well as a fellow at the Uganda Heart Institute. You're most welcome.
Good morning, Aso. Professor has decided that I take the lead. I think following Dr. Cotino's lecture, the young ones are taking over, and that is part of transferring of power. So I thank you very much, Professor. I've had the privilege of working with Professor Kitia in Barra for over 3 years, and he's an amazing gentleman. But today, it's all about the presentations we're having, and I'll present our first speaker is going to be Dr. Chamulabi Margaret. She holds an MBCHB and an MCS of COSEXA. She also has a master's in public health, and currently on the great journey of becoming a neurosurgeon, doing her M.Med in neurosurgery in Makerere University. The other presenter we're going to have is Dr. Sembatia. I've privileged to also work with Dr. Sembatia. Dr. Margaret, you can come up. I worked with Dr. Margaret in Makerere when she was doing her MCS. So when I crossed over to Mbara, I was also lucky to work with Dr. Sembatia, who is a COSEXA neurosurgery resident at Mbara Regional Referral Hospital. And he is currently their chief resident. He's also a scholar in machine learning and deep learning in medical imaging and AI in glioma diagnosis. This is at Spark Academy. He's the education director, Mission Brain African Region, and an executive advisor, Mission Brain Trust of MAST of Mbara. And is currently now a member of the Neurosurgical Society of Uganda and the candidate member of the International Society of Pediatric Neurosurgery. Dr. Sembatia, you're welcome to take your seat. And finally today, we shall also have, I would call her my colleague, friend, and classmate, Dr. Namuga Martha, who is, she's a urologist and a global health advocate at Mulago National Referral Hospital. And she works as part of the transplant team, headed by Professor Frank Asimwe. And she's also a fellow of the Global Surgical Equity Program with Center for Global Health, what we know as CHESA. at the University of California, San Francisco. Dr. Namuga, Martha, you're welcome. Now, the other two speakers we had for this session, because of the network issues, we have failed to get them online. So we shall have the three speakers available present today. So Dr. Chamlabi, the floor is yours. Thank you.
Good morning, everyone. Thank you very much, Dr. Setavi, for the very humble introduction. So I'm privileged to be here. Yeah. I thank you for choosing my dissertation to be part of this ASAL. So I'm presenting work from my actual dissertation. So the topic for this dissertation was exploring the predictive role of neurofilament light chain protein in neurological, mental health outcomes following non-severe trauma among adults. The study was a prospective study, and we did it over a 3 months period, and it was at Mulago National Referral. So the outline will be, I'll define some specific terms, and I'll give a small introduction, and then give you the research questions, the problem statement, and then the study procedure, results, and the conclusion. So, oh, sorry, I'd forgotten. Yes. Before I go ahead, I need to really thank my supervisors. Professor Galkande, I really, really thank you for being my lead supervisor and for helping me through this entire process. It's been a long journey, about 2 years, and he's been very instrumental and very helpful. Then also my other research supervisors, I'm truly grateful. Then it's also a funded study, and it's one funding program from the Brain Health. So what's neurofilament light chain protein? So it's a protein, it's just an intermediate protein that is produced from axons. So axons, if you remember our neurons, axons are just that structure, if you remember. So when you have damage to that axon, that is from the cortex to the anywhere along the spinal cord, if you have damage, you release what they call neurofilament light chain proteins. So those proteins are responsible for the diameter and the structural integrity of the neuron. The quantity of release of this protein tells us about how much damage you underwent. They tell us about the significant quantity of damage that you have. So this can be detected in blood and at the same time in CSF. So we chose to test it in blood. So this neurofilament light chain protein has been tried out in other health, neurological and mental health illnesses like Alzheimer's and many of Alzheimer's, multiple sclerosis, so we are trying to borrow it to come to trauma. So over the couple of days, we have been learning about trauma and TBI, and by now we know the significance and what trauma has done to our society, the morbidity, the mortality that it has caused. But what in trauma really happens is you get damage to your axons. So the extent of damage to your axons, those axons we saw in the previous slides, that's what determines what will happen. The adverse effects will be from that damage from those axons. And that will give us the acute, what we see, and then also will be responsible for your chronic condition on the neurological sequelae that will go ahead. So biomarkers are actually variable insights into diagnosis and disease monitoring. So elevated levels of neurofilament chain protein have been shown to be of prognostic potential and role for up to a year. So in Uganda, this has not been explored. So we set out to do this exploration and see how it relates in our center. So our research questions were what's the association between serum NFL levels and the GCS score? And then secondly, we wanted to know how does this NFL relate to neurological and mental health outcomes. So, and our study hypothesis was mainly based on the fact that we think that the more your axons are damaged, the more neurofilament chain is produced, and hence, the more damage that we can assess. So, our null hypothesis, there is probably no association, but the alternate is there's probably an association. And specific objectives, we wanted to see how the serum NFL levels will relate to the patient's GCS score among the mild and moderate, and then also wanted to see the relation between serum NFL levels and neurological outcomes and also the mental health outcomes. So the problem as to why we tried to use this biomarker was that there are no predictive models that allow prognostication. So this jeopardizes outcome. And such family discussion are based on insufficient information. So we felt like it was imperative that we prioritize the use of these biomarkers to see engage them in clinical practice to enhance patient outcome. So we set out to do a study, and we worked on 100, according to our sample size calculation, we had 176 participants who we enrolled, and we had a checklist, we had a short abstraction, we did blood sample collection, then followed them up from discharge, and also at 3 months post-trauma. We wanted to assess the functional outcome and also a check on the depression score and then post-traumatic stress disorder. In our study, we also noted that we lost to follow-up 42 participants. 9 died, even with mild, moderate trauma, and then 1 just declined to fill the post-traumatic stress disorder checklist. Talking about the results, a majority of our patients were between the ages of 18 to 38. They were majorly male, and they were casual laborers. Their accident occurred between 7 p.m. and 8 a.m. majority. That was 76%. Most of them were using mood enhancers. Alcohol was the most mentioned, and they denied being high at the time of the accident. Majority of the patients reported hospital after 10 hours of trauma, and the accident cause was majorly a motorcycle. When we looked at the charts for the neurological outcome, we found out that they were majorly neurologically stable, most of the patients, but some had motor neurological deficits and some sensory deficits. At the time of the study, we noted that majority of the patients had not had a CT scan, but of those who had received a CT scan, majority, the CT scan findings were abnormal, and the pathology on the CT was a contusion. Majority of the patients were taken to the general ward for normal care, and those who had surgery, the major surgical intervention was a craniotomy. So this is NFL results in brief, and we had a range of 131, and we took the high NFL to be over 19.4 nanograms per milliliter. So looking at the association between NFL and GCS as per our first objective, we noted that when we compared to the normal NFL levels, those with high NFL were 10 and 20 times higher, 10 to 20 times more likely to have moderate TBI. I can't point, but I think you can see. But these findings were not statistically significant. Then when we made NFL as an outcome of interest through all the variables, we noted that NFL was not significant with all the variables. That made us think that actually NFL, these two groups that we are looking at, were probably similar, because we are doing the mild and moderate. So when we made GCS as an outcome of interest, that's moderate and mild GCS, we found out that actually there were very significant variables. That showed us that probably what we're seeing with the NFL were a true picture. It was a real true picture, that is post-resuscitation. The other was a pre-resuscitation. So with the help of Professor's discussions, he managed to help me pull out this table. And this became a very significant table for the study. So we noted that among the 9 patients who died, we found that actually they had high NFL levels. All of them had significantly high NFL levels, no matter their GCS score. So a case in point, if you can look at NFL 164, the NFL level was 70, yet the GCS was 14. So that kept thinking, so we are still wondering why. So this is a question for another day. So moving on to second objective, we noted that also our patients had 28% unfavorable outcome, and still this did not come out to be significant when we assessed it with NFL. Then for post-traumatic stress disorder, the prevalence was 13%, and still with NFL, this was not significant. So going back, that probably these patients were the same. Then we also looked at depression as one of the mental health outcomes and found the prevalence of depression among these patients was 33%, but when we did the analysis, still it was not significant. So, yeah, so our study failed to reject the null hypothesis and accepted the fact that there's actually no association between NFL levels and GCS score, and there's no association between NFL and neurological and mental health outcomes. Thank you very much. Those are references.
Thank you very much, Dr. Chamlabi. So we are coming from the National Referral Hospital, and now we shall go to the Regional Referral Hospital. Then we shall go back to the National Referral Hospital. We shall have Dr. Sembatia presenting neurosurgical services at Mbara Regional Referral Hospital, Uganda, the burden, the spectrum, and the outcomes. Dr. Sembatia.
Protocol observed. Thank you so much for this opportunity. I'm Dr. Sembatia Joseph Mary. I'm privileged to present the results of one of the topics that we're working on, that is
neurosurgical services at Imbarara Regional Referral Hospital in southwestern Uganda. Specifically, we are looking at the burden, the spectrum, and the outcome. And the corresponding author is Professor David Kitia. Thank you. So in the introduction, it is good to note that there is an overwhelming burden of neurosurgical services worldwide. However, Africa faces a significant gap in accessing these services. And it is noted that about 1% of the global surgical workforce is available in Africa, despite the fact that more than 15% of the unmet neurosurgical needs are in Africa. Similarly, Uganda is experiencing an increasing demand of neurosurgical care. However, regional referral hospitals in this very country have not equitably participated in delivering these services. It is good to note that anecdotally, there is uncertainty within the community about whether neurosurgical services can be, one, safely and effectively carried out in regional referral hospitals. That's when Imbarara Regional Referral now comes in. It has pioneered this since the year 2012 by providing neurosurgical services to southwestern Uganda and in nearby countries. Thus, the study aimed at documenting, one, the volume, the variety, and outcome of these services in southwestern Uganda. The objectives were mainly three. One, to assess the burden within a period of 5 years, that's 2019 to 2023, the spectrum and the discharge outcomes of these patients. It was a retrospective case series analysis at Imbarara Regional Referral Hospital, specifically at the Division of Neurosurgery, and the period of the study was from January 2019 to 2023 December. Admission patterns, types of procedures, discharge outcomes, and outpatient attendance were extracted from our prospectively maintained database at the division. Analysis was done with Python, and data visualization done with frequency tables, pie and bar charts, and appropriate regression models were used in this study. The results of this study within the period of 5 years were overall, we had a total of 5,090 cases. And on average, about 1,000 cases were being seen every year for this period. And about 31.8% of all the admissions were operated cases. It is also good to note that among the operated cases, traumatic brain injury contributed the biggest percentage, over 80% of the admissions, and operated cases were traumatic brain injury cases. This graph shows the age comparisons among the cases that we see, and we are seeing that there is an increasing number of cases over the years. Specifically, we see more of the adults. Why? Because most of our patients are really traumatic brain injury patients, and most of them are adults. This also explains most of the traumatic patients are mainly road traffic accident, border borders, and the likes. The other graph on the right of the screen shows gender proportions, whereby most of the patients were male throughout the study period, over 80%. And this is because most of the trauma patients that we receive are mainly adults. This other graph shows still the burden of the cases, whereby we are seeing an increasing number. Though in 2022, we are seeing a drastic drop in our outpatients visits. This was the time of COVID when people were restricted from moving, and this explains the drop. But despite that, still about 700 patients were seen that very year, and the number kept on increasing. Looking at the trend of the pathology over a period of 5 years from 2019 to 2023, we are seeing that the trend was statistically significant, though we haven't gotten the exact pathology that contributed to this significance. But it is clearly seen in the graph that most of the patients that we see are patients with traumatic brain injury, represented by the blue line, which is increasing over time. Among other cases that we see, like chronic subdural, intracranial tumors, spine cases, pediatric cases, among others. This other graph shows the burden and the rising number of surgical cases that we do at Mbarara Regional Referral Hospital. And we are seeing an increasing number from 2019. This can be explained by the fact that we have a training program, COSEXA, and also we have MMed students that really participate in operating these cases. And it is also good to note that we have other infrastructure. We have ICU, which caters, which is a key role in our discipline. We have the radiology department, whereby we are able to diagnose these pathologies and we are able to intervene because of our dedicated theater that we have at the facility. So all this explains why we're having an increasing surgical volume over the years. It is also good to note that we have sister disciplines that we work with, like ENT, which is fully functional, the internal medicine, which is fully functional. We work together to see that we provide these services to these people. This other graph shows just the comparison between adults and pediatric cases that we see over the time. And it is noted that we see more of the adult cases. As alluded to, these are mainly traumatic brain injury patients, and most of them are adult patients. And mainly, these are border men that we commonly see in our facility. This other graph shows among the common traumatic cases that we operate on, we do, as we see from 2019 to 2023, we see we do more of the bar holes, secondary to chronic subdural hematomas. We do the craniotomy, and the leading cause of this, as far as trauma is concerned, were mainly extradural hematomas. And also we do a lot of decompressive craniectomy. And we have seen lives changing because of this. And the fact that we have ICU, which is well stocked, there are 8 beds, we are able at least to cater for these patients post-op. And this is being explained in this very graph by the increasing number of the cases. This other graph shows the common pediatric cases that we do. Among others, for the period of 5 years, we have been doing more of the myelomeningocele closures and also hydrocephalus treatment. But as you can see from 2020 onwards, the graph of ETV vis-a-vis VP shunt is higher signifying that we are doing more now endoscopic treatment of hydrocephalus rather than the traditional VP shunt. Thanks be to the Minister of Health and our collaborators that have enabled us to have these endoscopes at our facility, and we are able to do this. The second last slide shows the proportion of the discharge outcomes of all these patients that we see over this period of years. And it is classically seen that almost more than 80% of the patients we admit and we operate on are discharged alive. We take this honor because of the infrastructure we have, the ICU, theater. We are able to intervene in time because of the radiology departments we have and the dedicated theater. However, it's also good to note that we have a smaller percentage of mortality, which is about 12.7%, and the biggest contributor to this, as said previously, is trauma, specifically TBI. So, in conclusion, the data I have presented here shows an overwhelming burden and the diversity of neurosurgical cases that we are able to handle at Regional Referral Hospital. That is in Mbarara. And specifically, it is mainly the TBI cases that are more in the picture, though other cases are being worked on, like traumas, like intracranial tumors, pediatric cases, spine cases. We are able to do all this. And it is good to note that majority of our patients are discharged alive, over 80%, because of the infrastructure and the human resource that we have. The mortality rate is about 12.7%, which is compared to our neighboring institutions like Eldoret, Muhimbili. If you look in literature, it's almost around the same picture, 10 to 13%. So we think with what we have, we are able to provide neurosurgical services effectively and safely at regional referral hospitals. What are our recommendations? Our recommendations are this information can be used by the community to know that these services can be safely provided at regional referral hospitals. And also this information can be used by the policymakers really to make sure that all regional referral hospitals, apart from Mbarara, can be able to provide these services. Thank you so much.
Thank you very much, Dr. Sembatia. I know when we are speaking neurosurgery, the neuros are firing. So we don't want to exceed 10 minutes per session. So we are going to go back from the regional referral hospital to the national referral hospital. And the next topic is at the heart of my supervisor and my teacher, Dr. Jackie Mabwijano, designing the first trauma surgery fellowship for East Central Africa, a cross-sectional survey of Uganda faculty and residents by Dr. Namugamatha. Thank you.
Good morning. Thanks for having me today. I'm going to tell you about designing the first trauma surgery fellowship for East Central Africa, a cross-sectional survey of Ugandan faculty and residents. So we have no potential conflicts of interest. So 8% of all deaths worldwide are due to trauma, and 38% of them, in fact, can be averted by proper care following trauma. So 3 of the 5 top causes of death among young people are all trauma-related. The highest is road traffic injury, homicide, and suicide. And remember, from the 2021 census, the Ugandan population, 59% of it is between the ages of 5 and 29. So Uganda has a pretty young population. So previous studies have shown that inpatient trauma training saves a lot of lives. So in Uganda for over 20 years, with the help of leaders in trauma and in surgery, we've been offering this Kampala Advanced Trauma Care course. And we've expanded in the recent past to upcountry hospitals. I think some of us have benefited. However, in Uganda itself, we don't have any trained trauma surgeons. In the 14 to 21 countries of the College of Surgeons for East Central and Southern Africa, there is no single trauma or acute surgical critical care fellowship being offered. So that means that most trauma patients are actually looked after by general surgeons or specialists who basically are interested in their anatomical area. So neurosurgeons will look after the head, abdominal, general surgeons will be interested in the abdomen, orthos, the leg, etc., etc. So because we know that forming any fellowship or any educational intervention without input from the stakeholders can be an uphill task. First of all, are you forming an intervention that people want? Is it necessary? Is it something that people would support? So with that background, we aim to assess the surgical residents and faculty perspectives on a potential trauma fellowship program in Uganda. So with pilot testing and cognitive interviews, we formed 2 cross-sectional surveys, one offered to surgeons who are part of a SOU, and one offered to residents at Mulago National Referral Hospitals. So the survey had several multiple choice questions and 1 free text response questions. And the respondent characteristics came from 13 subspecialty disciplines that take care of trauma patients, as seen below. And residents were from 3 years of training. So most of faculty and residents were dissatisfied with the state of trauma care in Uganda today, and most of them perceived the reasons for poor outcome in trauma as being insufficient or inadequate material resources to take care of trauma patients, delayed or late presentation to hospital, and insufficient or inadequate human resource. So when asked if there is a role of a trauma surgeon, there was an overwhelming support or agreement that there is a role of a surgeon who specializes in management of injured patients in Uganda. So if this is the case, why then are there no trauma surgeons in Uganda? So perceived reasons for lack of trauma surgeons in Uganda were lack of proper trauma systems and lack of a training program within Uganda. So when asked about the barriers and motivating factors, most of the faculty cited trauma infrastructure and poor employment prospects after training as one of the barriers to a lot of fellowship trainings. While the motivating factors were that there's a high burden of trauma patients, so you would not lack clients to work on. And also there's already established pathways in other specialties like urology, ped surgery. So in case we ventured in this, it should be able to pull it off. So faculty and residents also made some recommendations in their different subspecialties. They told us what they expect a trauma surgeon, surgical critical care specialist to be able to do, as seen in that table. And we are going to use this and consider them and incorporate them in our curricular development. So results from curricular recommendations, Surgeons and surgeons who would be faculty and residents feel that our typical curriculum for a trauma surgeon should include trauma surgery, surgical critical care, as well as emergency general surgery. And most of them suggested that the ideal fellowship setting of training would be hybrid of both local and international settings. So trauma represents a staggering unmet surgical need in Uganda. You have seen from this conference and from the information you knew before, and faculty and residents view a locally run trauma fellowship program as critical in addressing the burden of trauma. And faculty and residents also went ahead to provide some actionable recommendations for curriculum development. So it's a team effort. So I'd like to acknowledge all these people who contributed. And some of these are the responses in the free text question. Uganda is overwhelmed with trauma, with an urgent need for better emergency systems. A development of a trauma curriculum is long overdue because the need is enormous. Patient survival would increase exponentially. This would be the best thing as far as trauma care in Uganda is concerned. Subspecialists currently taking care of trauma patients are not really interested in the trauma patient as a whole unless it involves an anatomical area of their interest. Thank you.
Thank you very much, Dr. Namuga. Now I welcome questions from the audience. I think we shall take a question or two for each of our panelists. And then after they answer the questions, we shall have closing remarks from Professor Kitia as the neurosurgeon on this panel. Thank you. Any questions? Yes, Professor Galkande. You have a microphone, go ahead. Please, yes.
Thank you all for your presentations. I'll maybe focus on the Mbara one. I'm wondering, when you do all that neurotrauma work, how much of that work occupies your emergency theater? How much of that work occupies your elective list? In other words, how much are you not able to do because of neurotrauma? That's the time aspect. Maybe if you do this again, you could tell us about the economic aspect. We want to make the case in terms of the language people understand. How much resources is it taking out? The time resource, the money resource. Vis-a-vis the fact that Matthew said that 38% is avertible.
Thank you, Professor Galkande.
Maybe just one last one for Maggie. It's in the conclusion, I didn't see those 9. The 9 patients who died and they had a significant NFL. And what sense you make out of it?
All right, thank you. Madam President behind. Yes.
Thank you for the presentation. My question is directed to Dr. Martha. You looked at postgraduates, your distribution were year 2, year 3, and year 1. I was just curious that the postgraduate year 2 were very few, considering these are the ones who are usually in the accident and emergency unit. And in the year 1s, what the perspectives were giving you from where they had practiced, or was it some experience they'd had within Mulago Hospital. Then my second question goes to the presenter from Barara. There was a dip in 2021. There's a graph you showed about deaths and those who absconded and those who are alive. And there seem to be a lot of deaths around 2021 in proportion. I was just wondering what could have happened around that time.
Okay, thank you, President Chituka. Any other question? Yes, over to Sister.
Thank you so much, our presenters of this morning, for those wonderful presentations. I am saddened, or we are all saddened, by the burden of trauma in our country. And I see here, we are all specialties, we are all people of different specialties. We are all planning how to manage these trauma cases. But I think let us pause and look around. We as surgeons here, it may not be only to you, but all of us seated here, we are looking at the abnormal to be normal now as we travel on our roads. What can we do as surgeons? What plans can we do? What message can we pass to our leaders so that from now on we shall also be planning prevention other than treating these cases? Thank you.
Thank you very much. One more question, if we have any in the audience, then I'll have the floor, starting with Dr. Sembatia, to give us a feedback on those questions. Thank you. You can use the mic.
Thank you so much for these questions. I think if I may start from the suggestions and questions of Professor Galkandi, I think most of them were suggestions. However, the other question was how much of these cases occupy our emergency theaters and electives. As it is said and shown, most of our emergency cases are trauma patients. And we run this on a daily basis. And most of our elective cases lists are populated by cold cases like intracranial tumors. That's when we do a lot of open craniotomy, transphenados, and the microscopic surgeries. We do all that during our elective cases, which these days it is only a single day in a week that we carry out elective cases, despite having an enormous number really of cases on ward. Patients can even wait for 3 to 5 months waiting for surgeries. Yeah. I think the other comments were suggestions from Prof. Kalukande. Then the other question of 2021, whereby we are seeing that kind of drop, more deaths, uncare, that of abscondment. I think we looked at that, and one of the reasons that really came to our minds was because of that wave of COVID, whereby even doctors were not spared really during that period. Those who didn't really have like permits to move, they couldn't really attend to emergencies as we do now, because these days we are 24/7 available for any emergencies. That's what I can say. Thank you.
Okay, thank you, Dr. Sembatia. Could it be that we had few cars moving because of the lockdown? So less trauma. Dr. Namuga, Martha.
Thank you, Dr. Chituka, for the question. The experiences were not limited to just the ones they've seen in Mulago. So perhaps the first years reported from their experience was from elsewhere, before they came for MED, during MED, and so on and so forth. We also noted that the second years had fewer responses. Well, the survey was sent out for 6 weeks weekly, and they just didn't respond. Perhaps they couldn't find time from their busy schedules, I'm not sure.
All right, thank you. Dr. Chamlavi.
Mine was about the conclusion. Prof, I didn't know what to make out of the 9 and the quantities of NFL, but I'll come and we discuss further. Then about sister's question, what can be done about trauma? I think we need to make like public, there's like the way we did for breast cancer, like the way we did for HIV and AIDS. I think we need to make an uprise and just go and, you know, make a fight and say we are tired of doing all this, and it takes away our energies from doing other things. So we pray that the government can come and really fight for us. And we need a lot of political will and power, I think.
Thank you very much. I believe as surgeons, if we get out of theater and have such conferences, we put our information out there, I think the political class and the public health class will have an interest and they will act accordingly. I now invite Professor Kitia to give us a closing remark on this session, since he's the neurosurgeon on the panel. Thank you.
Thank you very much, Dr. Setavi. I would like to appreciate the leadership of us all and the committee that organized this conference for the work well done. I would also like to thank the Minister of Health for the promise he made to us that they will give us consumables as for neurosurgery. I tell you, we are struggling, and we've been struggling, all of us. The patients struggle, the surgeons struggle, and the attendants also struggle, because we get a case and then we must ask them to go and bring the consumables. Sometimes it's very difficult for them, and they may come late, actually. And I would like also to appreciate that the ministry approved 2 posts of resident neurosurgeons at district level. I think that's very important to us, and we should appreciate that. Slowly by slowly, we shall get where we want to go. Where do we want to go? We want to increase the number of neurosurgeons. At the moment, we are working at a ratio of 1 neurosurgeon to 2.6 million of the population, and yet WHO recommends 1 per 100,000. And they also accepted that LMICs are not very well positioned, so they said, okay, we shall accept 1 to 200,000, but you see how far behind we are. So if we do that, then we shall, if they create posts like they have done, and that we increase training like we have done in Mulago Hospital and in Mbarara Regional Referral Hospital, then we shall be able to take neurosurgery to the north, because in the north now there is no neurosurgery at all. In eastern Uganda, it is only a private institution. They are doing a very good job, we appreciate, but we need other public hospitals to participate in this battle of giving services, of neurosurgical services to our community. And we have seen that there is an increasing demand of these cases, even at regional level. And that there is safety. We can do these operations safely. The outcome, the mortality outcomes are not, can be tolerated, I think. They're not all that bad. A word of advice to those who are talking about trauma. Trauma is a very important thing. As you can see, the papers presented today were all about trauma. Trauma has been there in the previous presentations. That we should also change the way we train our candidates. The big problem of attitude can be addressed if we send our candidates on attachments rather than teaching trauma on during workshops and lectures. We need to have them on rotations, on attachments. The curriculum of general surgery should change also, that candidates are sent to appropriate centers for training, so that we can uplift their attitude as far as handling trauma is concerned. Once again, I appreciate people who have come and the organizers and leadership of us all. Thank you very much.
Mr. President, the culture has been set, a photo with your presenters, and we'll go to the next session chaired by Dr. Namugenyi and Dr. Tendo, isn't it? Yes.
Thank you so much, and thank you, Dr. Setabi, for chairing that session. Most of you don't know, when I was in my first and second year MEd, Dr. Setabi was one of the kind surgeons, young surgeons, to mentor me, and yeah, I appreciate that. At this juncture, we'll invite Dr. Tendo Catherine and Dr. Victor Chigonya to chair the next session. Dr. Tendo is a general surgeon. She's also the Deputy General Secretary for the Association of Surgeons of Uganda. She has expertise in trauma care. She's worked at a high-level trauma center with the Bancroft Global Trauma Care, and she's also an ATLS instructor. Dr. Tendo, you're welcome. Dr. Victor Chigonya, kindly, is our publicity secretary. All the nice things you do, you see, that you get to go back home with. That gentleman, he's a general surgeon and laparoscopic surgeon at Chibuli Hospital. He's the head of the chair surgery at the hospital. Kindly, you're welcome. Your presenters have about 7 to 8 minutes. Please keep time. Our timekeeper, please be active so that we proceed. Thank you.
Thank you, Dr. Christine, my boss, as I call her. And you're welcome to our session. If you're seated and your GI is empty, you haven't dumped anything, kindly make your way to the serving tables. And as you may have noticed, I've moved with a mug. If you need to keep your GI confused, we have mugs on sale, which are branded as SAO, at a fee of 50,000 shillings. So kindly visit that table if you can. It's a cold weather. Thank you. So this is a multidisciplinary session about trauma and urology, and co-chairing with Dr. Victor. So I'm going to invite the panelists. We have Dr. Jacobo Unsuvuga. So Dr. Jacobo Unsuvuga is he's currently a pre-intern from Gulu University and a researcher as well with general interest in the surgical trauma. He's had 4 publications so far, and there are 10 more publications in the waiting. He's a biostatistician with great knowledge in the use of statistical programs like R programming. So Dr. Jacobo, I invite you, please. So he'll be presenting about factors associated with patient satisfaction with postoperative pain management among traumatic orthopedic surgical patients at a tertiary hospital. And like I mentioned, he's a researcher, so he has 2 sessions in this time. And he also presents about the prevalence and associated factors of depression in orthopedic trauma among patients admitted at a tertiary care hospital in northern Uganda. And then we also have Dr. Willie Kwegombe. Is Dr. Willie Kwegombe in the house? All right, I've been informed he's not around. Dr. Obapas Robert. Yes, Dr. Obapas Robert will be taking us through the prevalence and associated factors of erectile dysfunction among men attending the urology clinic at Mulago Hospital. A cross-sectional study, you're welcome. Then I'll also invite Dr. Sahar. I don't know, I may mispronounce your name, but according to my primary school, I'll say Dr. Sahar Ya. I don't know if he's in the, he or she, I can't even tell. I apologize. But do we have, is he online or he'll be in-house? He's not around. Okay. So we'll have 3 presentations, and each presentation will be 8 minutes, but maximally. So let's try to keep that time. And as they present, please take some notes, and we'll invite questions. So let's invite Dr. Jacobo Unsuvuga. Thank you.
Thank you so much for this great opportunity once again. This is one of the studies. Good afternoon to you all. Like the name stated, Jacobo Unsuvuga is my name. I'm happy to be here once again in the SOL conference for yet this other great opportunity. Before I start this study, I'll make sure that I'll keep my time. It's important to use this platform to say something a little about me. First and foremost, I must thank, it's good enough he's around, Professor Asimwe, the awards you told me when I finished my diploma in 2018. Those words, I kept on them. It's why in 2019, I joined for MBCHB in Gulu University. Thank you so much. We're in private theater up there in Uganda Cancer Institute. You told me, no, your body is for consultants. Go. You're wasting time. Those words, I kept them in my mind, and that's why at least I managed now to get done with MBCHB, and one day I'll be a surgeon. Before I start still, I need to notify researchers in the house that I do some part of work as my way of living. I'm a biostatistician, well-versed in R programming, STATA, and SPSS. I've done lots of analysis for many postgraduate students way back from 2018 to date. So SHOs who are here, I'm at your service. Thank you so much. Now, This study is about prevalence and associated factors of depression in orthopedic trauma patients admitted at tertiary care hospital in northern Uganda. Particularly, this hospital was Gulu Regional Referral Hospital. The other members, Christine, Fedris, Brenda, are colleagues. They were cosmates, and Dr. Morena Isanga is a psychiatrist in the Department of Psychiatry, and Dr. Stephen Baguma is a medical officer on the ward. So, physical injury, disability, and emotional distress have a common relationship. Several studies have shown a relationship between trauma, depression, and poor outcomes. The literature on trauma and depression is limited with regard to clarifying the relationship between the degree of injury and depression, and the relationship between physical function of patients with less severe injuries and depression. Depressive symptoms have been reported in admitted patients of musculoskeletal trauma. However, prevalence and associations of depression have not been reported after definitive management of the injury. In this study, this is a cross-sectional study. We went to the surgical wards of Gulu Regional Referral Hospital, and we went to 125 patients who had musculoskeletal injury. In these patients, we randomly recruited them in a week, and in here, we used a Beck's Depression Inventory score, and we assessed their pain as well using the VAS score to find out on how their mental status was running. So the surgical setting was a surgical ward of Gulu Regional Referral Hospital, and our eligibility criteria, we were interested in orthopedic trauma patients in Gulu Regional Referral Hospital. The reason why I'm emphasizing orthopedic trauma patients, because among the patients admitted in the trauma surgical ward of the hospital, it is them that normally stay there for closer, more than even a month, because of implant issues, constraints. Patients from the north, most of them are financially constrained. So they don't really have money sometimes to buy the required implants. So they end up staying on the wards for more than a month even. So we excluded those who were critically ill. We used a questionnaire that had both open and closed-ended questions, and a special score of BDI, which we used to assess the depressive symptoms. We received ethical considerations from Gulu University Research Ethics Committee and administrative permission from Gulu Regional Referral Hospital. Now, it is important to note for surgeons who are here in the house that oftentimes most of you, when you go to operate, you are interested mainly in what you are going to operate. Sometimes, some of these patients, you'll find the surgeon always commenting, awaits for an implant, awaits for an implant. And in the end, this patient stays on the ward for more than a month. So what really happens? In the end, most of these patients actually are mentally broken down. And it is very common in some surgeons that people no longer take patients as a whole. They are interested in the surgical condition that they are going to work on, forgetting the mental status examination that they studied in the undergraduate learning in the psychiatry rotation. So, we enrolled 125 participants. Their average age was 32.6 years, and 27 patients were females. So, out of these, 43 patients had an abnormal BDI score and a higher VAS score for pain. A younger age, living in nuclear family, and cannabis drug use were associated with abnormal BDI score. Up there in the north, many people are highly exposed to drug abuse. And the one which is highly commonly abused is the cannabis. In the conclusion, we found out that depressive symptoms are common in musculoskeletal injury patients at 1 month after admission. Please, this doesn't limit only to those that are having musculoskeletal injuries. Any patients, surgical in nature, even in medical, more than a month being on a ward is never simple. There are many issues, psychological concerns that these patients go through that people, or as doctors, don't take concern and are not interested in. So it is important for you to know that when you're looking at these patients, it's important to look at their mental aspect as well. I must conclude by acknowledging for yet this other great opportunity oversaw, It's really a great honor to be here once again. I was here still last year in 2024. I'm also appreciative of the University Research Ethics Committee and the Guru Regional Referral Hospital. I must not forget the motivational sessions. I've been an active member. I attend physically, and in my absence, I also always do attend on virtual meetings in the Suje's motivational sessions that I've always been actively involved in. So Suje's, I'm highly appreciative. This is the Nsubuga you are trying to make. I must appreciate the psychiatrist on this study, Dr. Naisanga Moli, and I must appreciate the medical officer of the ward, Dr. Baguma Steven. Thank you so much. That was study 1 out of the many. Apoyo Matek is an actual version of thank you.
Thank you so much. How do they respond to Apoyo Matek? Be or Afoyo? Be, Aya do, Be. So a round of applause for Dr. Nsubuga. And thank you, Mr. Simwe. Those words, you see, now we are having an upcoming orthopedic surgeon. Yes, so I'll invite Dr. Obapas, then you come on again to have your next presentation. Thank you. So Dr. Obapas is going to tell us about prostate cancer among patients presenting with obstructive lower urinary tract symptoms at a tertiary hospital in southwestern Uganda. No, I apologize. It's about prevalence and associated factors of erectile dysfunction among men attending the urology clinic at Mulago Hospital. You're welcome.
Thank you, Madam Chair. I want to take this opportunity to recognize my teachers in the house. Notably, I also want to recognize the presence of my senior surgeon there, Mr. Podoi. He taught me when I was just beginning to crawl to become a doctor, and Dr. Ajiko, and the absence of the senior most, Mr. Kiria, Professor Kiria. I want to take this opportunity to thank them for coming around. Also want to recognize the presence of all my professors and teachers in their various capacities. Let me dive into my presentation. I'm called Ubapus John Robert. That's the principal investigator. Was basically studying the prevalence and the factors associated to erectile dysfunction among men attending urology clinic in Mulago. Yeah, these are my supervisors, Mr. Badru and then Mr. Makumbi. But we have other host of supervisors, including Professor Galukande. He has been always very instrumental. Okay, this is the outline of the study. Basically, I'm going to define one operational definition. According to this gentleman called Tom Lu, he described this as inability to initiate or sustain an erection sufficient for a satisfactory encounter, sexual encounter. So basically, we are going to be referring most of our time ED. I'm going to be mentioning ED. In this context, I'm not meaning the executive director, I'm meaning the erectile dysfunction. In the global stage, a study was done in 1999, and it was projected that by 2025, we shall be having 322 million people with this disorder. And this cuts across, and it has geographical variations, as we shall note as we proceed with our study. What is the problem here? So the bigger issue here is erectile dysfunction. We have to acknowledge this is a significant public health concern in Uganda affecting men. We went ahead and did a survey, like a pilot study in the clinic. We realized like there were 4 people in average seen in a clinic a day. But according to interaction with experts in the department, they really think this is an underestimation of the problem, either because we are not proactive in making a diagnosis or patients are reluctant to ask us these concerns. So we're also looking at the associated factors. These are multiple, as we shall note them as we proceed with the presentation. Despite all this, we didn't find a tying information in the literature. So we were trying to explore this and be able to come up with something justifying our course. So basically, my professor used to say, likes telling me, justification is a mirror of my problem statement. So I'm not going to dwell in it. My objectives, basically, specifically, we're looking at the prevalence in one arm as objective one, and then we are looking at to ascertain the associated factors. What are these different factors which affect erectile function in men? And I also want to make a disclaimer that the findings of this study may not reflect what's happening to any member here in the House. So basically, in our study, we did a cross-sectional study in urology clinic of Mulago National Referral Hospital or specialized hospital. It took us 3 months doing this study, and our population we're targeting were men aged between 35 to 60 years. So I think most of us fall in that category. So we recruited 384 people according to our study. I mean, our calculation using the FLIS and Kesley formula, we came up with a 384, which was the largest number to be our sample size. So this is basically showing us the variables, how they affect the outcome. Our outcome here is erectile dysfunction, and these are the different variables affecting it. Now, in our procedure, this is the information, we got them, and we put them in Epidata, that is a Microsoft Excel. And then the data which was clean, we exported it into Starter version 14 for analysis. So what are our findings? So basically, this is the characteristics of the study, our study population. So you realize what is keynote here I wanted to mention, you will see our various factors, both the categorical and continuous variables, how they're affecting the erectile function at different levels. So one of the important things here I wanted to mention was the socioeconomic status. In our study, we noted having a high socioeconomic status as a risk factor, by the very serious risk factor that we are going to study more. Now, basically, we did a bivariate and a multivariate analysis. These are multiple factors we are looking at. So in these factors, when we assess the bivariate analysis, that is a factor plus the outcome. We are looking at two factors, one factor and then the outcome. Now, we realized those factors with a p-value which was less than 0.2 were significantly associated with erectile dysfunction. So in this case, we subjected them into analysis, into multivariate analysis. So the factors we subjected into multivariate analysis included history of alcohol use, chronic cigarette use, and then urethral stricture and lower urinary tract symptoms. Basically, this study will, I'm sure, is going to interest key experts like Professor Simwe here and the rest. In our continuous variable, which was age significantly affects erectile dysfunction. We're going to, objective one in the analysis, our objective one, we found erectile dysfunction, because we're looking at the prevalence, 65.3% of the people had this concern. Then in our objective two at a bivariate level, we noted factors like socioeconomic, as I noted before, had a significant impact on erectile dysfunction. Then what does this show us? At a multivariate level, we realized we kept on decreasing our factors because it has to have a significant statistical relevance to the study. That's why we went ahead to keep doing these analysis models. But then we noted that cigarette smoking basically didn't have, maybe it was a co-founder. There were co-founders that were affecting it. That's why it was not significant in the multivariate analysis. So in the discussion, basically, I wanted to say the prevalence we found was 65.3, and with those key factors, chronic alcohol intake, urethral stricture, lower urinary tract symptoms. Most of these factors are amenable to urology department. So in the variable studies in our setup, in our neighborhood and in sub-Saharan Africa, we noted that our study, because of the nature of the study or the department we studied in, we had a higher prevalence. But still within the limit of different studies which were done across the globe. So we think, could it be also because of the tool we used? But no, it wasn't. So because some of the tools we kept sharing them, because these tools were modification of the other. So age is a very big factor, because from age 35, there is 2.9 risk of you developing erectile dysfunction. Every year that increases. Every year there is 2.9 risk. So what does that show us? As we age, we need to be very cautious of this public health concern. And then alcohol consumption, also very significant. Urethral stricture and lower urinary tract symptoms. So as I conclude, the limitation of the study, because we are assessing the outcome and associated factors within the same setting, we were not able to make a very conclusive study, because this might need somebody to look at and follow up these individuals. And then, as we conclude, the prevalence among men attending urology clinic, we found it was very, very much significant. That might inform public health of our study, and it will be a game changer. My professor once again re-echoed these words to me and said, you can never talk about a man's health without sexual function, and you can't talk about a sexual function without erectile dysfunction. Thank you so much.
Thank you so much. Can we have another hand clap for Dr. Obapas? Very, very interesting research, and I had to take it in slowly, not to rush it, because it's quite sensitive, and I'm sure we have questions out there. Once again, I will invite Dr. Equitable Nsubuga to present about the prevalence and associated factors of depression in orthopedic trauma. Okay, factors associated with patient satisfaction with post-op pain management among traumatic orthopedic surgical patients at a tertiary hospital. You're welcome.
Thank you so much for yet this other great opportunity. I'm told I have 5 minutes. I will use them. But in every session, I'll talk about something briefly. Because this is the best platform, at least some of us shall be known. No, it's the other one. That one will come later. Factors associated with the one from 11 to 11:10 in the book. Thank you. But meanwhile, I must appreciate again for this other opportunity to be here ahead of you, my seniors, the surgeons in the house, and entire team at large, protocol observed. Once again, I must thank you so much, especially the surgeons who are here and the SHOs who really helped me during those hurdles. I must be open to some medical students who are here that in my undergraduate, I never paid any school fees. There were surgeons who paid for me from year 1 to year 5. I used to volunteer right from accident and emergency, Ward 7, spine, trauma ward, and most SHOs, at least I've introduced them there. Always they think, which kind of surgeon is that one? No. In the end, I reintroduced myself. Thank you so much. I have to take this opportunity since MBCHP got done. I'm really thankful for what you did for me, and I really do appreciate. I can't forget once again to thank Professor Simwe for those words. I remember I was with you You compared me, there was a certain SHO by then, was called Dr. Nsimbi Mathias. Actually, right now, I think he's a surgeon in Chisubi. He told me, but you, look at your friend. So all of those words are in my mind. That tempted me to go back. I must thank Dr. has just entered, Dr. Sekabira. I've been volunteering in Mulago from 2016 to date. Thank you so much. Mulago has never chased me away. I'm really appreciative. Back to my study. Even when all volunteers were chased away, the ED said, Subuga, your discipline, stay behind. Thank you so much. On my study here, many surgeons here in the house, or even some of you, you work on the patients. When you are done, you go away. You forget about the issue of pain. Most of you, even the following day, when you come, what really happens, you are interested in knowing how is the patient, is everything fine, you go to another patient. You don't really get time to interact with this patient about the pain this patient is going through, even on postoperative day 1. It is really amazing for some people. So here we got interested in patient satisfaction with postoperative pain management among those patients that were of traumatic orthopedic surgical injury, still in Guru Regional Referral. I'm interested in this because our findings, our observations in Guru Regional Referral are most of these patients, I think they were lessly cared for. So that's where we saw the problem, and that's why we are interested in more in that area of the traumatized patients. Yakobo Nsubuga is my name. Robert, Gavesias, Francis, Christine, Fedris, Brenda are classmates, and I must say, Dr. Felix Bongomin is one of my lecturers. Dr. Maurice Ojala is a surgeon in Guru Regional Referral, and Dr. Stephen Baguma is a medical officer on the ward. Now, in my operational definitions, pain refers to unpleasant sensory and emotional experiences associated with actual or potential tissue damage or highly unpleasant physical sensation caused by illness or injury. So pain management is the care of physical sensations caused by trauma or illness. Then patient's pain management satisfaction is defined as the degree to which the patient is contented with the pain management services offered or rendered. Briefly here, according to William and Craig, pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. Studies have found out psychosocial entities such as anxiety, fear, personality, confidence, decision-making, self-esteem, and stress affecting perception of pain stimuli. It's important to note that postoperative pain is one of the major concerns in these traumatic surgical patients. So postoperative pain management can be affected by multiple factors such as gender, age, preoperative expectations, information given prior to surgery, preoperative pain medication, type of anesthesia, type and duration of surgery, communication of staff with the patient, this is very important, and experience of pain relief. In our methods, this was a cross-sectional study. We carried it out in Guru Regional Referral Hospital. An interview was conducted using an interviewer-administered questionnaire, which had both open and closed-ended questions, and we were on the surgical ward. So we included all postoperative orthopedic trauma patients in Guru Regional Referral, and only those that were 18 years and above. Those who were critically ill, they were excluded. We used an open and closed-ended questionnaire to collect data. We got ethical approval from Guru University Research Ethics Committee and administrative clearance from Guru Regional Referral Hospital. In the key findings, we recruited 76 participants. Majority were aged 18 to 25 years. In the clinical findings, the overall, the 37 were very satisfied with how pain was being managed. 32 were neutral, and the 7 were not satisfied. Among the 37 who were very satisfied, it's important to know that those that were aged 18 to 25 years expressed being very satisfied, while married individuals showed a higher rate of satisfaction. Then primary education level had higher satisfaction. Among health factors influencing satisfaction, the availability of health workers to respond to pain concerns emerges as significant, with expressing very satisfied responses. Factors significantly associated with pain management satisfaction included: 1, patients aged 26 to 35 years, are more likely to report being very satisfied compared to those that were 18 to 25 years. Patients receiving painkillers when in pain from nearby private pharmacies due to out-of-stock supplies in the hospital. This is very important to note. Guru Regional Referral Hospital, where it is located, there are very many private pharmacies outside. But oftentimes, some patients really go and buy these painkillers from these pharmacies. So they reported that really they feel more better when they get these drugs from there, more than in the hospital. The reasons that we shall talk about later. Patients experiencing pain are 1.32 times more likely to report dissatisfaction when health workers are not available to respond to pain concerns. So the dear surgeons who are here, some of you, probably, you could prescribe, but you fail to follow up. Is my nurse doing this? Is my intern doing so? If that is not followed up, I do believe some of these patients always will never be satisfied. You come, you talk to a patient, pre-operatively, you give a patient time. But post-operatively, some surgeons really don't give time again to these patients. Yet that is the critical time some of these patients really need you. Nurses are significantly more likely than doctors to be associated with patient pain satisfaction. So this is very known that also some surgeons, after prescribing post-operatively, the nurses take over. Some of these patients are interested in seeing you. Some of this pain is psychological. When they see you, probably, they can get better and get relieved. Patients with mild pain post-operatively are less likely to report dissatisfaction compared to those with severe pain. So overall, less than half of the respondents were very satisfied. A similar number was neutral, and less than a quarter were not satisfied to pain management. 5 factors were significantly associated with pain management satisfaction, which included 1, patients aged 26 to 35 years, 2, painkillers bought from nearby private pharmacies due to being out of stock in the hospital. Sometimes national medical store really takes long to deliver these drugs to those places, regional hospitals, that are far away from town. So even the real paracetamol, these other drugs, any drug may be on an analgesic ladder, sometimes are not there. Because they are not there, patients end up buying these drugs from the private pharmacies nearby. So they are more convenient with them, but in the end it puts them to a cost. Health workers not being available to respond to pain concerns. This goes back to the surgeons in the house, my seniors also in the house. How are we interacting with these patients post-operatively? Pre-operatively, some surgeons will deeply interact with the patients because you want probably this patient to do your clearance. Maybe probably you want to talk to the patient and accept the surgery. But in the end, post-operatively, do you give enough time to this patient? Is this patient really appreciating the time you give him after an operation? Nurses being significantly more likely than doctors to respond to pain concerns. I think this is a general concern across most of the hospitals that the nursing system normally takes up the journey. But remember, as a surgeon, you lose nothing probably to pass by and say hello. Some of this pain is psychological. Patients with mild pain post-operatively as well. I must acknowledge again for yet this other great opportunity for us all that it has given me to present. I must acknowledge Guru University Research Ethics Committee, Guru Regional Referral Hospital. The motivational sessions ever since have been silently involved and as a member silently up to date in SUJEs. I really appreciate those monthly meetings. They have done a lot on me. The previous one was on bariatric surgery. I was about to become a patient of doctor, but I said no. I'm just fat enough. This is my health. I won't go there. Then I must appreciate Dr. Bengmin Fredericks. He's an internal medicine physician, but we have done a lot of work with him, over 54 collaborations. I've been a PI in Guru University with 26 ideas as an undergraduate, 4 are out, more 10 are in the pipeline. I thank you so much. You have been really a good mentor from my second year up to date. Dr. Jala Morris is a surgeon in Guru Regional Referral Hospital. Dr. Baguma Stephen is also a staff in Guru Regional Referral Hospital. Apoyo Matek. Thank you so much. Apoyo Matek is an actual version of thank you so much.
Dr. Subuga is such a great testimony, as you've heard. So thank you so much. I'm ably informed that the next presentation is online. It's a recorded session. He's not around. So I'd like the media to project his presentation. It's by Dr. Willie Kwegombe, prostate cancer among patients presenting with obstructive lower UTI symptoms at a tertiary hospital in southwestern Uganda. Let's have it.
Good evening, ladies and gentlemen. My name is Dr. Chegombe Willie. I am from Soroti University, the Department of Surgery. I'm here to present to you the findings of a cross-sectional study on prostate cancer among patients presenting with lower urinary tract symptoms at a tertiary hospital in Western Uganda. Operational definitions of not the abnormal directed examination. Think of it as any abnormality that you would find in the prostate.
Sorry, are we able to continue?
Good evening, ladies and gentlemen. My name is Dr. Chegombe Willie. I am from Soroti University, the Department of Surgery. I'm here to present to you the findings of a cross-sectional study on prostate cancer among patients presenting with lower urinary tract symptoms at a tertiary hospital in Western Uganda. Operational definitions of not is the abnormal directed examination. Think of it as any abnormality that you would find in the prostate gland. Directed examination. Lower urinary tract symptoms as a set of symptoms are defined and classified by the American Society International Prostate Symptoms. Physiological pattern, basically we're referring to the physiological types of prostate cancer described by pathologists and how they correlate to the clinical findings of the patient. Of note is that the lifetime risk of a male developing prostate cancer is 1 in every 8 male will develop prostate cancer. Making prostate cancer the second commonest family malignancy. And number one malignancy in about 118 countries, Uganda inclusive. Usually the cases happening between patients above 65 years of age. However, initially the loads were lower for low-income countries like Uganda. Currently, the trend is changing.
Probably we are having some technical
My name is Dr. Chegombe Willie. I am from Soroti University, the Department of Surgery. I'm here to present to you the findings of a cross-sectional study on prostate cancer among patients presenting with lower urinary tract symptoms at a tertiary hospital in Western Uganda. Operational definitions of not is the abnormal directed examination. Think of it as any abnormality.
All right, I think we may not be able to continue. Can we have the mic, please?
Good evening, ladies and gentlemen. My name is Dr. Chegombe Willie. I am from Soroti University, the Department of Surgery. I'm here to present to you the findings of a cross-sectional study on prostate cancer among patients presenting with lower urinary tract symptoms at a tertiary hospital in Western Uganda. Operational definitions of not is the abnormal directed examination. Think of it as any abnormality that you would find in the prostate gland. Directed examination. Lower urinary tract symptoms as a set of symptoms are defined and classified by the American Society International Prostate Symptom Score. Histological pattern, basically we're referring to the physiological types of prostate cancer described by the pathologists and how they correlate to the clinical findings of the patient. Of note is that the lifetime risk of a male developing prostate cancer is 1 in every 8 male will develop prostate cancer, making prostate cancer the second commonest male malignancy and number 1 malignancy in about 118 countries, Uganda inclusive. Usually the cases are happening between patients above 65 years of age. However, initially the loads were lower for low-income countries like Uganda, but currently the trend is changing, with rates of prostate cancer increasing. This is basically because we're getting better diagnosing the prostate cancer, but also getting better at keeping documentation. Patients are aging more, and there's an increase in the risk factor for all cancers. Fortunately, majority of these cancers are presenting at an advanced stage with incurable symptoms of incurable disease, which could be local advanced disease or metastatic disease. In the local advanced disease, majority of the studies conducted in Nigeria and in Uganda by Okoko and Yahaya, they have highlighted LUTs as the commonest presenting complaint. But we all know LUTs are not only caused by prostate cancer, but it's a myriad of other causes of LUTs. And a large number of patients actually presenting to the OPDs with lower urinary tract symptoms. Unfortunately or fortunately, the majority of them are likely to get their first test or screening for prostate cancer at this time. This might not be equitable, as we do not have enough information, clinical information on the rates of prostate cancer, biochemical patterns, and also surgical patterns of prostate cancer among this population of patients. Therefore, we set out to describe the patterns of prostate-specific antigen, doctorate examination findings, histological findings, and rates of prostate cancers among this population of patients at Barrow General Referral Hospital. Ours was a cross-sectional study at Barrow General Referral Hospital. Non-random consecutive sampling was used to select a sample size of a sample of 140 patients who were subjected to assessment of the severity of LUTs using the IPSS score, and then later the blood sample is drawn for measurement of total sodium phosphate-specific antigen levels, and then a dictorectal examination. Out of these 140 patients, as you can see in the flow chart on the right, 99% of the patients actually were found to have abnormalities in total prostate-specific antigen levels and dictorectal examination findings, and were subjected to a dictally guided TrueCut prostate biopsy. By the way, abnormal total prostate-specific antigen levels were considered as levels above 4 nanograms per mil. Our findings: overall, we enrolled 140 patients. Mean age was about 69.8. Majority of the patients were between 61 years to 70 years. Most of them had a very high PSS score. The mean PSS score was at 24.32, and the highest PSA levels were observed among these patients who underwent prostate biopsy, who had confirmed prostate cancer, and those ones who underwent those ones who had abnormal dictorectal examination. The lowest mean PSAs were observed in patients who had benign prostate hyperplasia. Abnormalities in the RIs were also common in 57.1% of the patients, and the commonest abnormalities were enlarged prostate, nodular prostate, and loss of the median fluid. On histological assessment, the commonest histological subtypes were actually all benign, but prostate cancer was found in 46% of the patients who underwent a prostate biopsy. All those who had a prostate biopsy had prostate adenocarcinoma as the commonest and the only histological type, and it was a very high risk for unfavorable with some score above 18 majority, 37.8 of the patients. The graph here to your right shows is a line graph highlighting the proportion of different histological findings as per the IPSS score. As you can see from this graph, the proportion of patients with prostate cancer here quite increases drastically with increase in the IPSS score, but this relationship was not found to be statistically significant with a p-value of 0.84. The dictorectal examination finding were more likely to have the patients with abnormalities on DRI were more likely to have a positive biopsy for prostate cancer, and this was actually driven after adjusting from the total serum PSA. Commonest abnormalities associated with prostate cancer were had prostate consistency and loss of the median fluid. In the discussion, we realized that majority of the studies that were conducted in a similar setting to ours in hospital setting agreed with our findings. However, community-based studies conflicted with our findings, which highlights the fact that there's either an ascertainment bias with hospital-based studies, but also the fact that patients presenting to the hospital most likely present later symptoms of advanced disease. However, to note in the discussion of the patients with severe lutes were more likely to qualify for a trocar prostate biopsy, the Fisher's success of 0.01, as they had very high medians PSS scores, and they also had abnormalities in the declarative examination. This further is in agreement with the most guidelines, the 2018 NIC guideline, GCE guidelines of 2023, to screen all patients symptomatic, all high-risk symptomatic patients for prostate cancer. Positivity rate of prostate cancer was high at 46%. This was higher than most studies that did not consider the determinant of the denominator in this case. However, despite of all these findings, majority of the studies actually that were conducted in Nigeria and also in Northern Uganda by Equitable were in agreement with what we found. But despite of this, none of these studies elaborated a statistically significant relationship between these two parameters. Also, prostate cancer arises from the colorectal zone, and we know what that means. Abnormalities on DRE carried a significantly increased risk of having prostate cancer. This has been a known fact and could mean that prostate cancer, colorectal examination could actually be used as an alternative for screening prostate cancer, especially in areas where PSA is not readily available. The anatomical origin of the prostate cancer suggests that malignancies can also easily be detected in the early stages. Mean Gleason score was too high, which was true for Yahaya and Okuku, but not true for studies in white population in USA, Louisiana. This could mean that either our African patients have poor taking behaviors, but also Africans have been known to have genetic predisposition to aggressive prostatic cancers. In conclusion, we had high rates of severe lutes among these patients presenting to the OPD with symptoms, and these were likely to qualify for testing. There were also high rates of prostate cancer, but there was no statistical significant relationship between lutes and diagnosis of prostate cancer or this category. The increased risk of prostate cancer among patients with DRE abnormalities makes DRE an appropriate substitute for screening in areas where PSA testing is not accessible. High-risk adenocarcinoma was the commonest type of malignancy among these our patients. I would like to thank Dr. Marvin Mutakoa, Dr. Equitable Joseph for providing mentorship and supervision. The Sorority team, thank you for the support. Other members of the research team, Dr. Kidi Ronald, Dr. Subuga Ronald, and the patients for allowing us to collect information from them.
Thank you so much, Dr. Willie. That was quite an interesting study as well. Prostate cancer is out there. And they tell us that men above 40 should have a PSA done. We start from there. Think about it. So right now I'm going to invite 2 questions. 2 or 3 questions. There is one. Can you have another mic here?
Thank you very much. Mine is to Dr. Obwapos. There's always a saying in urology that a man's usefulness can only be announced after a report from his urologist. And that's where the issue of stigma comes. My experience with men with the disorders of sexual function is that as they come as a couple, they are willing to answer questions, and they first start blaming the woman. After you have exhausted the woman and start zeroing on the man, they change the doctor. And that's what brings problems. You cannot get these statistics. 3 out of 5 is a very high figure. And I see about 20 men here. I'm so worried. That's a very big problem, and this has to be taken seriously. Mine is just a comment. Thank you very much.
Thank you, Dr. Epodoi. I think I had a similar comment.
Thank you so much, Dr. Nsubuga. I'm very interested in your paper about pain because it's really a topic that should be discussed more. And actually, I will ask maybe the ASAO Council, maybe next conference, we invite a pain expert to really talk to us about pain. Some of us who have been patients, this one is now personal, but really post-op pain is really not managed well by surgeon. And most of the times we are not there. So the nurse is the one is there, but most patients are always in pain before their next dose. And even all my cesarean sections, I remember I will always cry of pain, a painkiller before my next dose was due. And the guy will not be there, it will be the nurse. And I've worked in some places where the pain management is really good post-op. The patient will have an epidural, they will have a PCA, they will have at least 4 models, 4 modalities of pain post-op. We don't have that privilege here in Africa, but I think we can do better. I think it's a topic that we should explore more. We can get an expert and we make protocols for pain management post-op so that we just say, this is protocol A, protocol B for this patient, because it's a big gap in our post-operative management. Thank you so much for bringing that topic up.
Thank you. Thank you, Dr. Ann. Let's have Mr. Simwe.
Thank you very much, presenters, Dr. Nsubuga and Dr. Robert. Dr. Robert, your topic of erectile dysfunction is very interesting and very relevant. I was just interested in some of your definitions. To begin with, the definition of erectile dysfunction itself, I think was a bit shallow, if I may say, because there was a significant amount of subjectivity to the satisfaction of the parties. I think we need to dig a little bit deeper. What's the satisfaction? If someone is annoyed with you before the sexual act, they might decide that they are not satisfied. That might be described as erectile dysfunction. 2 checkpoints for sexual satisfaction is 1, penetration, and 2, orgasm, for either of the parties, preferably for both. So maybe you may need to look around for a definition which incorporates those 2 aspects. Secondly, when you're talking about the socioeconomic factors, very, very important. I don't know how you classified our Ugandan men into low income, middle income, high income. You may have, but that's also very important. But also income, one aspect that goes with socioeconomic is the expenditure. The man may be earning his 1 million, but he has to spend 2 million. So he goes home when he's very stressed. So just those 2 aspects, the definition of erectile dysfunction and then the description of the socioeconomic status. Thank you.
All right, thank you. Let's have these 2 hands and then we'll hand over.
Thank you very much, Dr. Robert. My question is on, you mentioned that age plays a role as a contributing factor for erectile dysfunction. Did you maybe come across data on the role of diet? Because we know what significantly has changed over the years is what we eat. Yes.
Thank you so much, Dr. Bapus and Dr. Nsubuga. I have 2 questions for both. To Nsubuga, actually not a question, just a compliment. Issue of pain, as Dr. Anna has mentioned, it's actually quite a big thing. Personally, I experienced when I had a cesarean section. It was really not a nice experience for me till the nurse, because I was having a lot of pain, and the nurse was like, I think this one, because she's a doctor, she has kajanja. But it was a terrible experience for me. I think there's need for us doctors, because actually you'll not understand unless it becomes you one day. Yeah. And then to Dr. Bapos, I just wanted to find out or to know the reason as to why you strictly looked at 35 years and above. Does it mean this one below 35, they're actually doing well? Thank you.
All right, thank you. We'll stop at that because of time. Yeah, Dr. Bapos, very sensitive study there. I wonder if there was an objective tool for your study, because we've heard about Mulondo out there. And I don't know if you came across some of your participants who say they were taking Mulondo, and what was your perception on that in terms of ED? Thank you. You can please address the questions.
Thank you so much, Chair, and all the questions. Starting with the last thing first, I was not, in my questionnaire, in my study, I was not studying the treatment modalities or how people are trying to fix the erectile dysfunction. So the issues of Mulondo, maybe it's something that we shall look forward into studying it. Yeah. Following it retrospectively, answering the question of Dr. Muge, he talked about why the age 35. According to African Charter on Youth and East African Charter, they share the same thing in common. They put the youth to be from the age of 15 to 35. So according to Uganda Bureau of Statistics, it puts our perspective from 15. I mean, it was 18 to 30, but the revised version is talking about 15 to 30. But by and large, we were trying to borrow the idea of Africanicity, trying to be inclusive. So we also wanted to to increase the power of our study, because we very well understand that the younger people, their sexual function, by and large, has less trouble. So we wanted to pick from 35 and onwards and up to 60. 60, because our retirement age at 60. From 60, there we can't study much about you for now. Thank you. Deborah, I had a question about age. Yeah, we understand that one, age, as we age, our blood vessels start getting trouble. This is the same mirror of what happens in cardiovascular disease. For example, heart disease, you start getting coronary artery diseases. It's the same thing that happens in our phallus, down there. So you realize that some of our blood vessels start getting atherosclerosed, reducing the blood flow, and a penis basically relies on good blood supply. Yeah, and also as we age, the testosterone level depreciates. So all these factors that come in to answer that issue of age. Yeah, there are many other factors, including diet, that includes alcohol, that we brought in. However, when we talk about alcohol, it was high risk for patients who take intermittent alcohol, those ones who drink not very regular. But chronic alcoholics were safe a bit. But in the long run, the chronic alcoholics can get a permanent damage, permanent problem. But in a short run, they were a bit safer in their sexual function. Now, to answer Professor Simwe, thanks. The first concern was talked about the satisfaction and about the definition. Yeah, according to our study, we borrowed findings from previous other studies. One of the studies were by this gentleman called Tom Lu. Tom Lu, he made this analogy in 2020, I think 2022. So in his definition, he talked about inability to initiate or sustain an erection satisfactory enough for a satisfactory sexual encounter. Now, according to him, that's what he was defining. And remember, we were using tools. We had tools. I was using a SIM score, Sexual Health Inventory for Men, which is a modification of IIEF, International Index of Erectile Function, which has been applied to many studies amenable to our setup locally and even geographically in the East
and even in other areas outside Africa. So that's why we use that study. But however, thank you, Professor. I'm going to implore more and understand more about it so that next time I will be able to give you a conclusive answer to that question, Professor. And then to my senior, Mr. Epodoy, thank you for your concern. Yeah, one of the things that could have affected our study, because it was basically the setting of the study. We did it in urology clinic. This is a specialized unit specifically handling urology concerns. Now, you realize some people come to other clinics, and when they talk about erectile function, they tell them, go to urology. So perhaps could be one of the reasons why we had a high prevalence. That's what I think. But however, it's also a concern that I will keep on understanding it more with the experts in the department and also ideas from different colleagues as we keep reading. Thank you so much.
All right, thank you. Let's have Dr. Nsubuga.
Thank you so much. My seniors, Dr. Ann Wesonga and Dr. Doreen Amuge, thank you so much. I think your concerns about pain are really pertinent. I wish ASO will look into that in the forthcoming conference. It is really very concerning. Many surgeons, like I earlier said, are focused in the preoperative period. Once surgery is done, very few of them get involved. So we hope, probably we shall get better sensitization over this. And with time, we hope it will be better. Then another thing still, the surgeons, I wish, because I've seen this practically being done in where I was, I did my undergraduate in Guru University, so we rotate from Guru Regional Referral and St. Mary's Hospital at Cho. One of the things I've seen, a surgeon reaches out to these nurses on ward, especially the in-charge. Sometimes really pain must be controlled, but the person keeping the key where those drugs are, at that time when the patient needs that drug, is not available. So these are concerns that I believe with continuous sensitization, I believe it will mean a lot of, it will change a lot. Then another thing, I have not received the question there, the surgeons who are here, the SHOs, fellow other colleagues in the house, the issue of the mental status. All of you who have gone through the undergraduate training, you were told about taking a patient as a whole. Most of these patients live with a mental breakdown from our facilities. So I think it is important and paramount, even when before you discharge a patient, taking a few things in a mental state exam will help this patient. Some of these patients, we shall help them from totally breaking down, because it is not only what you have operated that will kill a patient, that patient may resort to suicide even postoperatively. Thank you so much.
All right, thank you, Dr. Nsubuga. One key thing to note here is that as a surgeon, a patient will not remember you for the surgery you've done, but the pain postoperatively. You may do a very good minimally or maximally invasive surgery, and then the pain. They'll always remember that pain. So let's take this serious, as well as the mental issues. And for Dr. Obapas, not to worry, we are all aging, and let's celebrate our birthdays. Don't you worry about the wisdom that comes with age. So let's give a round of applause to our panelists. And I would invite them for our group photo. As I invite Dr. Christine to invite the next panelist. As she comes, I just want to welcome us once again to that table. We have our SAO branded items. We have a coffee mug, we have jazzes, we have t-shirts, we have scrubs. Let's own up the association. Get a badge, get a scarf, a tie, and we can even brand your shoes maybe in the next conference. We could brand the cups that you're using to take tea. So let's own this up and celebrate ourselves as well. When you put on the scrubs branded as SAO, you feel it as well. Thank you so much. Dr. Christine? Oh, they've asked the president to kindly show up in this photo. Thank you.
Thank you. Thank you very much. Yes, at this juncture, we all know that most of these things, I like to believe we are in a very good place. All of us are very comfortable. The AC is good. We like the ambience. We like how everything is being done right. So none of this, we can't achieve any of these things if we didn't have support, especially from you, our members, from our sponsors, our exhibitors. So we really, really, really appreciate the support, especially from our exhibitors. Please, we encourage you, when you're tired, just walk through and look at their products. And at this point, I will invite Dr. Chigonya Victor. I won't say much about him, I already talked about him, but he's the publicity secretary and also the chair, surgery, Chibuli Hospital, to invite our chief sponsor for this year, the East African Medical Vitals. Thank you.
Thank you, Dr. Christie. When she called me, I was going to theater. I have a theater list today. So I came with my scrubs. So, but the patient has ED. So we are going to sort out a few issues, and by the time we finish, we shall be okay. So thank you very much. Good morning once again. Thank you for being here today. Dr. Chigonya Victor is my name. I'm the publicity secretary of ASAU, a member of SUJES. I'm a footballer. I used to play rugby. Many people think I don't know rugby or I can't play rugby. But I was actually a captain somewhere where I used to play from. So I used to sprint. I was the chief sprinter for the medical school. Can you imagine? So I do all those things. Now today, I want to introduce to us a very great person who has been part of ASAU for some time. You see, these conferences are not easy to organize and put together. It takes a lot of resources, both financially. It takes a mental toll on the committee, by the way. Sometimes on the WhatsApp group for the committee, someone can put a statement forward, then people go quiet for 48 hours. It's not that they don't know what to say, but everyone is like, what next? What are we going to do about this? The conference has 5 days to go, but nothing seems to be happening. But behind closed doors, people are doing a lot, and the stress is there, and we try to manage it, but there are people who make sure that things happen. So today, I'm here to introduce to us a very special person who has really, really, really made sure that this conference happens. Not only this one, but even the previous one. One of our biggest sponsors since we started having these activities is East African Medical Vitals. And this is a local manufacturing company which manufactures gloves. I don't know if any surgeon here doesn't use gloves. That is a police case. I'm telling you the truth. I'm head of IPC where I'm the chair of surgery department. I'm also head of IPC. So I always tell people, put on gloves, change gloves. So we can't work without gloves. I mean, So with us, we have the MD of East African Medicals. That is Mr. Brian Kavuya. Mr. Brian Kavuya is, he has been dedicated to transforming healthcare in the country. He's a trained electrical and computer engineer from the University of Cape Town, and he has over 12 years of experience in manufacturing and bridge finance. So he has focus on quality and accessibility, and has driven key milestones, including installation of a second production line that has doubled East African Medical's capacity. So he's ensuring reliable access to essential medical supplies, and he continues to drive the mission of the company forward. So without wasting any more time, allow me invite the MD of East African Medicals, Mr. Brian Kavuya. And they are the biggest, they have been the biggest sponsors of this activity. I think I'm not the right person to disclose the figure. That is to the president. I'll leave that to the president of ASAU. Maybe I'm not supposed to now. Thank you, Mr. Brian, you're welcome. Unfortunately, I can't give you this as a gift. I don't know where you'll use it, but maybe in the factory. Thank you, you're welcome.
Thank you, Dr. Victor, for that very, very warm welcome. Before I begin, let me ask, can we have that brief video just showcasing our plant in Namave? Right. Thank you so much for that. That was just a brief video just showing our production process. So I'm not so sure whether I will manage the protocol of medical professionals, but let me give it a shot. The president of the Association of Surgeons of Uganda, what I have now come to know as ASO, the former president, and all esteemed surgeons and medical professionals present, it is an honor to address such a distinguished gathering of people who I respect, admire, and like. As a young man, a young boy rather, I had a dream of becoming a surgeon. However, along the way, I became drawn to engineering, and then before I knew it, Nature won the day, and I found my home in business. It fills me with immense pride to stand before you at this prestigious Surgeons Conference and exhibition in Uganda. As Dr. Victor has said, we have been part of ASO since we started. And as Managing Director of East African Medical Vitals, we are manufacturers of surgical and examination gloves. We are actually the first surgical gloves factory in Africa. And I want to share just a brief story of our commitment to providing, of how we came to be. Our journey started, most people think we started in 2020 or 2021, but our journey actually started in 2016 when 3 corporate entities, the Legacy Group, which is a multi-business sector business group, a Sigma Capital, an investment advisory firm, and Vaso Investments came together. Vaso is a medical consumables factory, so the 3 came together to hit the call by government for the Ugandan business community to venture into manufacturing in order to develop our economy. After 4 years of a detailed feasibility study and shopping for financing in this difficult market, which I'm sure we all know about, we finally began construction in January of 2020. The start of our project, of course, coincided with the difficult period of the COVID-19 pandemic, which painted a gloom picture about how dependent we are on the global supply chain and on imported goods. The global shortage of gloves highlighted Africa's vulnerability, as we were often relegated to the back of the queue. Rather than discourage us, though, at EMV, this experience increased our resolve to be part of the solution. Most relevant to the forum today, to you, I know, is what we discovered a short while into our project implementation. We were hit with a stark realization that the quality of gloves which are available for Africa, including Uganda, and other were actually paled in comparison to those used in Europe and other developing nations. Our research revealed a disturbing truth that the gloves reaching our healthcare workers do not meet the acceptable quality levels and standards of regulatory bodies in Europe and other developed countries. Of course, this disparity became glaringly evident, more evident during the COVID-19 pandemic. So, shortly after learning about that, our implementation took almost 2 years, delayed significantly by the pandemic, but we remain cognizant of this challenge. Why would gloves fit for use by our surgeons and on our patients in Uganda not be fit for use in Europe? Another important issue which we should all be cognizant of with regards to medical devices is the issue of sterility. There is currently no international accepted sampling criteria for testing sterility. Sterility can only be judged or proven or, supervised by regular auditing of quality systems. International medical device manufacturers are hardly willing to accept regular audits from our very knowledgeable and competent National Drug Authority. I'm actually proud of the National Drug Authority. What the National Drug Authority needs is more companies here for them to audit, because when we see the kind of stringent process they take us through, and when we compare it with some of the factories we have visited which supply gloves to Uganda and Africa, we're actually very, very happy about the work that they're doing. So, and the case is the same in all other African states. So we mostly have to take them at their word. So that's the position we find ourselves in and from which we wanted to emerge. Therefore, at EMV, the first surgical gloves manufacturer in Africa, we're not merely producing gloves so that what was previously available is what we provide. We are building a legacy of quality and safety. Every stage of our production process, from sourcing of raw materials, rigorous quality control, and is guided by an unwavering dedication to excellence. We are driven by a desire to ensure that Ugandan healthcare professionals have access to gloves that meet and even exceed the standards of the European market by constantly improving and tightening our own internal acceptance quality levels. And acceptance quality levels, esteemed members, is basically just the level at which quality defects are acceptable. And what we have now come to understand is that the level of acceptability of quality defects for Uganda and Africa at large is actually higher than that for Europe. So how have we done this? We have not only been certified fully, of course, by NDA, but our ISO certification. We actually had a company in Uganda that was offering us ISO certification in order to try and prove the quality that we are doing internationally beyond just the Ugandan borders. But we are actually now certified by the Lloyd's Register Quality Assurance, a UK-based certifying body. And we have already embarked on a process of obtaining a CE mark certification for our gloves. And that will enable us to be able to supply those gloves to Africa, to Europe, or any donor-funded agency that's available locally. It's very interesting that even when you're supplying the donor-funded agencies, you need to supply them at a level that matches the European quality. So this signifies our adherence to the highest international standards, quality, and safety. But beyond the basics, we appreciate, especially for people in this room, that all who need to wear surgical gloves to perform invasive procedures, and most especially surgeons, in particular, we appreciate that comfort, fit, packaging, ease of donning, etc. are important factors to consider and continue improving on as we progress. We will soon be embarking on a customer survey, and we hope to partner with ASO, which will be looking deeper into these issues. We believe that healthcare professionals observe nothing less than the best, and the patients they serve deserve the safest possible care. Legacy gloves represent our unwavering dedication to this principle, and we are confident that our products will contribute significantly to the advancement of surgical practices and safety for both patients and healthcare professionals in Uganda. I want to extend once again my sincere gratitude to the Association of Surgeons in Uganda and all healthcare professionals present for your continued support and partnership. We are delighted to continue serving the healthcare community. Thank you.
Let's put our hands together for Mr. Brian. Thank you. By the way, East African Medicals has not only supported the conference, they have supported the camps. I think the most recent camp, every health facility we went to got 2 cartons of gloves. Every center got 2 cartons of gloves from East African Medicals. So they have been with us for quite some time, and they have been very good at what they do. So I will invite the president to give a token of appreciation to Mr. Brian. Mr. Brian, please come over.
It is bad manners not to say thank you. In my tribe, they say, itasima.
It will go in here. You still want picture? They want pictures. Thank you very much, Mr. Brian. This is just a reminder. This Asau attire is for you people. So you make the orders at the table. We have surgical capes. We have the scrubs. They are branded with Asau at a fee. So look smart, be smart in Asau attire. You can also take some to Minnesota. Tell them we are around and available. Tell them we have Asau out here. So thank you very much. Christine, I think you will take over. We have someone from CCare. I don't know if he's around. Someone is up. Oh, he's here. So one of our partners today has been CCare since we came on Wednesday, and they have exhibited their work. So I'll welcome Dr. Iga Chirabo to speak to us about what they have to offer at CCare. Thank you.
Ladies and gentlemen, esteemed surgeons, fellow healthcare professionals, I'm honored to be in your presence this afternoon, representing CCare IHK, where I serve as a chief radiologist. And today, I want to first and foremost take a moment to express my deepest admiration, respect, and appreciation for the incredible work that each and every one of you does every day. Your dedication, expertise, and compassion have a profound impact on the lives of countless individuals and families. I would also like to appreciate and extend my sincerest gratitude to the Association of Surgeons of Uganda, the committee, for organizing such a powerful event. Your efforts have brought together the best minds in the field, providing a platform of knowledge for knowledge sharing, collaboration, and growth. Thank you for your tireless efforts in promoting excellence in surgical care. Without wasting time, I would like to bring you to speed to what we're currently having at our hospital, CCare IHK. Media. I think you have you've projected a different presentation. So CCare IHK is a multi-specialist hospital boasting 3 hospitals currently and about 22 specialized clinics all over the country. We at CCare IHK, we have a brand new MRI. It's Siemens Magnetom Altair, and we are able to do very advanced diagnostic imaging, MRCPs, spectroscopies for our surgical cases. We also have a 128 slice scanner. So we've been talking about malignant neoplastic conditions, staging, the usual infectious conditions, trauma comes in handy. We have as well, we have a C-arm for orthopedic, we have a C-arm for orthopedic procedures. Yeah. Yes. Next slide, please. Next slide. This one. Okay. Yeah, so we have a mammogram as well, state of the art for breast imaging. And we've talked about the C-arm for vascular interventions and orthopedic procedures. We also provide interventional radiology for minimally invasive guided procedures, biopsies, and yeah. So when it comes to our surgical equipment, the hospital, we have a holmium laser machine where we are able to provide procedures like lithotripsy, hemorrhoidoplasty, prostate surgery, and a lot of minimally invasive procedures. We also have a laparoscopic tower, and with this we are able to do advanced laparoscopic procedures, all minimally invasive abdominal surgeries, and minimizing the patient stay, patient complications, and also maximizing precision of these procedures. We also have endoscopy suite, an endoscopy suite, providing advanced gastrointestinal endoscopy, ERCP, and C-arm, already mentioned. We have a harmonic generator as well. We have a harmonic generator, which helps us in open surgeries requiring advanced coagulation and all laparoscopic procedures. And at this moment, I would like to call upon all you surgeons to come share this space for your surgeries, to come use this equipment, and to refer your patients. We have a very big team of specialized specialists in surgery. We have urologists, we have neurosurgeons, we have general surgeons, we have gastroenterology surgeons, So we welcome you to come and partner with CCare for your surgical needs and to refer your patients. Let's collaborate for excellence in the surgical care. Visit our booth and let's connect with our team. Thank you so much.
Thank you so much. Thank you, Mr. Kavulu, from East African Medical Vitals and CCare. We really appreciate. I would like to invite the session chairs for our next session, Dr. Flavia Were and Dr. Job Kutesa. Dr. Job Kutesa is around. He's a urologist at Mulago National Referral Hospital. He's also the executive director for Nikao Medical Center. You're most welcome. Our next session is strengthening surgical antimicrobial stewardship and curbing AMR systems in Uganda and Africa at large. I think this is a very important topic for us, right? All right, Dr. Job Kutesa seems to be out of the room, but probably I can go ahead and invite the presenters to join the stage, and hopefully he will find us. Dr. Julia Harrison, kindly come to the stage. Dr. Harvey Lukaya is currently not around, so he will not be able to join us online. Dr. Edith Namakula. Dr. Sheila Watima. I will allow your session chair to introduce all of you, so I don't want to do that job. And Mr. Jonathan Babuya, who is represented by, oh, and yes, one more presenter, Dr. Yakobo Nsobuga. You're most welcome. Kindly let's keep time. Please, when you're told 7 minutes, kindly keep it to that. We'll need to go for our lunch break. Thank you. Hey. Dr. Flavia Were, you're most welcome. I'm very happy to introduce you. Dr. Flavia Were is my cohort mate. Very proud. Very proud of her. She's a general surgeon at Doctors Medical Hospital in Tebe. And she's also a mother. So, yeah, we extend her.
Good afternoon. I hope this is on. Good afternoon. Without further ado, we are going to dive straight into this session. I'm going to invite the first presenter, Dr. Yakobo Nsobuga, who is going to talk to us about surgical site infections in surgical wards at a tertiary care hospital. Dr. Nsobuga, you're most welcome.
Thank you again for yet this other great opportunity to present to the ASO community. Good afternoon to you all. Protocol observed. I will use my time appropriately whenever such a chance arises. Dr. Ruzige was talking about you must step out of the many and show the people what you do. I just want to share something little before my main presentation, especially to my junior colleagues, the medical students who are in this room. First and foremost, ASO, thank you so much for accepting them to be part of this. This is really a great motivation. Through discipline and persistence, that is how people will see you. It was because of this, one of the days previously when I was in main theater, we left at 8:30, a surgeon said, what do you want me to do for you? I said, I've not paid the ASO conference money, paid 400,000 for me. That is why I'm here. And that is why I'm number 2 on that list of payment. I didn't have that money. Thank you so much, I had to say that. Back to the study. A surgical site infection in surgical wards at a tertiary care hospital in northern Uganda. This hospital still, it is our regional referral in Gulu. I'm Yakobo Nsubuga, Brenda, Christine, Fedris, those are colleagues who were medical students by then. This is one of the studies we carried out at undergraduate. Then Dr. Felix Bongomin, I'm sure most of you know him, but particularly on this study, he was a microbiologist. And then Dr. Maurice Ojara is a surgeon, as well as Dr. Derek Amoni in Gulu Regional Referral Hospital. Oftentimes we know the managing director, East African Medicals, has just talked about sterility. Sterility contributes to part of these surgical site infections in the end that we get. So a post-operative patient, particularly here, we refer to that patient, to those patients who were operated and are out of theater found on surgical wards during the time of this study. So surgical site infections are defined according to Owen and Storrell in 2008 as infections occurring up to 30 days after surgery. So in our study, day 1 was the operative day and affecting either the incision or deep tissue at the operation site. So in this study, the background is a surgical site infection can occur after surgery in the part of the body where the surgery took place, whereas it can sometimes be superficial, involving the skin only. Other surgical site infections are more serious and can involve tissues under the skin, organs, or implanted materials. That's according to CDC in 2010. Surgical site infections are a worldwide problem that has far-reaching implications on the patients, leading to morbidity and mortality, as well as significant financial implications. They have an incidence of between 2 to 5%, with an incidence as high as 20% in the colorectal surgery worldwide. That's according to NEL in 2014. It is the 3rd most common nosocomial infections among surgical patients, with up to 38% of nosocomial infections being associated with surgical site infections. In this study, it was a descriptive cross-sectional study that we carried out from June 2023 to June 2024 for a full year. Data was collected, and in this we are determining presence or absence of surgical site infections amongst these respondents. We used the criteria of diagnosing surgical site infections involving infections occurring within 30 days after any operative procedure, where day 1 was the procedure date, and also involving only skin and subcutaneous tissue with prolate drainage from the superficial incision. Discharge from the wound was submitted for bacterial culture in all cases. In addition, the patient must at least present with one of the following signs or symptoms: pain, tenderness, localized swelling, erythema, or heat, according to CDC 2017. Our setting, we went and collected this data from patients who were admitted on the surgical wards of Gulu Regional Referral Hospital in northern Uganda. Our inclusion criteria, we're looking at all cases admitted in surgical ward with various surgical problems, either as elective or emergency cases whose surgical operations were done at Gulu Regional Referral Hospital within the study period and developed wound infection later on. We excluded all patients who were too sick and unable to participate in the study, and also excluded cases of wound infection operated elsewhere, diabetic foot, and abscesses. We collected data using a structured questionnaire that included a lot of demographics and also an observation checklist that was used to diagnose the surgical site infection. This is the observation checklist that we used. It had components like date of event for infection, which occurs within 30 days, whether it was present or absent. If it was present, is it involving only the skin or subcutaneous tissue in the incision? All this was done under supervision of these doctors. Dr. Derek Amon is a general surgeon under Department of Surgery in Guru University. So we were with him on all these cases as they were being done. Another component was whether there was purulent discharge from the superficial incision, whether we identified an organism on culture, opened superficial incision with one of the following, probably tenderness, localized swelling, erythema, and hotness. So some patients had 3 or 4 of those. A diagnosis made by surgical site infection done by a surgeon or other cadre. So in our study, all of these were done by the acting surgeon who was there by then. We received ethical considerations to carry out this study from Guru University Research Ethics Committee and an administrative permission from Guru Regional Referral Hospital. We enrolled 389 patients in this study for 1 year, and 201 cases were operated as elective cases. However, 188 cases as emergency cases. Postoperative wound infections, we got 23 cases, and the overall incidence of infection in that tertiary hospital was 5.9%. The infection rate, it is important to note that in elective cases, we had 7 cases. However, we had more in the emergency cases. What explains that? Probably it is yet to be discussed. Out of 23 cases of overall infected patients, 8 patients developed minor infection or stitch abscess, 15 patients had flank suppression, requiring opening and drainage of the wound. And then it is important, E. coli was the commonest bacteria for wound infection. Yesterday, Dr. Gabriel Okumu was talking about understanding the microbiodata in different regions in the country. It may be E. coli in this region, but probably it could be another one in the other region. Maybe in the east it is different, probably in the West Nile it is different. So this study, we believe, it brought out this information. So this is a pie chart showing distribution of infected cases. You realize 70% of the cases that presented with surgical site infection, they were from emergency cases. Why? Probably maybe the issues involved in preparing these cases. These are cases that really need urgent theater intervention. Maybe the nursing team is not yet ready. Maybe the sterilization of some of the things, it is not yet ready. Probably we have anesthetic issues on board. Maybe some of the things you are going to use, you'll end up not following the real sterile procedure in the view of saving a patient. Probably those are some of the reasons, maybe as to why emergency cases in the end presented with surgical site infections. So this is the graph showing the distribution of what we got as per the laboratory in bacterial observation. E. coli had the highest, and then we had some that didn't really give us any growth, much as we had taken the sample there. So E. coli followed by Klebsiella, Pseudomonas, and Staph aureus, including those that were methicillin resistant. In the conclusions, as per that tertiary hospital, the post-operative wound infection rate was 5.9%. Then the infection was significantly higher in cases that underwent emergency surgery, and E. coli was the commonest pathogen to cause infection. I must acknowledge, lastly, as I'm leaving this platform, for the last time I want to thank again the ASOU community. Thank you so much. I want to thank Guru University Research Ethics Committee for the permissions always granted on our studies, and the entire university at large, particularly the Faculty of Medicine where I was attached by then Guru Regional Referral Hospital. I want to thank once again the motivational meetings we have had thoroughly in the SUJE's meetings. Whenever we meet, sometimes we share with some doctors. They take you, maybe they think you are SH or surgery. Oftentimes I talk with Dr. Mbine, but I know he doesn't understand this man, who he is. I'm here, sir. Thank you so much for those words. Thank you so much. Dr. Jackie, I see you. Thank you so much. I remember the words at A and E, and this is what I've become. I thank Dr. Bongmin Felix. We have been together in all these studies, managing to come out as a PI in 26 ideas on undergraduate level wasn't a simple game. I must thank Dr. Jala Morris, a serving surgeon in Guru Regional Referral Hospital, and Dr. Amone Delik, who is under the Department of Surgery in Guru University. I must not forget where I volunteer always, 2016 up to date. That is Mulago National Referral Hospital. They have been there for me, and I will always be there. Thank you so much. Afoyo Matek, meaning thank you so much in a short version. God bless you.
Thank you very much, Dr. Nsubuga. As we listen to the rest of the presenters, we still have to continue thinking about how we encourage antimicrobial stewardship while balancing it with things like antimicrobial prophylaxis, for example, after surgeries, while at the same time minimizing overuse of antibiotics. Sometimes we prescribe antibiotics unnecessarily, for example, for the so-called clean cases. So let that also be in our minds. Let's listen from our next presenter, Dr. Julia Harrison, about pediatric sepsis. You're welcome.
Good afternoon, everyone. My name is Dr. Julia Harrison. I'm a general surgery resident at the University of Minnesota who's been working with the pediatric surgery team at Malago this year. And I will be talking to you about pediatric sepsis in resource-limited settings and integrative literature review that we're using to implement the surviving sepsis guidelines on the pediatric surgery ward at Malago. So thank you to ASAL for this opportunity. We have no disclosures. Sepsis, as you all probably know, is a leading cause of morbidity and mortality worldwide. There's over 26 million neonates and children affected per year, and 85% of these cases occur in LMICs. Sub-Saharan Africa has the highest age-standardized incidence and mortality of anywhere in the world, and there are peaks in early childhood. Sepsis from surgical pathologies is widely under-recognized outside of surgical specialties, but everyone in this room, I'm sure, has treated sepsis quite frequently, whether it be related to traumatic injuries, neonatal congenital conditions, bowel obstructions, burns, appendicitis, or many other conditions. In 2020, there was an international consensus guideline published on septic shock and sepsis-associated organ dysfunction in children. This represented a major step forward in our understanding and treatment of sepsis. However, it was written irrespective of resource settings, and it was based largely on studies conducted only in high resource settings, even though we know that most sepsis occurs in low resource settings. So this guideline requires adaptation prior to being implemented in settings such as most of Uganda. So our aim with this literature review was to assess the current literature that has been done in resource-limited settings in order to help us adapt these recommendations. Advantages of this integrative review were that we could combine research from different methodologies because there is not a lot of research on this topic and it's a broad topic. Disadvantages are that we were unable to perform qualitative or quantitative analysis of studies results. So we looked into PubMed and African journals online, including articles that were randomized controlled trials, observational studies, guidelines, meta-analyses, and qualitative studies. And then we used a web platform called Rayon that helped us organize our results. Inclusion criteria for articles were research focusing on neonates born at greater than 37 weeks and/or children up to 18 years old, covering one or more of 8 domains, which we took from the 2020 Surviving Sepsis Guidelines. So that's sepsis identification, antibiotic selection and timing and duration, source control, nutrition, resuscitation, including fluid resuscitation, blood product administration, and vasopressor use. We excluded sepsis due strictly to infectious diseases such as malaria and dengue, and then sepsis strictly in immunocompromised populations. So we identified about 2,300 articles via PubMed and about 800 via African Journals Online for initial screening. We screened out about 3,000 of these. We ultimately had 52 full texts that we assessed for eligibility. 44 were from PubMed and 8 were from African Journals Online, and we excluded 24 of these. That left us with 28 full articles to review. 20 were from PubMed, 8 were from African Journals Online. The types of studies we found included 1 randomized controlled trial, 1 meta-analysis, 10 prospective observational studies, 8 retrospective observational studies, 5 cross-sectional studies, and 3 guidelines. You can see that the domains covered in these articles, there was quite some big differences based on domain. So sepsis identification was by far the most commonly studied domain of sepsis. Resuscitation was next, which includes fluid resuscitation. And then antibiotics were another big topic. Things like source control, nutrition in septic patients, blood product administration, and vasopressor use essentially had no primary literature. Years represented, you can see that there were not a lot of articles until about 2016. I think this mostly represents sepsis becoming a concept as like a research concept more than anything else, and more awareness of studying sepsis versus previous articles that might not have named sepsis but might have studied infections or inflammation, things like that. So some synthesis of our findings in terms of research gaps. Most research on pediatric sepsis and LMICs has focused on communicable diseases such as malaria, dengue, and HIV, or early onset neonatal sepsis, which is obstetrics related. Many studies that have been done actually excluded surgical patients. No studies looked specifically at surgical patients. And we suspect that surgical patients differ significantly in their pathophysiology and their optimal management. However, there's not enough data to determine this. So in terms of study types, there was a lack of high-quality prospective studies across the board. There was only 1 randomized controlled trial identified, which is the FEAST trial that looked at fluid resuscitation in children with febrile illness. I should note that these were mostly, their biggest proportion of patients had sepsis from malaria. In terms of sepsis identification, studies have been heavily focused on this topic, over 50% of the articles that we included. This may reflect difficulty in timely diagnosis of sepsis, especially in neonatal and pediatric patients, and especially in resource-limited settings. In terms of antibiotics, studies on antibiotic timing and duration show a high rate of pre-hospital antibiotic use, up to 80%, and also a high rate of resistance to first-line antibiotic in septic patients, so up to around 50%. And this altogether calls for local protocols based on local resistance patterns. There's no primary research examining nutrition, blood product administration, or source control in pediatric septic patients in resource-limited settings. As we know as surgeons, all of these topics are very important to how we treat surgical patients. So in conclusion, there are large research gaps existing across all domains of pediatric sepsis, identification and management in resource-limited settings, especially true for surgical patients, which represents both a major challenge for clinicians, but also an opportunity for improvement. Future directions. So the pediatric surgery ward at Malago Hospital is currently enrolling patients in a prospective cohort study where we are tracking baseline data related to sepsis in our patient population here. We hope to implement the 2020 Surviving Sepsis Campaign guidelines and track changes after that implementation. And we welcome feedback and collaboration on that process. I'd like to say a huge thank you to my collaborator, Dr. Brian Kasaga, and our mentors, Dr. Jennifer Rickard and Dr. Nasser Kakembo, as well as the entire pediatric surgery team at Malago. And these are our funding and acknowledgements. Thank you.
Thank you, Dr. Julia. Our next presenter is Dr. Sheila Watima, talking to us about prevalence of multi-drug resistant UTIs. Thank you.
So all protocol observed, good afternoon. By the name's Watima Sheila, I'm an MMed surgery resident. And I would like to present my research topic on the prevalence of drug-resistant UTIs and the antibiotic sensitivity profiles among males with blood outlet obstruction attending Malago National Referral Hospital. So the co-investigators that I would wish to recognize in this particular study were Dr. Badro Toleko and Dr. Eric Katajira. So those were my operational definitions in my study, with blood outlet obstruction referring to any obstruction at the level of the bladder that will either impede or slow the outflow of urine. And MDR, we are going to look at MDR UTIs. We are referring to infections that are resistant to 3 or more classes of antibiotics. UTI, this will be an infection within the lower urinary tract infection, within the lower urinary tract that will be confirmed on urine culture. So in our introduction, we come to notice that antimicrobial resistance is an escalating global concern. This was, let me say, in reference to WHO 2025. And from the previous speakers, we come to notice that we have escalating conditions of sepsis with an overwhelming concern of AMR occurring. This is actually becoming worse with the escalating, escalating cases of MDR. Those are infections that are resistant to actually 3 or more classes of drugs. The reason is these MDR-related infections become a concern to all pertinent individuals managing managing patients. The reason is your options of management of such patients are actually narrowed, as patients are resistant to several drugs or classes of drugs. And in our setting, UTIs are among the commonest drivers for antibiotic use. And more so, if we are to particularly narrow down to the particular group of our study, patients with blood outlet obstruction, this is worse. Because as we know, these patients have impediment to urine flow. That particular status predisposes them to recurrent infections, and coupled with the presence of indwelling urine catheters, it actually worsens the use of antibiotics, which subsequently contributes to the development of MDR. So in our particular study, we set out to determine the prevalence of MDR UTIs and to also capture the sensitivity profiles among the patients with blood outlet obstruction. This was a study that was carried out in a scope of 3 months. It was a cross-sectional study, and we recruited adults from ages 18 and above. Our inclusion criteria, we are looking at patients who came in with obstructive symptoms. Particularly, there had to be evidence of obstruction that was evident on radiology and voiding CUG. Those that came in with radiological evidence, we particularly considered patients who had had a significant residual urine above 50. Then we also had patients recruited with obvious pyuria. In the exclusion, we eliminated patients who had had a recent history of antibiotic use within 1 week. So from our results, as I mentioned, for the age categories, patients ranged between 18 to 90 years. Our median age in this particular study was our median age was 62.5 years. And most of the patients, predominantly our patients, had BPH as the major etiological cause to their bladder outlet obstruction. And in this particular study, we recruited a small category of patients with indwelling catheters. If you have to look at the records, only 37% of our patients actually had indwelling catheters. So from results still, we recruited 156 participants within the surgical outpatient department. And upon recruitment, these patients actually had urine cultures done, and the analysis was done by the automated backtake system. So the whole culture and sensitivity system was done automatically. 64 out of the 156 participants had confirmed UTIs, and 61% of those with the confirmed UTIs actually came to be diagnosed with MDR UTIs. But since we are looking at an overall prevalence of MDR UTI in our study, we had this calculated as a fraction of those with positive MDR UTI against the entire pool of the population, that is against the 156. So when we did that, our prevalence in the entire study population came to 39.1%. When it came to the etiological organisms isolated, it did not differ from what other studies had identified elsewhere in literature. E. coli was the most predominant isolate identified, followed by Klebsiella pneumoniae. E. coli was actually contributing to about 35% of the, in terms of the distribution of the etiological organisms. So what was so special in our study was with the sensitivity profiles. We come to notice there are some common antibiotic drugs that are people's PED drugs, especially when it comes to urine tract infections, for instance, ciprofloxacin and levofloxacin. But these are drugs that were highly found to be resistant in our study population. For instance, if you are to look at the resistance profile of Cipro against E. coli, it was at 100%, okay? These are some of the empirical drugs we give to our patients, especially in our setting where we do not actually follow up to have culture and sensitivity results done. That similar high resistance was also noted to other beta-lactams like cefuroxime and ceftriaxone. But the good thing from our study, we are able to identify drugs that relatively had a lower resistance profile. For instance, the nitrofurantoin, amikacin, piperacin, and I mentioned meropenem. Those are some of the drugs that were identified to have lower resistance, associated resistance profiles in patients with bladder outlet obstruction. So the question is, what do we make of such a message? The idea is, in our setting, we often rely so highly on empirical treatment vis-a-vis, let me say, the ideal of carrying out cultures. So from these particular results, it clearly indicates to us that as we are offering such empirical therapy, especially with one of our commonest PED drugs like ciprofloxacin and levofloxacin, these are very ineffective drugs in our patients, in this particular risk group of patients. I would suggest maybe patients could initially be initiated on regimens that have shown to have low resistance profiles like nitrofurantoin, maybe amikacin, as we wait for the culture and sensitivity profiles in these patients. So in this particular study, we went ahead to look at some of our markers of resistance so that we try to understand how best we could address the high resistance that was noted in the study participants. So as I mentioned, the analysis was done automatically by the backtake system. We're able to only identify 26 markers out of all the 64 participants with confirmed UTI. this identification was, this particular identification was only noted in 40% of the study participants. This left us with a gap of 60% of the participants. In this particular 60% of patients who had confirmed UTIs, there was no known marker of resistance that was identified. So still, that offers a gap in research. We need to carry out maybe further comprehensive research in the future to actually identify, to streamline the potential markers of resistance in some of our patients. For instance, our particular study was able to identify particular markers like the extended spectrum beta-lactamase and the carbapenemase resistance. But as you know, the fluoroquinolones, their mechanism of resistance is associated with DNA mutations, okay? Maybe future research would be needed in terms of PCR studies so that we can actually quantify how much of the burden it is, since such fluoroquinolones are actually the ones that are associated with a greater magnitude of resistance. So despite the fact that we weren't looking at the factors associated with the risk of MDR, we carried out 2 minutes. We carried out an analysis to somewhat associate, to link any associations with the development of MDR UTIs in our patients. And significantly, two factors were considered significant. That is the presence of someone having an indwelling catheter and the diagnosis of a urethral stricture were some of the factors that were significant. But still, when it came to, those were the two factors that were significantly identified, but an indwelling catheter in particular was one that had a significant p-value. And from this particular conclusion, we came to understand that a patient who has an indwelling catheter actually has 4.6 times an increased risk of developing an MDR UTI compared to someone who doesn't have an indwelling catheter. So I had combined my discussion. I think in conclusion, as I wrap up, we noticed that we have a high prevalence of MDR UTIs in our particular patients. Still, as I mentioned, patients in our particular study indicated a high resistance to commonly used antibiotics. So my message to the team here, probably as we move out here, we need to revise our options in terms of empirical management in patients who are presenting with bladder outlet obstruction. And in the recommendation, I recommended the future research strategies, but still I need to emphasize the need to promote routine diagnostic urine and culture sensitivities. These facilities are available. We are lazy, maybe as clinicians and as patients, to actually follow up on such results, but this is something that I'm empowering us to actually consider. Then the other issue, I wanted to work hand in hand with the ward units so that we could develop maybe local institutional protocols vis-a-vis the national Uganda clinical guidelines that are available. Thank you.
Thank you very much, Dr. Sheila Watima, for that wonderful presentation. I'm sure there are very many questions that will come from that, especially with regards to the current prescriptions that we are giving routinely for people who come with UTIs or bladder outlet obstructions. Our next presenter is Dr. Ampaire Daffin, who is going to talk to us about mapping evidence on antimicrobial resistance in a Ugandan setting. Dr. Ampaire, you're welcome.
Thank you so much. I'm Dr. Ampaire Daffin. I'm a pre-intern. I work in CZ Hospital, and I also volunteer at Barra Regional Referral. I work in very many places. So I also work at Holy Innocents and Barra Heart Institute. Before I start to speak, a few years ago, I found myself in an OR, I was standing beside one of the most skilled pediatric surgeons I've encountered, and he always made small incisions, smart, perfect, and that was in my 3rd year. And he's with us today, Dr. Felix Oyania, and I'm happy to say that he inspired me to become a pediatric surgeon. I am heading to become a pediatric cardiothoracic surgeon. Thank you so much, Dr. Felix, for inspiring the young generation. So this small girl standing here today, I'm alumni Kawale University, and I have so many mentors, Professor James Tumwine, Professor Joy Kwesiga, and so many other people, Dr. Mugara Robert, Dr. Rodney, and Dr. Gamukama, he was also around. And then also Dr. Kasaga Brian, he's here today. Yeah. So as I start to present my work, I worked with Jonathan Babuya, he's MBCHB5, Busitema University, Abbott Abaho, MBCHB5, MAST, as well as Joshua, Barbara, Charles Lugaju is pre-intern from MAST, and Dr. Brian Kasaga. So our work was about antimicrobial resistance. As we all know, it's now a global crisis, and about 4.95 million deaths are associated with antimicrobial resistance, and surgical site infections affect up to 50% of the surgical patients in developing countries. So AMR increases mobility, mortality, and healthcare costs. So in Africa, the SSI incidence after C-sections, we found out that it was 11.9%. This was a scoping review, and many bacterial isolates from SSIs are highly resistant to antibiotics. So antimicrobial resistance, why did we do this study? Why is this study important? Uganda's National Action Plan on AMR provides a framework for AMR control. Then there was lack of consolidated evidence on AMR in surgical care settings, making intervention planning difficult. So our objective was to map the available evidence on AMR in Uganda surgical settings in alignment with NAP AMR. So the methods we used, as I've told you, we did a scoping review, we used Dryan. Our inclusion criteria was studies on AMR in Uganda surgical settings, and our exclusion criteria were studies unrelated to Uganda or surgical care. So the data, we extracted our data, and everything that we are going to talk about is what is showed in that slide: the study type, causative agents, resistant patterns, and alignment with NAP AMR objectives. So from our results, we found out that in the majority of the non-funded information disclosed was from the central Uganda, and then for the northern Uganda, it was also not funded at all. And then the other, so our main causative organisms that we found out were E. coli, Klebsiella pneumoniae, Enterobacter species, Bacillus species, and coagulase negative Staphylococcus. Yeah, then so the major gaps that we have in AMR control in surgical settings are: we have weak surveillance systems for AMR in surgical units. We have limited infection prevention and control efforts. Then we also have inadequate antimicrobial stewardship programs in our settings. We have few studies on sustainable AMR investments in Uganda. Then we have the implications for surgical practice in Uganda are strong surveillance systems needed to monitor AMR in surgical units. We need more effective infection prevention strategies. Then we need strategic antimicrobial stewardship programs for rational antibiotic use. There is need for continuous medical education on AMR awareness for surgeons. Yeah, so those are the same things. As I had told you, I work at Chisizi Hospital, and these are the people I would like to acknowledge. The SOTA Research Group, then Incision Uganda, our chairperson, Incision Uganda, Davis Wanturaki, Dr. Jane Faulola, Dr. Kasaga Brian, Dr. Bua Emmanuel, our Incision Uganda patron, Dr. Mgara Robert, Dr. Paul Matovo, our surgeon at Chisizi Hospital, Dr. Gamuka Mathaise, Dr. Oluka Dennis, our surgeon at Chisizi Hospital and pediatric fellow at MAST, Dr. Teddy Achola, she was supposed to be here, she's a surgeon, and I think she's heading for neurosurgery at MAST. Dr. Mgara Rodney, orthopedic surgeon, Kabale University. Dr. Odong Charles Newton, pediatric surgeon, Soroti University. Dr. Kasaum Julman is currently an associate professor in Ethiopia. And the late Musingus David, my dad. Thank you so much for listening. And as I conclude, I have one thing I want to leave us with. I like Winnie Byanyima so much. So she says, without active citizens, you cannot have responsible government. And in Ecclesiastes chapter 9, verse 11 says, I saw that under the sun, the race is not to the swift, nor the battle to the strong, and neither the bread to the wise, nor wealth to the intelligent, nor favor to the skillful, for time and chance happens to them all. So all of us have the time and the chance. It's according to how we use the time and the chance. Thank you so much for listening. Thank you. For the questions, Brian is going to answer them.
You can still have a seat and answer a few. Thank you very much to all our presenters for this session. At this point, we shall invite any questions from the audience. There are no questions.
No, I have a question.
Yes, please.
I'll just speak really loud. Thank you very much for the wonderful presentations. I think this is a very important topic. My question is actually for the last two speakers about antimicrobial resistance and choice of antibiotics. And my question would be, is there an antibiogram at your hospital? And more importantly, do people know about it? Do people use it to help make better choices on antibiotic use?
Shall take another question?
Okay. Thank you so much, Dr. Sheila, and the young pediatric surgeon in the house, in the making, Dr. Duffin. Yeah, actually worrying. Looking at your findings, what the study found out, like patients are morally they're resistant to all the medications that we are giving them. So my question now comes: so how are we going to handle this? Now we're having a patient walking into you, and you know very well all these drugs you're going to give to them actually are not working, I remember 2 weeks ago I was at urology clinic and I had these patients that done our culture and sensitivity, and actually he was resistant to all the antibiotics except actually imipenem and amikacin. And again, now he had been on IVs. Despite that, the guy is not even responding on treatment. So actually I was perplexed, like I couldn't do much. So I don't know what kind of advice would you give in such a state now? Thank you so much.
You have another question?
Thank you very much. So my question goes to Dr. Daffin. Apparently, my name is Asa Collins, and I'm a med student. So apparently, we've seen antimicrobial resistance rising over time, and perhaps a reason to this might be the attitude we give it. So my question is, have you looked at the attitude of patients and the attitude of also clinicians when you tell them about this, because they play a key factor? Because most of the antibiotics that they've mentioned that patients are resistant to are over-the-counter drugs. So do you assess the attitude that patients, that when you tell a patient that, you know what, don't overtake, because some people get stomachache, amoxicillin, cough, amoxicillin. So have you assessed this attitude during your research? Thank you.
Thank you very much. The last question will go to Dr. Nsubuga. How do you handle patient expectations? For example, if you've had a patient that you've operated on in an emergency setting and they expect a certain antibiotic over another, because we are in an area where patients read up, there is a lot of information online. So if a patient expects maybe coamoxiclav and you're giving them ciprofloxacin, how would you handle that in order to combat surgical site infections? Let the presenters respond to those questions.
So I'll start up with the question of the antibiogram. Okay, I think I'll speak from my experience. I think for Molago per se, I've not had an opportunity of seeing each ward having its maybe peculiar antibiogram that has been maybe pinned somewhere or maybe registered somewhere. I think people work on anecdotal experience or maybe anecdotal experience on which particular antibiotics work for them. But in Uganda per se, we have the Uganda clinical guidelines. In reference to my particular study, there are drugs that are recommended, the nitrofurantoin, the fluoroquinolones, the ceftriaxone. But as mentioned, people in practice have their anecdotal experience, and for that I may not speak much. About Dr. Moge, who had the concern of the high resistance, noted resistance, I think that was the relevance of the study. We wanted to actually pin out this, but it's never too late to get started. Maybe moving forward, we could probably recommend better practice. That's with routine diagnostic urine cultures, but it also comes with other preventive measures on, for instance, in my particular study participants, if we could lessen maybe their duration of chronic catheterization, I feel maybe that would be a necessary way of improving this. Thank you.
Thank you so much for the questions. So I'm going to first talk about also the antibiogram. At Kavale, Professor James had organized this in NICU. We had one. And then for the question about AMR rising over time, attitudes of patients and clinicians, from where I've been working in TC's hospital, for the clinicians, they have actually taken up this. On surgical ward, we do not give a patient antibiotics without a culture and sensitivity. We do not. So we do culture and sensitivity, then we start the patient on antibiotics. And then also we had developed using honey instead of antibiotics. So on wounds, we usually use honey. And then, then for the patients, of course, we cannot control the patients. They will take the drugs even when they are home, even when they do not come to the hospital. They will go to the clinics and take the drugs. But when they come to us, we explain to them. So we do patient education for the patients. Yeah, I hope I've answered my questions. Thank you.
Dr. Nsobuga.
Thank you so much. That's an interesting question. I think the issue of antibiotics, especially at the prescription rate, it is a multi-system approach. Why am I saying so? You realize that different doctors, to what I've seen, practice differently when they are prescribing. For example, there are doctors who give prophylactic antibiotics even when they are not important at some point. There are those who will tell you that at least we must get laboratory bacterial confirmation, and then we start after culture and sensitivity. But to me, in the end, all these would be capped down through continuous medical education, probably a senior person, and it can be an inter-discussion amongst the health workers to guide each other. Realize even some of the doctors practicing on wards, some of them are not yet well versed with what the pharmacist, for example, of that ward is having. There are few surgeons who take an initiative to find out the pharmacist of this ward, what is available. For example, if it is a government facility, very few people go to the pharmacist of that ward to find out which drugs are available. If you could find out those drugs that are available, probably they could give you an idea, maybe in your CME, to educate other health workers on your ward and have proper prescription. In the end, it rotates around sensitization, because one of the greatest challenges we are having currently in patients coming, especially who need those antibiotics, some of them are elites. So someone will say, I need this particular drug. It has been working for me. Another person would say, when I take this drug, I get this side effect. I get an abdominal upset. So in the end, I think it's about more of sensitization. With this, a patient can be brought to notice to know what is right and what is wrong. A patient will appreciate if you give him time and will understand your piece of advice. Then those that go against your piece of advice, I think you'll advise them to take their own path because you can't own them. I think that would be my submission. Thank you.
Thank you very much. Do we have any other questions from the audience? No. Okay. Yes, please.
Thank you so much. Fred Maiso, and my question goes to Dr. Watima. I would like to know from your study, perhaps for the patients who have been confirmed with multi-drug resistant UTIs, did you have any consensus? How long do you treat these particular patients? Is there an agreed that this is the time I treat these particular patients? And I don't know whether you are able to encounter cases whereby someone has been on antibiotics for 3 weeks, perhaps they have been on nitrofurantoin combined with a quinolone. Now they come back, they come to you, you need to switch to something else. Of course, amikacin is being IM or IV, no oral version, unless it is there when I'm not aware. How do you go about those patients? And my main concern is, how long do you treat? When do you choose to stop treating? Thank you.
Thank you for that question. So, for the patients in my study, we were fortunate to identify some that were actually sensitive to drugs like piperacin, meropenem, amikacin, nitrofurantoin. So those were some of the options that we are recommending in such patients. But in particular, to my study patients, we intermittently opt to use intravesical amikacin, okay? And with intravesical amikacin, we recommend like a start dose. We could recommend a start dose, reassess a patient maybe the subsequent week, or we can do depending on let me say, the level of, the initial level of pyuria, and also the clinical presentation of the patient. If they are not significantly septic, just a start dose of intravesical amikacin is adequate. For patients who have obvious urosepsis, those are patients that would warrant admission so that you do parenteral management with the parenteral regimens. Thank you.
Presenters? Yes, one more question from Professor Frank.
Thank you very much. Just a few comments about urinary tract infection. One, not every frequency dysuria, low abdominal pain is urinary tract infection. There's a lot of medicine that is antibiotics being given to people just because they've got urinary tract symptoms, but they may not necessarily be having urinary tract infection. So we must get into the habit of doing the urinalysis and then step it up to doing cultures. Secondly, I think our prescription habits are being guided largely, and with all due respect to the people who are sponsoring us, are largely based on who has given you the most latest CME, or has sponsored, which drug company has just sponsored the most recent ASO conference. We must find strength in us to treat by the findings on culture and less by, I was told this drug is the best and therefore I give it. And many of us either head units or own units. Let's make culture and sensitivity routine. Thank you.
Thank you very much, Professor Simwe. I think if there are any further questions, they will be directed to the presenters in other sessions. Thank you very much to our presenters for this session. We have come to the end of this session. Thank you very much. It's lunchtime. Yes, let's have a photo, group photo. Let's have the president in the group photo, Professor Galukande.
I was looking for Iga for the group photo.
All right, thank you so much. A round of applause for our AMR panelists. Yeah, according to our program, it's about 13 hours, but in real time, it's 14 hours. So it's lunch break. We are going to break off for lunch, and we'll kindly pick our coupons from Immaculate at the desk, because we have a tight program after lunch. Lunch is exactly 45 minutes. So as you have lunch, take note of the time. We shall be moving around the table so that we are back in time for the afternoon session. So kindly pick your coupons and let's interact. I know surgeons, when they meet to interact, they say, I entered the abdomen, I found, weird saying. You entered the abdomen, you found a frozen abdomen, you explored, let's interact, let us network and, have further discussions. Yeah. May God bless our lunch. Thank you.
So we are going to go ahead with our next session. In this session, we have guests from the NSSF Financial Literacy Program who are here to speak to us. And I would like to invite them to take on the next session. Thank you.
Good afternoon, ladies and gentlemen. I'm waiting to get people's attention. Good afternoon, ladies and gentlemen. Thank you. My name is Ana Maria Sanyu. I work at the NSSF in a very beautiful section called Financial Literacy. What we do is we talk about money, and usually we talk about money that doesn't come to NSSF. We talk about the money that you have in your pockets. And today we were invited to do the same. But before I invite the speaker for the day, I would like to talk about NSSF just a little bit. I know some of you must be knowing about NSSF, and some might be maybe they just hear about NSSF. So NSSF is mandated to collect and invest funds on behalf of its members, and its members are people that are in employment, active employment. Since 2022, everyone who is employed is bound to pay NSSF legally, unless you're employed illegally. So if you're employed legally, you're bound to make a contribution to NSSF, and that money is supposed to support you when you are retired or when you reach 55 years of age. The other thing about NSSF that I would like to talk about is its voluntary product, which is about allowing members or anyone else in Uganda to start saving for themselves. The product is called Smart Life Flexi. You can download the NSSF app, and then you'll be able to register and make your contribution using mobile money or the bank. The bank currently is Stanbic Bank, or you can use Stanbic Bank FlexiPay system. You can start from as low as 5,000, but today we are with surgeons. I don't think they can start with 5,000. So you can start with as high as 1 million, since I'm speaking to surgeons. But we take any money from 5,000 and more. You can contribute any day you want, anytime you want, and anywhere you want. Your money will be earning interest on a daily, but credited on your account once a month. So, after all that is said and done, I would like to introduce the speaker for the day. So, our speaker today is Mr. Francis Kamlegia. Francis Kamlegia once worked with Pricewaterhouse, and I like the fact that he doesn't want to be called former, so I'll stick to his current positions. And one of his exciting current positions, currently, he is the newly appointed non-executive director for MTN. But other than that, and other than the many boards that he sits on, I'd like to speak about his other work. He is the executive director and founder of Masaka School of Deaf. He's a farmer. He does coffee, he does fish farming, among other investments. He has an exciting story, and he has a lot to talk about money and to offer. Ladies and gentlemen, please welcome Francis.
Thank you, Maria, for the introduction. Good afternoon, doctors, professors, surgeons, but most importantly, ladies and gentlemen, it's an honor to be invited to share with you both personal experience and some knowledge about finance, personal financial planning, as well as a topic I was speaking at yesterday at a Rotary conference was about retirement and talking to young people how important it is to start early planning for that. But then again, contradicted myself completely by saying that retirement is something that came from the people who colonized us, and they put us into certain structures in terms of when we should work, so that there is a pipeline of a certain generation which works and then goes. But it's very unlikely that you will retire, but what's going to happen is that you are going to change careers, the different roles that you do in your work life. Even when you think about it right now, you may start off as a general practitioner, then you become a very specialist in terms of some surgeons or whatever it is. Then eventually you go into consulting, then you might even go into academics, and you just continue and continue. You never will be doing the same thing for so long because of the nature of your profession. But the English word retirement, when you check the Webster dictionary, defines it as stopping to do something. I don't think as a medical practitioner or physician you'll ever want to stop doing that. It even talks about receding, which is backward looking. So I always explain that I'm not retired, but I redeployed myself to do other things, transitioned out of what I was doing to something else. And that transition requires one to have a financial plan. And I'm going to be talking to you about that. But let me start with giving some free advice. Among the various non-executive roles that I currently have, I'm a board member of Nakasero Hospital. And I've been working with my technical team, and I think through the Uganda Medical Practitioners Association, if that's the right name of the organization, to deal with a matter that had been raised by the Uganda Revenue Authority about the tax treatment of consultants, medical consultants in particular. And I'm pleased to say that as of now, we've gotten a ruling from the Tax Appeals Tribunal that private medical practitioners who are not employees of hospitals, as in being on their payroll, but they go in on a need basis, running clinics as and when needed based on the arrangement they have with the hospital, are not employees, but they are self-employed people. And as a result of that, if you fall in that category, the expectation is that the hospital would deduct 6% from what they pay you as a consultant. That 6%, unfortunately, is not the final tax. The expectation is that you should be filing your own return and declare your income from all the other businesses that you run, and then the 6% is considered to be an advance tax and withheld from whatever you should be paying. I thought I would share that. My most recent full-time job was tax consultancy. That is something I did in PricewaterhouseCoopers for 27 years in England, in Kenya, and in Uganda. I've tried to get away from it, but it's very difficult to get away from it. So that is something that I thought I should share. Secondly, let me also put forward my appeal. I set up Masaka School for the Deaf 20 years ago in 2005. It's a very long story why I set it up, very personal to me, but on Saturday we celebrated 20 years of that school. In the 20 years the school has been running, we've provided education, primary education, numeracy, literacy, and vocational skills training to 1,262 deaf children. The people who joined us in 2005 at the age of, say, 8 or 12, and now youth or young, even young adults, youth of 30 plus years. At our reunion, we had 37 of them who came back, and the testimonies they shared were very, very powerful. One of the challenges we've had is how to deal with the hearing impairment, in the sense that you can get people giving you hearing aids, but you cannot just give people who with different degrees of hearing impairments the same hearing aids. Just like you cannot just give anybody the same spectacles without checking their eyes properly. We've been very successful in providing education, in skills training, and creating the right environment for those children to thrive and succeed. The one area we are struggling with is the medical and clinical aspect of it. So I would welcome any support of any kind, and it's always best to first visit and see what we're doing and get a feel of the setting and the children that we're working with. And then thereafter, you work with the people around the institution to see how we can partner to support those young children to improve the quality of their life. A lot of them, and medical practitioners, you know this, based on our statistics, only 5% are born deaf, what you'd call congenitally deaf. Almost 40% lose their hearing between the age of 4 and 8, 10, 12. And again, the usual suspects: measles, malaria, mumps, meningitis, and then quite a number also eventually lose their hearing, just like we lose our sight, although we never think about it that way. When we wear glasses, we never think about the fact that actually our sight is deteriorating as we age. But for hearing, we consider it to be a disability. But the deaf people have a very unique and interesting culture. They have their own language, and that alone means if you come to our school, which currently has 122 deaf learners, you will feel very strange because they have their own language and you'll not be able to communicate. But they are very, very good at integrating foreigners who don't understand their language into their culture by trying as much as possible to teach them sign language. Okay, I couldn't miss this opportunity to share that in the presence of eminent physicians and surgeons. So the subject was financial literacy. I broadened it to financial planning, personal financial planning. I've got some talking points which I'll share. There are 3 pages. I didn't prepare a presentation. I'm actually stepping in for somebody who I'm told traveled on very short notice. It worked out really well for me because I'm already speaking at an event here at 5 p.m. And also the subject I was asked to speak to, I spoke at a Rotary conference yesterday, so there was not a lot that I had to do to step in on behalf of my very good friends, NSSF. So, financial literacy. There are 5 things that I want to start off with when it comes to managing one's finances. And what I'm talking about here is not finance, it's not accounting, it's not something that is very unique to financially trained people, but we all know. But I'm just going to help you to put some structure to it. So you all work and then earn from the work that you do. And that is what we call income. So whatever it is that you earn as a consultant, as an employee, as somebody who owns property and collects rent, as somebody who has a fleet of motor vehicles, or whatever it is that you apply and do to earn money, the starting point is income. Now, when you earn, you then have 3 different ways you can deal with that money. You spend it, and we all spend money. You know, when you look around, you can see almost everything that is around has been as a result of money spent. Your very nice tie, you know, the jacket, the shoes, the whatevers, you know, going to the salon, you know, all that is spending. Yeah. And it's always important that you should spend the money you have, because when you start spending money that is not yours, that's then we get into very different complications eventually. So you earn and then you spend. Now, problem is some people spend everything, and now where that's where the problem comes. You earn 100 and you spend 100. In fact, when you earn 100, I chair a board of a bank. It's I&M Bank, and our business is actually to lend money. We look at you and your potential income and your credit worthiness, and then we lend you money. We even lend you money based on your income and future earnings. So it's possible that you may be earning 100, and then the bank looks at your regular earnings and says, whereas you only earn 100, we believe you are worthy 1,000 in terms of credit worthiness. And then the bank will give you 1,000. So suddenly now somebody who's earning 100 and spending 100 starts spending 500, which is way, way above what you're earning. And you get into that lifestyle. And if things go sour, there can be huge, huge problems. So rule of the thumb or best advice is do not spend everything that you earn. Save. Now, when it comes to saving, the question is, how much should I save? The other question is, what am I saving for? Very often, you may not know what you're saving for until you find reason to have saved. And by that time, it is late because you spent everything. So you don't need a reason to save. You should just save, because saving is paying yourself. But also, because I don't believe in the concept of retirement, I believe that we'll continue being gainfully employed in different capacities throughout our lifetime. And as a result, it means we are going to have a very long life. The doctors will know better that when a child is born today and they say the life expectancy is 67 years, it does not mean that at 67 that child will die. I was born in 1967. Life expectancy back then was 48 years. So technically, I should have died 10 years ago because I'm 58 now. But I didn't die. And actually, I'm doing everything that my physician and nutritionists and gym instructor and everyone is telling me, so that I can hang around for at least another 30 years, because there are lots of things I want to do. And if I make it, I'll have exceeded expectations of so many of my ancestors who didn't make it to 80, and I really hope I'll do that. But it's one thing watching your diet and going to the gym and doing all the exercise and really having a very healthy lifestyle. It's another thing having a financial plan for that lifestyle, because it can be very, very sad and frustrating and not so good if you're old and you're poor. Having worked for over 30, 40 years as a very, very successful physician and surgeon, but you have nothing to show for it. So you earn, you spend some, but most importantly, you save. And I was very fortunate that at a very early age, nearly 35 or so years ago, when I had started my formal professional training, I attended a course that taught us so many things, but the one thing that stayed with me was the formula to save, and also inculcated me the habit of saving. And this gentleman told us that you get your age, divide it by 2, and the number you get is the percentage of your income you should always aim to save. It was many, many years ago. I think I was about 25 years, and I was living in England, and I was saving because I wanted to buy property. I saw I was paying a lot of money in rent, and the person I was paying the rent was actually using about 50 or 45% of what I was paying in rent to pay the mortgage, and the rest was his for keeps. So I started saving at a very, very early age, and it stayed with me. But also what then also proved that to be right is when I look at the NSSF law, which says the company contributes 10% and the employee contributes 5%. So if you are 30, divide 30 by 2, that's 15%. It means already NSSF is taking care of you at that age. But if you have the capacity to save more, you should. Because if you're 40 and you want to transition out of your very, very busy life of being a surgeon at the age of, say, 65 and do other things, because there's so much more that you can do, and most likely you want to do, other than running clinics in very, very busy A&Es and whatever it is that keeps you busy. But most importantly, you want to have the lifestyle that you've been used to and you deserve for somebody who has worked for so many years and also very highly trained. Then you need to have what you'd call a nest of savings, which the financial planning people say should be equivalent to about 70% of what you've been earning for you to continue with your lifestyle. So if currently, to maintain your lifestyle, you need, say, 10 million shillings a month, by the time you get to 65, 70, you shouldn't need that much, because school fees should have been cleared. A lot of the obligations in terms of debt and rent, mortgages should have been paid off by that time. But most importantly, if you've invested, and that was the third step in terms of finance, you should have assets that at that point in time generating income for you. So the 5 steps: work, you earn. When you earn, spend, because you need to make sure that you have all the creature comforts as somebody who is earning a living. But most importantly, save. And if you save at least 20, not 20, if you save a number which is equivalent to your age. So if you are 50 and you're starting saving at that age, that is a bit late, but it's better late than never. The idea then is that you don't have so much time to accumulate the kind of funds and finance you need for you to live comfortably from the age of 70 onwards, because however good you are as a surgeon, the truth is, at a certain age, even hospitals and all sorts of other medical establishments, even if you have your own private clinic, there are young people who are coming in, there's a lot of technology coming in, there are lots of things that are happening which might sideline you, and without necessarily saying that you're an old man, old woman, move on the side, but that's just the way society moves and technology moves and services move, and that is okay, because you will have prepared yourself for that transition. So earn, spend, don't spend everything, save some, save as much as you can, afford to save, but most importantly, invest. So saving and investment are 2 different things. There is a certain time period in your life when you can afford to be very aggressive and very high risk in terms of investments. And looking around this room, a lot of you might even be in that age bracket. Please invest wisely, invest having consulted with the experts who understand those different investment products. Then when you get to a more advanced age where you want to be seen to be risk averse because of the things that can go wrong, and I say that should be from maybe 60 or even 55, because NSSF helps you to save until 55, and then 55 you can withdraw that money. If you've been a surgeon for the last so many years and then you can take your money from NSSF at 55 and suddenly you start venturing into real estate, I think that could be dangerous, because real estate is not something you do as a hobby. Maybe there are those people who do it as a hobby, but it actually is a proper business. And if you think it's the right time to start doing that, that's okay. The only thing is that if you're using your own savings to build property, if you spend 1 billion shillings to build a block of 10 flats in Nigeria, it's possible, and it can cost up to 1 billion shillings, depending on the kind of finishing that you want and also the location and price of the land. A 2-bedroom flat in Nigeria, you'll be lucky if you collect maybe 1.5 million shillings. So 1.5 million shillings times 10 is 15. 15 million shillings times 12 months, that's 180 million, I think. So that means you've spent your own 1 billion shillings and you're going to be collecting 180 million every year. So it's going to take you 8 years to get your money back, your own money back. Yeah. And remember, your 1 billion shillings from NSSF was meant to be the money that takes care of you now in your next 30 years, if you're going to live up to 85 or 90. So it may not be the best way to deal with our savings, but if you are 35, 40, 27, it makes sense to go to the bank, even 50, 55, and borrow, and then add on your savings and develop property, so that on one hand you have a liability of 1 billion shillings, of which maybe your equity is 300 and the bank's is 700. So you're using other people's money, what we call OPM. And it's okay to pay the bank at an interest rate of 16%, 18%, 20%, whatever it is, and pay them for 10, 15 years. And then after paying off that debt, the entire property is yours. So it's good to do it at an early age for those who are in formal employment, but those who are in the business of real estate, again, it's a different ballgame. So there are so many products on the market, locally and internationally, that you may wish to consider in terms of investment, because there comes a point in life when it's not about how many land titles you have, but it's how much liquid cash you have, or at least you have access to. So if you have equities that are tradable, government securities, bonds, shares, you name it, and you can convert them into cash, say, in a week's time or so, that is a better position to be in as you transition into the later years of your career. Because, God forbid, if somebody were to tell me now, a surgeon from this room, tell me that I needed kidney transplant or triple heart bypass or one of those really complicated things, and before even anyone looks at you, you need to put $20,000 on the table as they're exploring and doing more research and investigation. And then I start saying, oh, I now need to go back to Masaka and put my coffee farm on the sale and look for buyers. That even can fasten the process of your demise as a result of that. So it's really, really important that, ladies and gentlemen, as we advance in our careers and also in our age, we have access to liquid assets, not necessarily cash, but liquid assets that you can easily convert into cash. So I've talked about earning, which is income. I've talked about spending, saving, very, very important. And you don't need a reason to save, because the time when you wish you had saved some money and you don't have it, you'll be in a very, very difficult position. Then I've talked about investment. Saving and investment are very, very different things. But most importantly, again, I now say this using my own profile as a senior citizen, you also need to protect your assets. And protection, here we are talking about insurance, whether it's medical insurance for your own personal protection, or insurance as we know it in terms of protecting your assets. Because it doesn't make sense taking your entire savings from NSSF, building a block of flats in Buate, and then with these floods that we're seeing, water comes and washes away part of the perimeter wall, and then the tenants move out because now they're not feeling safe and secure in that property, and your property was not insured. So it's very, very important that you have insurance, and medical insurance in particular for senior people, because there are so many unknown and uncertainties, but I know that insurance works. So let me then talk very briefly about retirement, because it is a topic that has come up quite often. And I start off by saying that I personally, I like using my own example, because if they call me retired, I kind of give retirement a bad name. So I'm not retired. All I did was to decide to transition out of a career, a very, very successful career in the world's biggest professional services firm, where I had served for 27 years. And I wanted to do other things. And I did not want to wait until 65 to do those things. But most importantly, I also wanted to transition on my own terms. It's very, very good as a professional to transition and go and do your own things on your own terms, as opposed to the government telling you, Dr. So-and-so, you are now 65, this is not personal, but you are old. And for that matter, please pack up your bags and leave. Yeah? And then suddenly you start wondering, what's happened to you. Yeah? So the life expectancy, the longevity that we're going to enjoy due to very good medical services, very good lifestyle that we have, the middle class that I see around this room, means that you are going to have a long life, and it's very important that you have a financial plan for that life. And nobody owes you anything as far as personal finance is concerned. Anybody who owes you anything, they give it to you at the end of every month. And they pay you, and thereafter, they expect you to take care of yourself. So for me, personal financial planning is more than just about money. It is planning for your life. It is about managing your money, but most importantly, it's about being in control of what I've explained as the 5 key aspects of your finances, namely income, spending, saving, investing, and protection. Usually, what helps with this kind of conversation is to make it personal and get people to internalize it, because it's very easy for professionals, medical professionals, to say, but I'm not a finance expert, I don't understand those things to do with money. And an engineer saying, but those things are for accountants, and I don't understand those things. And that's why I always find myself in debt, or I find myself that the money is paid to me, but at the end of the month, I have nothing to show for it. So I simplify it by asking a question, and that question is a very simple one, and it's very direct, and you don't need to answer it, but you can reflect on it. And the question is, why do you work? Now, for professionals, I've been told I practice. I asked that question to architects, and they said, they are professionals, they practice architecture. Is that the right word? And the lawyers also, they practice law. I says, that's a long, you've been practicing all these many years. At what point will you stop practicing and start working? Yeah, but that is the term that is used in the profession. But most importantly, you do not work for money. Yeah? For you guys, it's a vocation, it's a calling, but still, we know very well, very medical establishments, before you pay the consultancy fee, nobody is going to spend time with you. Even in some cases where situations are very difficult and very emotional and very complicated, still they will commiserate with you, but still you have to pay before either you are discharged, or in the very unlikely event that the life was not saved, still money has to be paid. So, and we understand that, and I need actually to even to disclose this. So I'm a board member of a hospital, I'm a board member of an insurance company, I'm a board member of a bank. So it all, and I'm a board member of a telecoms company. So it is, and I'm not speaking to any one of them, but I understand how things work, and that's the way it is, and that's the way it should be. The important thing is we need to take care of ourselves, and there are so many different ways we can take care of ourselves. And we're not that badly off and that needy as people in our villages. So you do not work for money. Money most likely will not buy you freedom, but money as an enabler can actually bring access to a lot of these things that we all desire as human beings. So if money cannot buy you happiness, I believe it can buy you the key to happiness, depending on what that key is and what makes you happy. But most importantly, what you want and you should desire is financial freedom. Financial freedom and financial autonomy comes from you managing your money very well. You manage your money by spending less than you earn. You spend less by desiring less, because very, very often, especially the young people, we find ourselves spending money on things actually that we don't even need. But we're buying them simply because our neighbor or our friend or somebody that we know has something and we want it immediately. And in fact, only we don't even want the one that he has. We want something bigger, newer, shiner, more fast, more whatever. And you then find them even posting it, having acquired it, to tell the world that they've got it. It just shows you that actually nobody cares. Yeah? Nobody cares. Anytime you find yourself having to tell people what you have so that you can get approval, it's a bit sad, yeah? Because nobody cares. Everybody has their own rat race. So you desire less, it means you'll spend less. When you spend less, it means you'll save more. When you save more, it means you'll be more in control of your own finances. And you can even afford to be selective and tell this hospital that I cannot work with you unless you're willing to pay me so much. Because as far as you're concerned, you offer a premium quality service, and you're not commoditizing yourself as a very specialist surgeon, and you're not that desperate to work anywhere in whatever conditions, and you build a brand around that. And come 58, 62, you'll be surprised. Everyone will be looking for you, because now that is the phase where you are no longer working to earn a living, but you are in a phase where you are financially stable, independent, and secure. But most importantly, you have a lot to offer as an individual. And for me, I define that as a phase of life where you've transcended from success to significance. And when you move into that space, now you can explain to anybody why you existed. Because at the end of the day, that's what matters. Anything that you do for yourself and ends with you means that there will never be any evidence that you ever existed. But the things that you do for the world, the society, humanity, and they stay after you, that is the most important thing. Because whatever it is that we have, your skills, your knowledge, is not for you to keep, it's for you to use as a steward, through which God blessed you with the knowledge and resources and network to serve humanity. And I can't think of better people who serve humanity, God's beings, than the surgeons. I thank you very much for listening to me, and happy to stay and take questions. Thank you so much. I'll be guided by the incoming president, outgoing president.
So I would like to invite our president, Professor Galukande, to give a vote of thanks for the talk for our speaker.
Thank you very much. I'm wondering why we didn't invite you 10 years ago. So I'll allow for 2 questions, two burning questions. Any questions? Yes. Yes, Dr. Olivia Chituka and Victor Chigonya. That would be it, I think. Please go ahead with the question.
Thank you. Thank you, Mr. Kamblega, for the great talk. And we are glad that we had you today. It has been a South plan to always have such talks, but thank you for setting the ball rolling. These are very important talks we should be having. Actually, these talks should start in primary school, not when you start feeling the pressure. Anyway, my question is about saving and investing. You seem to be supporting more saving, and the finance, the gymnastics of finance tend to tell us that if you just keep money there and it's doing nothing, it is actually losing value. I had started believing so until you came today. It means you are confusing me now. Because I want to invest the money, I don't want to keep it. And I've been listening to a number of very successful business people. Of course, YouTube has a number of those videos. And they tell you that actually their net worth is actually not cash. It is actually what they have. If they just woke up one day and turned what they have into cash, they will be the richest people in the world. Most times when they tell us the very rich people in the world, we think he has a very fat bank account, but most times it's what he has that can translate into cash at that time. So I just wanted you to help me now come to your side of saving more. I used to be there and I had started going away. Now I'm not yet halfway, you are bringing me back. Thank you.
Dr. Chituka.
Thank you, Mr. Kamlegia, for that very enlightening talk. I would like to, first of all, maybe I don't know if it's an ask or a comment, but when you talk about saving and what you earn, I think we also have to bear in mind how much we earn. Many people probably think doctors earn much more than we actually earn. We probably earn very little. And we are most likely caught up in the race of just surviving, as in what you earn does not give you the basic. So what is your comment about that? Does it mean you have to really lower your standard to a point? I don't know. Because if you can't cover basics, that becomes another thing. And then the other comment I have is whereby it's a kind of phenomenon that's happening as we get older, and you made a comment about you're no longer paying fees, and you need less money to live in a sense. But there's a phenomenon of our children who you educate and educate. They finish their undergrad, their first degree, you pay for a master's, then you have stay-at-home adult children. That is becoming one of the scenarios that's coming in, and the children are now still, they are full adults, but they are still relying on you. So what's your comment about that? Thank you.
All right. Yes.
Okay, so thank you very much for the questions. So let me start with Dr. Chigonya. Actually, your point is very valid and can be very confusing, and I need to explain that the portfolio of your financial planning has to include both savings and investments. Even when it comes to investments, you also have to consider both fixed assets, land, buildings, and liquid assets, bonds, shares, and cash. Now, I'm not in any way saying that you should not invest. In fact, if you recall, my 5 steps was you earn, that is income, then you spend, and again, this also kind of addresses Dr. Kituka's point, that when it comes to spending, when it comes to earning, the moment you decide that regardless of how much or how little you earn, you save something, then that becomes just a habit. Because to be honest with you, I don't know how much is enough. And in fact, one of the challenges we have as human beings and individuals is that we never define what is our enough. And I talked about that also, that if ever, when you look around and you see somebody has something bigger, nicer, newer, you know, this person was 3 years behind you in medical school, even you taught them, you've seen them, and then suddenly they're wherever they are, then you start creating peer pressure on you, which even never existed before you saw them, and then suddenly you start realizing that you've underachieved, yet actually yesterday you were okay, and then you go and start committing yourself to do things that you don't need, you can't afford, and actually nobody cares about them until you tell them that that thing is mine. And then they say, oh, well done, and then they move on. I said, you guys, didn't you hear what I said? That is my thing. I said, yeah, it's okay. And they move on. And when it comes to the end of the month and the bank is writing to you very threatening letters, none of your friends care. So very, very important to save, regardless of how much you earn, to make it a habit by spending less than what you earn. Don't spend everything. And again, you know, look for opportunities where you can earn more, because you deserve more. You shouldn't accept a situation where you feel underappreciated, and then as a result, you're compromising on one or two things. But going back to Dr. Chigonya, the idea is you should invest, but invest in assets that generate income. You should invest in assets that will also appreciate in capital. So between the age of, say, 35 and 40, 55, I think that's a very good space to be as adventurous and as aggressive, of course, within your risk appetite as possible, and do everything that you think you can within your own control to invest as much as you can, not simply to be seen to have stuff, but actually invest with a view of assets generating income in the future. My point is, at 65 and above, you need more access to liquid cash than having 13 land titles in Usunju, in Kabera Maido, in Liantonde, because the young children which Dr. Kitoka is talking about, a lot of those young Gen Zs do not care about your square mile in Liantonde. But you have got so much emotional attachment to it that you don't want to sell it. But actually, if you sold it and you bought a treasury bond, or you bought shares in JP Morgan Chase, or you put it on a high interest income account in Mauritius or Kenya or wherever, Dubai, that is money. So for me right now, a return of 5% per annum, I'm okay with it if it's on hard currency, as opposed to a return of 12% on real estate. But it changes with age and risk appetite. So Dr. Chigaunya, please invest, but you need to do your balance sheet, and this is not finance and accounting. For every loan that you have, which is a liability, there should be a corresponding asset on the other side. But if you've got 100 million shillings from the bank and you don't have anything to show for it, that is very unfortunate, because it means you've actually not invested, but actually you have a debt. So as you progress in life and in age, the portfolio changes. But investment, it's actually investments that generate the passive income. So you start off by saving, and then if you save maybe 30 million, you can now borrow 70 million, and now you have 100 million, and then you invest. Now when you invest 100 million, it generates income for you, you pay off the debt, and later on you have an asset which has also accumulated in capital. As for stay-home children, many of us are in that situation. I think as parents, especially our generation of parents, number one, we also need to have a one-on-one with our children, because they are not as materialistic as we are. And that's the beauty with them. So they won't go and buy property because, number one, they can't afford it, but also, two, they are okay with staying at home for some time until they are able to go and fend for themselves. But the last thing you want is for you to get to the age of 68, 72, and you're saying, I never did A, B, C, D, E, F, G because of children, yet suddenly that child is now 36, and he has a very successful career in Singapore and is not interested in Uganda because, as far as she's concerned, she's a global citizen. So between 22 and 28, may take a bit of time for them to stabilize and settle, but I can assure you they will not be in your home at 40. And most importantly, we become so westernized, they'll be lucky if you are 78 and they are 42 and they are coming to stay with you as we used to do with our grandchildren. It's sad, but that's the reality. So in Luganda, Toeri and Jaulo, there must be something you do for yourself, and do it because you deserve it. And if you don't do it now, it's very unlikely that you'll do it at 78. I don't know what it is, but you need to know it because it's your life. Thanks, Prof.
Thank you very much. Another hand clap again. That's amazing wisdom. I picked that this wisdom is not, it doesn't apply to everyone the same way. Different stages of life, different dimensions and magnitude of the pills you have dispensed. So thank you very much. We appreciate your time. Yeah. All right, I think we're going to do the last bit of this session, and we get into the AGM. So is Dr. Mukasa here? Yes, Dr. Mukasa, are you ready to give us advocacy, diplomacy in surgical care? I'm not introducing him again because we've seen him like 20 times already. He's done a good job before. I am sure he's going to do a good job now.
Thank you, Chair. I'm bringing my computer because, as stated, my vision is failing. And I can't even see from the computer down there. Okay, this is after lunch, so I'll try not to bore you. I was asked to give a talk about advocacy. Where is the pointer? Okay, it's here. Advocacy and diplomacy in global surgery or surgical care. Advocacy and global health diplomacy is a pillar of global surgery. Global surgery has advocacy, diplomacy, policy formulation and implementation. That's health policy formulation and implementation. It has service delivery, health service delivery. It has education and training, and it has research. Those are usually the pillars of global, what we call global surgery. Now, diplomacy is a form of advocacy, and usually it's a formal way of let's stay that for now. So basically, advocacy and diplomacy is the same thing. You're trying to convince another person to do or to side with you or to join you in what you're doing. And diplomacy, normally we deploy diplomacy whenever we engage in intergovernmental platforms or with governments. We also employ diplomacy when we're speaking with partners, but we must also employ diplomacy indeed in our day-to-day discussions. It's an art of talking nicely about difficult things. A diplomat can talk about things in a very nice way. For example, I can give an example. The Ukrainians and Russians can diplomatically talk. The diplomats can discuss, even when their governments are at war. So you have to learn, and communication and engagement with people is always not an easy thing. And so you have to learn how to speak honestly, frankly, about difficult things using the right words and the right approaches. But of course, there is a way to do it as well. You've heard many times people say that if you wanted to meet the president, for example, or the chair of this session, or the incoming president, it may be easy for you to meet him in the corridor, or during lunch, or in the supermarket, than going to his office to talk to him, isn't it? We all know that's true. And usually, even in advocacy and diplomacy, we do the work outside the formal structures. That picture was when I was urging the World Health Assembly to adopt Resolution 6815. But the diplomatic engagements that I had to do as chair for the 194 countries involved me talking to the different diplomats outside the WHO, during drink-ups, during exercises. So it's an art. So today I'm going to talk, and I'm going to fuse the two. I will talk more about advocacy because, again, like I said, sometimes most people don't have a lot of opportunities to do the formal diplomacy that we know. So I will talk more about advocacy because that's probably what people want to know. The people always ask, how can I be an advocate? How can I advocate for this thing? How can I talk about improving surgical care in my hometown, in my province, in my country, and things like that? But the advocacy I'm talking about is not activism. So I'm not talking demonstrations, because there's only so much that you can do. There's a specific group that can do that. Well, you as professionals, we don't expect you to get to that stage. It's unethical, and of course, there's a lot of other things that just doesn't allow it. So you have to advocate. You have to learn how to speak properly and nicely, like you did. For example, you brought the permanent secretary here, the minister came here, the representative of the Speaker of the National Assembly was here. That's advocacy. You bring them to your forum, you discuss and engage with them about your issues, away from their office, away from the cloud of security. They are human beings, so they understand what you're talking about. They see your side of things, and then they can also explain how things are on their side. Again, before I go into the details, because the lecture will have a lot of written stuff, the PS here clearly showed us how you can help her work with you, isn't it? She said, prepare the documents, bring it to us, make sure that you bring it sooner so that it's aligned with the other policies that are in place. Because if it comes later, I can't get it there. Even if I want to do it, I can't. Because yes, there are gateways, there are opportunities, and there's a way you can do the diplomacy. So we'll go into the details of that as we go in the lecture. Now, of course, why do we advocate? Why should we advocate for improved surgical care, perioperative care in Uganda, for example? Well, one thing, as you know, is that, well, the common people, most people think that surgery is too expensive, it's not for everybody, only the rich can afford it. Okay, but that's not true. Okay? Or that already we also know that surgical services are mostly being provided at a very tertiary level of care, at very high levels of care, and in the urban areas. Well, the lower levels of care, the district hospital, and in the rural areas, nothing is happening. If it were you, would you want to have to travel all the way to Kampala, coming from the rural area just to access, an I&D for an abscess? No, you don't want that. You want that closer to your place. But does everybody understand that it's important that surgical services should be provided there? No. Like I said, surgery still remains a mystery to most people. Even how it is provided and what is required for it to be provided still remains a mystery. And most people actually think that they may not need surgery. But everyone, almost everyone, may need surgery one day or another in their life. You never know when it will hit you. Okay? And because of that, we have very limited investments to support and improve surgical care. And so if we want investments to come into surgery, we must engage diplomatically and we must advocate for it. And the last point, obviously, is telling you that we have a lot of morbidity and mortality, and it causes a lot of long-term disability. Most of the surgical conditions occur in people that are generally healthy, but the surgical condition debilitates them. And in our environment in the low middle income countries, we haven't caught up with making money online. We still have to walk to work. We have to use our hands or our legs to earn a living. So we can't afford to be disabled. Maybe if I was in London, I can make money online. Here, I can't. I still have to use my hands and my limbs. But like I said, otherwise, the people that have surgical conditions are generally quite healthy. But the surgical condition is physically disabling and obviously pushes them into impoverishment because, like I said, if you can't work, then you can't live. You start depending on your neighbors or your family, and yes, they may help you, but eventually, that's not going to work. What's happening here? I don't know why my slides keep moving faster. Okay, so what are the requirements? Here, I'm just showing you the picture. You see there's a picture of the monkey doing a dental checkup on the dog. Now, those two usually are not friends. The monkey is always naughty and always jumping around, but the dog usually doesn't get along with a monkey like that. So the monkey was a diplomat to be able to get the dog to be that calm, to be able to check his mouth. But if you look at his the left foot of the monkey, have you seen what it's doing? While he's busy checking his mouth, he knows the danger. So diplomacy does not mean you go there without knowing the risks and everything else. The risks and everything that is involved. So you need to know some things even when you are getting involved. Especially, you must know the person you are advocating to or the group of people you are advocating to. Okay? Because, for example, if I was going to talk or I was going to lobby my colleagues from the Middle East for some investment, and I was a woman, I can't go and meet them with my hair flowing and everything else. No. I have to dress up appropriately for them, isn't it? Yeah, you have to dress up for the occasion. They are Muslims. They like everybody covered properly. I will have to do that for the occasion because if I go there with my hair sticking out and everything else, we were not even going to get along from the start. Okay? So, oh my God, what's happening to my slides? Yeah, so you must have passion. Usually it's easier to advocate for something you are passionate about. Where it comes to global surgery, usually we're doing it because we're compassionate about the people that need this care. We know that potentially we could be victims or patients ourselves, but it requires commitment. It's not a one-day thing sometimes. It's difficult to convince people just with one day. So you may have to do it again and again and again and again and again. I have been working in advocating for global surgery since 2003. And I'm still at it. And sometimes it's difficult to see what you have achieved. Yeah. And then, obviously, as you heard even in the morning, you have to have the desire to change the status quo. The status quo right now about surgical delivery is that most people don't have access to it. It's very expensive. It's not very safe. Now, the second last bullet point, technical know-how, even in diplomacy. You cannot come to me and try to convince me when you know nothing about the topic. Because I'll ask you 3 questions and you'll go blank. I know enough about global surgery and the surgical services in my country and in Africa, so I can argue with anybody, with presidents, with anyone about it, because I have the technical knowledge. So you should always do your homework before you take up a diplomatic or advocacy challenge. Educate yourself, do some research about the issue you want to advocate for, what is there now, what is not there, what is it that you want, and then you must also have some information about the person or the group or those you are going to advocate to. What is their value? What do they want? What have they done in the past? You have to know something about them too. Okay? And then, obviously, in diplomacy and even in advocacy, it requires some political strategy. Huh? So you have to know a little bit of politics. There is politics in everything. Though we always are pointing at fingers for people in government as politicians. All of us are politicians by nature. Even just by the way we live, we are always political. Being, having emotional intelligence, is politics, isn't it? I may not like you, but I'm not going to say it. Isn't it? For the sake of peace, for the sake of us discussing properly. That's why, like I said, diplomats can talk about difficult things. My country is at war with yours, and I'm supposed to come and negotiate ceasefire with you. Maybe I'm a hardcore on the other side, but I have to hide all my claws. I have to hide those things about me so that I can, and you have to do the same so we can have a discussion. It's like marriage. Married people are not always at peace. It's the truth. But for the sake of living together, they have to learn how to talk to each other. You have to learn your partner. She has to learn you so that you can always deal with the difficult things properly without killing each other. So you need some strategy when you're getting in diplomatic engagements. So when we advocate for surgery, what's our focus? Obviously, we want access to surgical care, and it must be safe. We want to improve the health outcomes of the patient. We want to reduce the suffering that is involved. My colleague was presented a lot of papers on the psychological impact of surgical care or surgical disease, which sometimes and most of the time we have left and neglected as people working in the surgical space. And we want to ease the socioeconomic suffering of those that are afflicted by surgical conditions. That's usually the target. But like I said, when I talk about it in terms of general diplomacy and advocacy, that's why I was saying that you must have knowledge of what you really want. If I'm going to talk to MTN to give me scholarship, I want scholarships from a company, I have to be very clear about what I want. Because I have to convince them. And you can't want too many things. You have a list of 20 things. No, it doesn't work like that. It's very difficult to help you if you come with a Christmas tree of demands. So your needs may be big, may be many, but try to focus, narrow down to what is it that you want. Maybe 1 or 2 things that you can actually get. Remember that there will be another season. So it's not the end. You can always come back. But establish the relationship first. Get others to start working with you before you can, start putting more, balloons or whatever it is on your tree. Now, diplomacy obviously has a cycle of how things really happen. They don't have to happen in that order. But normally, for those who have studied the issue, the art of advocacy, they have created some kind of a cycle that is used. Okay, first of all, you must have, like I said, understanding of the topic or the theme or the issue that you want to advocate for. Here, like I said, I advocate for universal access to safe, affordable, timely, surgical care for those that need it the most. So you must understand the good. Here we have the issues of burden of surgical disease. We have global documents like the Lancet Commission on Global Surgery that has given perspective from the global. But you have to understand the issues in Uganda. You know what I'm saying? What's the burden of disease in Uganda? Remember that you may not even have statistics from all the facilities. But like I said, that's probably just the tip of the iceberg. There's a lot of other conditions that are in the community that they don't know. But when you look at malaria or HIV, those guys will give you statistics about what's in the population. Global surgery requires that we take surgical issues as public health. I think there was a presentation in the morning that talked about, the approach. We must understand the burden of disease that we have, you know what I'm saying? And then you also understand the lack of surgical care. Who's lacking the surgical care? What are the complications? What's the mortality from surgical disease? What's the disability? What's the poverty being created from all these borders? Remember, if you want to lobby government to pass policy to regulate the use of motorbikes, you have to come with that information. Okay? Sorry, I seem to be having problems with my slides. They seem to move on their own, or their time, I don't know. But we'll keep going. Now, the information that you present should be evidence-based. It must be accurate. It cannot be a lie. Okay? And like I said, you must use data, because data is very powerful. It's difficult for people to argue against you. Otherwise, it's just your opinion. Don't go and lobby and advocate with just your opinion. Okay, whatever you say, at least must be accurate and can be proven. Okay? And the data should be, compelling. Okay, so don't just, like I said, in the past, in global surgery, we've had this discussion of using emotion. So we have been complaining about the problem, how big the problem is. The burden of surgical disease, how many people are lacking access, blah, 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 blah. That is known now. That story, that song has been sung too many times. And, for example, if we're going to engage governments, government has got too many problems. And now I'm putting on my hat of being a government official. Governments have a lot of issues to deal with. And so when you come with another problem, it's sometimes difficult to get their attention. They may not really listen to you. Or they'll say, yeah, yes. Just to let you speak and go away, like sometimes we do with children. There are some kids who are very, and you say, yeah. They have their say and they go away. I think that if we're really going to be effective now going forward, we must change tactics. That's why I'm saying that now let's paint the picture of the benefits of surgery. If we do surgery, what are the benefits? Okay, it's easier because government is looking for solutions. Everybody is looking for solutions. People are looking for how they can reduce maternal mortality. So let's tell them, you see, if we can do safe cesarean section and we can deal with all the hemorrhage problems around childbirth, the maternal mortality is going to drop. That's what they want, isn't it? They've put in a lot of money. It's not getting down because they've neglected that component. Let's bring surgery as a solution to the problem that they are facing. It will be easier for them to buy in. So when you are advocating, don't always come with complaints. People have enough problems of their own. Try to come with a perspective of the solution. How does it solve their problem? How does it contribute to what they are doing already? That's important. Okay? Oh, God. And like I said, for me, the cost effectiveness of surgery becomes a good point. And that's why in my area presentation, I talked about, let's talk about the economic impact. Let's talk about how does improving surgical care strengthen the health system? How does it improve health outcomes? How does it help with uplifting people socioeconomically. That is what, and then of course we can come with the lessons. What have we learned from what we have done so that we can do things better? That kind of approach and information will be more acceptable, and it's a better thing. Because you see, sometimes you have 2 minutes to actually speak to somebody. And you want that whatever you say to them to remain with them. So if you bring a solution, it's always easier to remember than when you bring problems, because like I said, people have enough problems of their own. Okay, this is just a slide showing what I already spoke to, that you must advocate with evidence. There must be evidence. So we have those statistics coming from the global picture, but you can have your own statistics at country level. So there is value in doing studies that just maps out what's happening in Uganda, so that you have the accurate information about Uganda. This again is evidence about, cancer globally. You can see Africa is painted red, so there we have a lot of, the survival for childhood cancers is very bad, and surgery can contribute to cancer care. Okay? The next slide again paints, I think somebody already spoke to this, where they were talking about the deaths that are coming from surgical disease compared to the deaths that are coming from TB, malaria, and HIV. Just from trauma and injury, it's quite high. But yet investments are not going in there. So I'm showing this, but this is the old system that I don't believe in anymore, of painting the problem, or coming with the problem. So I'm just giving this because I already put in the slide, but I'm urging you to advocate with correct, positive information, not coming with more problems. Okay? So this, again, I've spoken about, having baseline information about your country, your district, your community. And these are some of the things that you can look at that are important to map out so that you can have this and then you can discuss. I can have this kind of information. Because, for example, when I say, yeah, surgery is going to help with reducing disability, there are too many people who are disabled, we're adding to them by not operating on them on time, maybe the conversation then will go, so how do we go about it? How big is the problem? So you still need that negative information, but it may not be information that you actually bring up at the front. Okay? Now, the messaging that you bring when you're advocating or having a diplomatic conversation should be customized to the person or the group or the organization that you're speaking to. Okay? This is very important. Okay? The good messaging I've already spoken to, so it must be positive. You must set targets for yourself. What is it that you want to achieve as you're advocating? Maybe you want more funding, maybe you want more equipment, maybe you want more human resources to come to you. Okay, so the message that you give policymakers, you give funders, you give the community cannot be the same. Customize the message to each group. I'll give another example here where community engagement is really important for us in global surgery. So far, since I don't know when, through 2015 up to now, it's always been us on the supply side advocating for improved surgical care. We, the professionals, people in public health, a few NGOs have been speaking about this issue. We haven't had a voice from the community advocating for themselves yet. Right? So for us, and most of us work in the public sector, so we work for governments. There's only so much I can speak against my government or any African government about the situation in their country, because I work for them, or I work with them. I don't want to alienate myself from working with them. I can talk about difficult things, but there's only so much I can do. But the strategy now we want to use, even in Zambia, is that we want to empower the community with the accurate information. The community doesn't know, because the community can do the activism I was talking about. They can demonstrate, they can threaten and say, you are not doing anything as our member of parliament, we're not going to vote for you if you don't ensure that we have surgical services in our hospital. You see that? So there's messaging. So I have to advocate to the community to ensure they can stand up for themselves. But I have to go and give them accurate information, teach them on how to do the advocacy and activism in their community, show them how they can get in touch with their congressman or their member of parliament, and things like that, because they can push the issue beyond what I can do. Okay? So the messaging is really important, and it must be customized, okay? This, I think I've already spoken to quite a lot already about the messaging. The messaging should be customized and come with positive messages because it's easier to swallow, and then it also gives you a chance to have a discussion with the people you are advocating to. Again, this I've already spoken to. This is talking about the economic and social value of investing in childhood cancer. So these are graphs based on data that would show those that you are talking to the benefits of them investing in childhood cancer. So it's a positive message rather than coming to them with the statistics of how many kids are dying or the sad messages. They have enough sadness from wherever they are working. You must establish connections and partners who you can work with. This I'm just from talking. So you cannot be advocating yourselves as surgeons only, or you, the surgeons and nurses, who else can speak for you? Maybe the church. The church is always talking about, you know, human dignity and a lot of that. You can bring the church along. The youth are very powerful and very strong, and they like to advocate, and they also know how to use social media. I don't know how to tweet and Instagram and a lot of other things. But the youth can be very good agents, and they're always looking for things to work on. The youth are out to conquer the world. Use their energy. Work with them. But you have to educate them properly and still remain there to mentor them and supervise what they are doing. Because the youth can also bend the world. Okay? So establish networks. Like I said, even the community, empower the community with the correct information so that, and also help them with the messaging. How can they present the message? What platforms can they use? And then also show them how they can access stakeholders. Again, I'll come back to the example of Uganda. A government always has a process of how it does its business. The budgeting cycle starts at a certain time and closes at a certain time. Policy formulation starts at a certain time and closes at a certain time. The World Health Assembly has a process. It starts with the Program Budget and Administrative Committee, or PBAC, and then goes to the Executive Board, and then it goes to the World Health Assembly. It's a process. So you can't bring something at the World Health Assembly. That's too late. If you want it to be tabled at the World Health Assembly, you have to know the process. How does it run? Even you yourselves as the Association of Surgeons of Uganda, when you're making policy and taking up things at the AGM, there's a procedure, isn't it? There are always rules of procedure. So you must guide those who are advocating, and you must also educate yourself on the steps and the processes so that you don't come too late. And also you synchronize with the other established processes so that things can get in there. And like I said, again, don't always go to the official residence or the official office of somebody. Usually it doesn't work like that. It doesn't work at all. Because the secretary, first of all, the security guard will block you, then the secretary will block you, or the person will be too busy because there's a lot of other things. So usually the diplomacy and advocacy and engagement are done unofficially. In diplomacy, where it comes to intergovernmental platforms, we made deals while we're having coffee. That's when we talk about the issues. By the time we come to the table, we already know what the Russians are going to say and what the Americans are going to say and what I'm going to say. They know, I know. So don't always work in the formal. The formal is just the cake cutting part. The deal is always sealed way before. Even in your own individual life, employ that tactic. You will see that you're going to succeed. Before you send in an application, meet professor and talk to him about it. At the conference, present there, let him know you a little bit. By the time he receives your document in the office, he already knows who's sending it. You understand? You must do it like that. So don't always go the official way. Diplomacy and advocacy doesn't have to be official. Usually it's not official. The official part is the last part. Okay? Now, in today's world, it's even easier because, like I said, the platforms that you can use are many. But again, you can be tweeting online. Does it really have an impact? Because you also have to know who you are advocating to. Having tweets and people are following, does that achieve anything? Probably not. Yeah, maybe the people will read it, but are those the decision makers? Are those the people who are going to make the change? Unless, of course, they are the actual target. If I'm trying to educate the community and inform them, then of course that works. But if I really want to get to government, and people can easily ignore things that are on social media. So it depends on your target. What platform you use depends on the target and where they can be found. So don't tweet and expect the government to respond. It may not work. If it's the government you want, you have to, like I said, meet the minister at a function, at a meeting, whisper in their ears. You may have 3 minutes only to present your issue. So know what you're talking about. Come with a positive message that you are bringing a solution. They will be keen and eager to listen to you. Okay. And you don't have to use the same method all the time. So you have to, once you do your advocacy or diplomacy, retreat and check, evaluate what you have done. Did you achieve your goal? Do you think you have to change your tactics? What were the barriers in your way? You know, can you do the thing differently? So it's always going and changing. It's like mountain climbing. Those who have gone to mountains, you know, it's not always that you climb a mountain and it's a straight line and you keep going up. No. Sometimes you have to go sideways. Sometimes you have to go backwards around a barrier before you go up again. So don't be discouraged by going sideways or going backwards. What matters is that you maintain the goal of what you want to get to. So don't be discouraged by that, okay? And you have to innovate in the times, okay? Maybe you expected to make you came and you said, I'm going to give a PowerPoint to the minister. The minister doesn't have the time for the PowerPoint. So what do? You have to adapt to the environment. So don't be rigid in your approach to the whole thing. Work with time. Be a chameleon. Fit in with the environment. Okay? And then you can also use other people, like I said. These are young people. I like working with young people because, like I said, they are very powerful. And so you can use role models, you can use the community, you can use the population, you can use the patient families to sometimes present things because the patients have a personal experience of having gone through that thing. How they are going to say it is not going to be the same as you who's never had surgery before. So use allies. There are people that can actually help you. Like I said, it depends on what you want. For example, the issue of us educating the population, we can use celebrities because the celebrities work very well with the people. The people are always following, the musicians, the artists. Let's bring them on board. In Zambia, I remember that we put together a team of musicians. And because we know that Africans love music, they like to dance, and they even want to learn all the words in the song. So what we did is put the educational messages about surgery in the song. So we sit down with the musicians, so we educate them on what to say, because the musicians also can pass on wrong information. So we teach them the correct information, and then they compose the songs. We work with them, and they like to work with you because you're doctors. Who doesn't want to hang out with a doctor? They envy you, just like you envy them. Okay? And then the musicians then go and sing the song, and it's a hit, and everybody knows about it. They know the words. All of a sudden, the information, boom, everybody knows about it. So you can use these role models and celebrities to channel your information, like I said, even the youth. Okay? So then you have to have the measure of success. What's success for you? The success should not only be the overall goal that you want. You must celebrate small wins. Even having an audience with somebody is success. So you must be able to succeed in that way. Here, I was mentoring little kids. These are like under 5 in a school. And I was teaching them about careers, about being surgeons, and what does it mean to be a doctor and a surgeon. So I was recruiting at that age, you can see. But I was busy planting things in the little kids' heads. Because for them, they're fascinated. Usually, they're scared of doctors. Doctors come, they come with injections and all that. But for the first time, you come, in a nice way, wearing your coat, but come with another message to the kids. You can see how attentive they are. Okay? So don't underrate anybody. Anybody can be an ally. These kids come from very good families. They'll go and tell their father about surgery. Dad, a doctor came to our school today and he told about surgery and how the kids are not getting any operations. Kids can pass on information for you. And kids have got the hearts of their fathers and mothers in their hands. Do you know that, or you've forgotten that? So even little kids like that can be agents for you and can help you to achieve what you want. Okay. But the key is that surgery should be viewed on, or perioperative care should be approached as a public health issue. So let's not confine ourselves just to the facility. We must go beyond the facility. And there are also other places where you can find tools that can help you with advocacy. Here we've just given a little example of the G4 Alliance. I'm sure you've heard about them. They like to do a lot of advocacy. They may have tools, even training and promotional material that you can use to do your advocacy if you want to learn more about how to advocate. And it's not just G4 Alliance, there's a Global Surgery Foundation, and there's a lot of other actors that can also help you in that regard. So you can try to go to those platforms online and get more information about what you can learn so that you can keep educating yourselves as you grow your advocacy. So thank you so much. Chair, do I have questions?
Thank you, Prof. We're trying some diplomacy indeed. Yeah, and thank you so much for this enlightening session. I don't know if you have any questions for Prof. 2 questions. Maybe we'll take one from Professor Galkande. Any other question? Oh, there are 3. Let's start here.
Thank you very much. Thank you very much for that talk. I missed a little bit of it, but it's clear that the surgeons must engage the whole spectrum of medicine, from molecular, bedside, in between, to public health. So how should we do it? Should some surgeons abandon the bedside and the lab and go public health? Or we hire some public health people and make them surgeons so that they understand? How should we do it?
Thank you. Let's take the 3, then you answer at once. You have the mic.
Thank you so much, Professor. I was trying to paraphrase your statement, but I don't know, maybe you will enlighten it further. You made note of advocacy, starting your plan early. In our setup here in Uganda, there are some challenges where it's assumed people who succeed have either had an earn. But I just want to say thank you, because it is giving some points to me to understand that some of these things, you can advocate for it, you can finish your assignment earlier than everybody's looking in camera. Thank you so much.
I think that was a comment. I think there are some 2 questions, then we can. That was a good comment. Please go ahead.
Good evening, Dr. Makasa. My question is simply
I'm a student, but soon I'll be a pre-intern. So what role can students play, and pre-interns as well, in surgical advocacy, and also what can they do? Yes, thank you.
We take one more and then we answer. Yes.
Thank you so much, Doctor. I'm very excited that you brought this up. And yes, we can reach out to the big people, but in our country, I think we have reached a level whereby the rich are getting richer and the poor are getting poorer. I mean, like, look at the pre-interns in Uganda. Like, you don't even have money to attend such a conference. You do not have it, but you have a paper as a doctor. How are we going to convince such a person to stay in the country, to work in this country, in this situation? How? Because when you look at our country, I think we have settled with the fact that we are going to finish medical school and a doctor is going to sit home for 1 year, and we have tried to talk with the leaders about this, but it seems no one is taking a step ahead to do anything. So what are the plans? And when the leaders come on board, they are complaining about brain drain. How are you going to convince me tomorrow that, you know what, you stay here? When I hear in Aga Khan, they are going to be paying me 4 million. You're paying me 1 million. Why should I stay in this country? Why? Like, I don't have a reason to be here. You get, I'm already frustrated. 1 year down, I don't even have money to move to Kampala. So when I get my paper and I'm moving to Aga Khan, they're going to give me 4 million. You're offering me 1 million. How are you going to convince me to stay here? And we have tried to talk through this, and no one seems to care. The people who are affected are actually home frustrated. The pre-interns cannot make it to such conferences because they are frustrated. People are frustrated. And people in this room do not care because they are doing well. Someone has a car outside, they're going to move on. Yeah. And I'm very grateful to a few people that have tried to help us. Actually, I was sponsored to be here. I thank Dr. Kakungulu for paying for me. And yeah, but my colleagues are out there frustrated. And I'm telling you the truth, half of my class has applied to Aga Khan, and we are ready to go. We are ready to leave this country. So I don't know how you're going to convince us to stay in Uganda. Thank you.
Prof, you can respond to those. It's good advocacy to start with.
Thank you. This is where I have to be a diplomat. Yeah. The first question from Professor, how should we do it? So the field of global surgery, like I said, opens up the whole field, meaning you who are involved in perioperative care have got other opportunities. That's how I look at it. You have to be involved from public health, through service delivery, through research, through education and training, through diplomacy, and sitting in policy formulation in the boardroom. Previously, surgeons stayed only in the theater. You came to the hospital, you ward, theater, clinic, and that was all. That's not enough anymore if you want this field of work or this issue you are dealing with to be improved. Because you just being in the theater, in the clinic, and on the ward, you are the only ones who knew what goes on there. There are very few people who knows what is involved. And you expected the people who don't know anything about your area of work to improve your care, which has not worked. And that's why we've come up with the global surgery now. Now, should we all be involved? No. We don't all have to do everything like we have said here. Not all of us are very good at operating, as you know. People can learn to be surgeons, and they're just not good at it. Somehow you push them through and you let them graduate. Isn't it? There are people like that. There are people among you who are political at heart, like me. I can talk a lot. I can talk to, I'm okay talking with governments, playing politics with them. I can do that. But the foundation of me being an operative, an orthopedic and trauma surgeon, make me fully understand what is required there. And I did my practice in orthopedic and trauma surgery for 10 years. And when I moved into administration, so I had to run as deputy director in the Ministry of Health. And then I was moved into diplomacy. I didn't choose those career paths. My government looked at what I could do and positioned me like that. Through that experience, now I'm fully fledged in global health diplomacy and advocacy. I'm not a good surgeon anymore because I've been 15 years away from the operating theater. I sit in the hospital. Yes, I sit in the hospital because I have to be in the setting. Because otherwise, if I'm advocating up there with no foundation or connection to the base, I'll be telling lies. So when I talk about things in the university teaching hospital today, I sit there every day. But the work I'm doing is more mentoring, young people to research, is advocating and coming and meeting people like you, supporting countries in this work. So we don't all have to do the same thing. Those who are very good at operating and they love it, stay there. It's okay. But there will be others amongst yourselves that may want to do other parts. And again, even you yourself. Today, this week, you've been here advocating. Next week, you go back to your practice. So again, you don't have to do it all the time. So that's how we approach it. And like I said, it's a new field now. So not everybody has to be somebody who actually operates. We need people who are surgeons, who understand surgery, who have to engage the community. We need people who understand surgery, who can be researchers, like I said, who can be trainers. Those who are doing education and training may not be very good clinicians as well, isn't it? They are good at training people, but they are not the best clinicians. So global surgery opens up the field even much more. It means there are more career paths. It's up to you to choose whether you want to be sustained in one specific field, or you can even do it part-time. You don't have to go in it full-time. And we don't all have to do the same thing. So that's my answer to Professor. The role for students, what can you do? The students, first of all, you have to stay engaged. As young people, as students, you have to stay engaged. So your presence and knowledge about what's happening is very important. Don't just study and only focus on passing your exams. That's very narrow. Because after that, what next? A good student is always prepared for the next step. If you know what you want already in life, it becomes easier to go. If you don't know what you want, you spend 3, 4, 5 years going around in circles before you go. But how do you get to know what you want to do in life? It's by interacting, by speaking, by engaging. There are organizations for students. There are also platforms like this one that can bring you on board. But it's not only this platform. There are virtual platforms now where you can engage in different platforms where you don't have to pay to go there. But you can still network. You have to empower yourself with more information and more knowledge. And what you do depends on your passion. What is it that you want? What is it that you love? If you don't know, you have to do a lot of introspection. So you know what you really like. And the best way to know what you like, at least you know what you don't like, isn't it? Most people, they can tell you a list of what they don't like very quickly. So you can know what you like by eliminating, isn't it? By removing what you don't like already. So know yourself, stay engaged, stay involved, and then you find your passion. And then you can start. Then, okay, maybe I like talking to people, educating patients. So how do I go about that? Now that you know you like to educate patients, then you can start looking, who can I work with? How can I do it? What do I lack? What do I need as a tool to do it? So it's a matter of doing more introspection, more research, more networking, and knowing to know what you want, and then you know how you can make the first step. And sometimes, again, usually, any journey you can never see. When I started from Lusaka, I didn't know what I was going to find here. All I knew is that this is time to pack now, so I pack. Okay, I finished packing, it's to get into the cab. So you can never know what's coming in the future. But you should trust that the future will bring something good for you. And so it will keep manifesting as you are moving forward. Okay, and like I said, also engage with other students. There are other students in other places. In my tribe, there's a saying which says, "Umwana oshenda atashabani no kuipika." A child who doesn't move around or never moves beyond his homestead praises his mother as the best cook. But the moment you step out your home state, you realize that, oh, the neighbor actually does it better. So don't confine yourself to a small environment. And like I said, in today's world, the world is open to everywhere through the mobile phone. So get involved, connect, and your world and your knowledge and everything else will expand. The retention issue, my sister was frustrated. Frustration and fear is the worst emotion you can have. You must not entertain that in your life. Like I said, the Western world looks very attractive because you've never been there. You've never lived there. I got a scholarship to go to the United States as a Fulbright scholar in 2007. I did my master's in public health epidemiology in the US. I couldn't stay beyond my graduation. I had to run out of there. Yes, because when you look from here, it looks good. Everybody seems to have the cars and everything else. But when I got there, there's what they call credit history. I went there with $1,000 cash. I wanted to rent an apartment. They couldn't rent it to me. They refused. They said, I didn't have a credit history. I was like, what's that? Oh, you haven't been borrowing and paying and borrowing and paying. And that's the culture there. That's the system. It's built on credit. If you have a good credit history, then you can borrow more. So when you look at them driving Porsche cars, they don't own those cars. They don't. Here, you live on a cash society. What you have is yours. The second part I could tell you, I actually wrote an article in the BMJ on why I want to stay in Africa way back in 2007. You can look at it and see the points. Family is everything. You can have as much money as you want, but if you are alone, out there, with no family near you, even the money will not be worth anything. Number 3, what do we want the money for? I think I addressed that issue again. If you want a lot of money, what do you want to do with it? We don't eat money. What do you want it for? Or maybe you want a house. Maybe you want land. But do you know that here, you have land, even through your homestead or your ancestors, that is yours? You know how many people on this planet can claim a piece of land under their feet is theirs? Do you know that? The Western world is already demarcated and the land belongs to somebody. And it's transferred from generation to generation. Here, I have land, me. With $1,000 salary, I have a piece of land, not 1, not 2, maybe 3, maybe 4. There are things that you have here that you don't attach value to because the Western world has been duping you and lying to you. They say you live on less than $1 a day, you are poor. You tell me, an environment where I have to pay $100 to eat and an environment where I can live on less than $1 a day, which one is better? So you are saying those things because you don't know. Go for yourself and find out. You will realize that there is no better place than this continent of Africa. I wanted to leave. A lot of my friends wanted to leave when you finish school. But because you also want to follow the traditional paths, you finish school, you become a clinician, an intern. No, the career paths are many. You don't have to be a clinician. There's room in pathology. There's room in public health, for surgery. Global health is opening up a lot of career opportunities for you. Why do you always want to be like your teacher who was an intern and then did residency? No, you don't have to do that. There is a lot of other work that you can do here. To be a doctor, you don't have to work in the hospital only. No. So don't be narrow-minded. We are expanding the field with global surgery. So stay in touch with all of us so we can show you because we've gone through it. And I can guarantee you, there's no place like this continent. Never.
Another round of applause for Professor. And for any other questions, remember advocacy is informal. We can always do it over a cup of coffee.
Yes.
Yeah. We shall take a photo together. I will invite Dr. Kakungulu or Professor for the next session.
Thank you, Dr. Kurigamba. Dr. Kurigamba is a general surgeon, a laparoscopic surgeon at Mulago National Specialized Hospital, a diplomat as well. So we are going to proceed. Our next session is the annual general meeting. And I would like to invite the General Secretary of the Association of Surgeons of Uganda to take over the program.
Thank you so much. Thank you to our keynote speaker for that very insightful and yet exciting. I think I was very excited. The talk excited me. At this juncture, before we set into the AGM, we have a tradition. ASAO appreciates the service of every single person who is involved in our activities, in service, mobilization of resources, supporting from afar. Yeah, we really, truly appreciate. And I think when people do good work, it's good for that good work to be acknowledged. So, and I think we've piled up a number of appreciations over the years. So you might see us awarding many people. This is cumulative work. These are cumulative, and today is just the day to award. I don't know if someone noticed something that changed in this room. Have we all noticed from day one if there is something new that changed in this room today about our setup? Dr. Maggie, what did you notice? Yes, yes. We have a new table, and that table is set apart. It's, I think when you even go near it, you can feel the power around that table. It will draw you in, and we'll all see it. I think we'll have a moment for the president to officially launch it. And we really, really appreciate the work of all our past presidents. I think ASAO would not be what it is if it is not for those. Those are just a few. All our past presidents are there, and their portraits are there. And this will be an encouragement to you to please come by our office and officially see the Wall of Fame. Yeah, so that is something I needed to hint about that is new. So I won't take more time. Kindly allow me invite Dr. Victor Chugonya to take over the award ceremony. Thank you.
Good evening once again. Thank you for being patient up to this time. And we are once again happy to see you. Let's first put our hands together for Team Soroti. Team Soroti has never missed any ASAO activity. Team Soroti, thank you. I think they even know them on the road now. They always know those people are going for. Team Mbarara, put your hands together for Team Mbarara. Thank you for coming. Team Minnesota, put your hands together for Team Minnesota. Team Seoul, South Korea. Team Korea, we have a representative. Other people will also recognize you. Dr. Kurigamba wants me to say Team Kanungu. Okay, thank you for being here up to this time, and we appreciate your presence and continued support for being here with us up to now. It is not easy. It's time to appreciate people. It is good to appreciate people, and I think we should do that. Faith, I will ask you to come and help me. Faith, and I saw Dr. Gamukama somewhere. Where has he gone? Faith, please come over to the table to help give out these awards. So we are going to recognize people who have been with us today. We need to be appreciative. People who have worked with ASAO in the past, and the committee which has been tirelessly working to see that these activities come to be successful. Faith, please come to the table with anyone you wish. I thought Dr. Gamukama would help you, but I'm not seeing him. But you can come with anyone you wish to. Yeah, he's here. He has been. So we shall first of all recognize the past presidents of ASAO. Did you check out the other table just near the entrance? It is our wall of fame. ASAO wall of fame. That one is a temporary one, but we are going to get a permanent one. Very soon they are going to tell you, you are going to hear that ASAO, by the way, we have our offices in Who knows our offices somewhere in Mulago? Not Mulago, the hospital, but the village. We have our offices there. So we shall be putting our real wall of fame there, as that's if in the future we get other offices, but those are the ones for now. So allow me kick off the award ceremony. So we are going to recognize our past presidents. Some may be available, some are not available. Faith, you are ready? And I'm going to ask various people to hand over these awards. Faith, when you're ready, let me know. And we have some other awards that we had kept for some of the past activities, like the camp. So I will start this off. I'll start with the current president, Asau, to come and help me hand over this award. So this award goes to Professor Frank Rubabinda Asimwe in honor of his role in championing kidney transplant surgery in Uganda. That is on the 20th of December 2023. Thank you. Yeah. Thank you, Prof. This one goes to one of our past presidents, and this goes to Dr. John Sekabira in recognition of your outstanding service as President Asau. So this is for our past president. So those of you who don't know, he's a past ASAO president, and the association is thanking him for his activities. Thank you. So I will request Dr. Sekabira to remain behind to help me hand over this one. I will also ask Professor Galkande to stay because he's going to hand over another one. So this one goes to Professor Moses Galkande. We thank him for the dedication and service as co-chair for the scientific committee. This is for scientific committee as the chair, co-chair with Dr. This is This one is for long service. You notice that every time we go to a region for a camp, we recognize the long-serving surgeons in that region. And recently we were in the, remember we were in the western part of the country, Ankole sub-region. And this award, special recognition award presented to Professor Kitya David for your long service, valued contribution and dedication. We thank you. I saw him around. Someone from Barara will deliver it. Dr. Oyania, you can receive this one on behalf of Professor. Thank you. I think he's around or he just walked out, but I know it will reach him. I will ask Ms. Chituka to come and hand over the next one. The next award goes to someone who has served on the ASAO committee. He has served on the committee for quite some time. And this one goes to a special recognition award presented to Dr. Josephat Jombwe. Thank you for your dedication and service as country representative COSEXA. So I think many of you have seen him in ASAO talking about COSEXA things. It took me long to understand COSEXA things, but at least I knew it would always be Dr. Jombwe saying something. So this one goes out to our distinguished speaker today. He has been really committed to this scientific conference, and he has really done us a great job. We have learned a lot. We have been inspired. And someone who came with frustration is going back happy. Let's put our hands together for that. Because little did we know that someone was coming all the way to Kampala to get a solution to their problem. So allow me to recognize Professor Emmanuel Makasa, aka Mukasa, as a keynote speaker at this conference. Thank you very much. We appreciate. Diplomacy from Kanungu. Thank you. Okay.
Can I put it in there? Yeah. Thank you so much. Everybody will be envied me.
Thank you. Unfortunately, I think this recipient is not with us, but I saw him earlier. This is also going to one of our guests today, Professor Dr. Ahmed Ogwel Ouma. He was one of our keynote speakers. Dr. Kurigamba, you're a diplomat, you move a lot. Can't this award reach Dr. Ouma? So it will reach. Maybe you receive it on his behalf. He's around? Okay. Our General Secretary will give it to him, but the diplomat can come along. Yeah, it will reach. Our General Secretary goes all the way to Kenya. Thank you, Miss Olive, for the great work. I will ask Professor Rubabinda to come and help me hand over this award. This one goes out to also a distinguished surgeon who has been a trailblazer in one of the areas in surgery, especially trauma. She has contributed to literature. She's writing books. She's a good teacher, and she's always part of ASAO. So this is a special recognition award presented to Dr. Olive Kobsinje for contribution to trauma care and research. Unfortunately, today she was around in the morning and she whispered to me that she would be back, but I think she's caught up somewhere in jam. So, Dr. Monica Namuga, allow me ask you to receive this on behalf of Dr. Olive. I know you are with her in trauma somewhere. Dr. Namuga is a urologist. Those of you who don't know her, I like telling people that every time I meet her, I tell people, we were classmates. I like telling people that she was my classmate. Thank you. You can actually give her a call. She may come back. She told me she's coming back. Professor Linda. So this one also goes out to, we're recognizing people who have made sure that this activity comes to reality. And I think we need to recognize people who have really done a great job today and behind the scenes. This one goes out to, it's an appreciation award presented to Dr. Namugenyi Christine. She's the co-chair of the scientific committee. If you don't know Christine, you put up your hand. That is an objective question. Is it yes, no, all the above? Thank you. Thank you. So this one, is it bad if I told all of us to stand up for this recipient? Would it be bad, really? Before I mention the name, I will ask all of us to stand up because this award goes to a very special person. I can see Margaret is excited to know who it is. You're excited like me, who is also seeing the name. Let's put our hands together for this special recognition award, which is presented to Miss Immaculate Chiza. If you don't know Miss Immaculate Chiza, people can tell you the history of ASAO and surgery. If you are a surgeon in this country and you don't know Miss Chiza, you are in the wrong room. She worked with Professor Rubabinda for years without salary. She started receiving salary last year. So we thank her for her dedicated work. I think so we thank her for her great contribution to surgery. sometimes it is very important to know that she has contributed to our becoming surgeons. If she doesn't put the right marks, huh? You're in trouble. So this one goes out to, I think, Professor, actually, you receive it and keep it. This one goes to Dr. Stephen Watia for his contribution in training urology and advancing urology care in Uganda. I think we all agree. So, Dr. Kakungula, I'll ask you to receive Dr. Watia's award, and I think at the same time leave it with the you can hand it over to Professor because he will keep it for his teacher. Thank you very much. And Professor, you can have a seat. I will ask Dr. Equitable to come over and hand over the next round. So this one goes to another great person in this country who has contributed to. This one was for last year, but I think at the AGM and the conference, we ran out of time. But this one was an award of appreciation which we awarded to Dr. Rosemary Nasanga for giving the Distinguished Charles Memorial Lecture. You remember she gave us the lecture last year, and she's somewhere enjoying her work, and I think the people in Nsambia are seeing her often, isn't it? Dr. Clara, come and receive this award on behalf of Miss Rosemary Nasang, and we are sure you will hand it over to her. Thank you. Thank you. This is to another one of the past members of the council, and this one goes out to Dr. Joe Chirabwire, who was also a dedicated member of the council as a COSEXA representative for some good time, I think over 6-7 years. I will ask Miss Alice Katelega to come and receive this award on behalf of Dr. Joel Chirabwire. So this one goes out to another senior surgeon who has contributed to surgery in a different way. This one goes to Dr. Sebare Kato for his contribution to advancing healthcare in the private sector. I by the way, I didn't know Dr. Sebare was a surgeon, but after my M.Med, my very first place of work as a surgeon was Case Hospital. So after working for 2 weeks, they told me I have to meet the CEO, the boss. When I went to the office, he was like, you look very young. When I finished surgery, which class were you? That's when I got to know he was a surgeon. So I was very excited, and he welcomed me very well, and he has contributed to healthcare in this country. Who is going to receive it on his behalf? I think I will ask Dr. Setabi come and receive this award on behalf of Dr. Sebale. I know it will reach him. Um, so this one goes to our, our very great partners who have worked with us for many times, and they have been part of the ASAO activities. This one goes out to Smile Train, and we are saying thank you for your contribution in advancing surgical care. We have worked with Smile Train for a long time, and it has always been Miss Alenyo and her team. She has actually been here since Wednesday. I'm surprised that she must have had a very serious appointment not to be around now. So I'll ask Dr. Irene to receive it on behalf of Smile Train. I know they're always together. Dr. Irene, please come over and receive this award. We know it will reach. Thank you. You convey our regards to Smile Train. Thank you. Dr. Podwe, thank you. I will ask. So, Dr. Podwe, just one more. Just one more for you before you go. This one goes out to Dr. Rose Alenyo. We thank her for her contribution and dedication to the services as a member of the ASAO committee, scientific committee. She has been part of the scientific committee that's last year and this year. And she has really made a big contribution to making sure that this conference, we have meaningful presentations. So I will ask, I would have called Dr. Irene back, that's if she doesn't mind, to receive this award for Dr. Alenyo. I know it will reach. Sorry for making you get up twice. So, Dr. Irene, you can stay as Dr. Podwe takes her seat. Thank you. So, we also want to appreciate people who have been part of ASAO for a long time, and they have really supported our activities. And these are special recognition awards. And these people have been supporting surgical services in their different capacities and making sure that what we do is a success. So let me start with Sister Nabide Anna. In recognition of your long surgical camp service, valued contribution and dedication. These people don't miss a surgical camp. Whether it is in Congo, you saw where the next one will be. We have already been invited. So be assured. Thank you, sister. Thank you. The next one goes to Sister Naigaga Noob, who has also been part of, these people don't miss surgical camps. They never. And they don't stop at the camps, they contribute to our services in the country altogether. Thank you. The next one goes to Sister Asekenye Mary. in recognition for her services in the surgical camps. These are recognitions for the recently concluded surgical camp, but also it covers all the services we have received from these people. Let me also have Sister Timango Alice. Thank you. Sister Namwena Janet, Lydia. Sister Mwanga Sisi. If you have gone for a camp and you don't see these people, it means you reached somewhere and you took a different route. Sister Mwanga Sisi. Sister Vicky Sanyu. Sister Ochom Mary. Sister Ochom, is she around? She's around? Sister Namagembe Florence. Sister Namagembe Florence. Sister Namagembe, she's around? Okay. Sister Nakato Ruth. Dr. Nachi, Sister Nachintu Mili. Sister Nachintu. She's not around. Sister Okelo Esther. Nachintu Mili. Sister Sharifa. Mugonzi Sharifa. Sister Mugonzi Sharifa. Thank you, Dr. Irene. You have done a great job. Thank you. So, I have more awards here. So I'll invite former President, Co-Secretary Representative, Dr. Jombwe, to help me give out these awards. And the very first one goes to this is for people who have served on the scientific committee. And this one goes to co-chair Professor Moses Galkande, who has served on the committee as co-chair with Dr. Christine. Professor, he can't believe the double happiness.
Are you sure about this?
I'm very sure. Professor Chamanywa in absentia, I think maybe Professor Galkande can receive Professor Chamanywa. Yes, award. At a small fee. Professor Chamanywa was a member on the scientific committee, or is a member on the scientific committee. Dr. Kakungulu Edward, a member of the Asau Scientific Committee. Scientific committee.
And finally, a coup. The next one goes to Dr. Victor Chigonya. They've told me this one has to also go in double. Associate Professor Frank Asimwe. Double.
And finally, there was another member of the scientific committee, Professor Sebufu, who is also absent, but I can receive it because he's in Mengo. Thank you. So as we conclude this activity, these are for the lifetime services that for the people who, the long-serving surgeons or surgeons who have done a great job in Western Uganda where we were for the camp. We already received one for Professor Kitia. I don't know whether Dr. Oyania will be able to carry all of them, but he should be able to, because rumor has it that the energy he uses is fuel energy. So this one goes to Dr. Deus Twesije, long-serving member in Western Uganda. Dr. Chung, you come over and hand over these awards. Dr. Chung, he always corrects me when I mention his name. He says it's Chung, Chong, Jong. Dr. Jong, he has already assessed the colons of Ugandans. He always gives the characteristics. I don't know why he doesn't give us the data here. He always has the characteristics in his head. He says, in Uganda here, the colon, the sigmoid goes and attaches to the transverse colon. He has those statistics. So this is to Dr. Deus Twesije. And another one goes to Professor Carlos Cabela. You are with him also. Okay. This is for people who have done a great job in Western Uganda. Dr. Deogratius Bitariho, you have a lot to deliver. These were supposed to be received the last time we had a camp. And this is to Professor Mutakoha Ericum. You will deliver? Thank you. This is for Professor Mutakoha and Dr. Deus. Thank you. You can, Dr. Chung, you stay. Thank you. Is Dr. Flavia Lued around? She's not around. She was part of the scientific committee and she's supposed to be receiving this award. Who can? Sister, you take this award, Sister Jiko. You take this award to Dr. Flavia. I think she's near you somewhere there. Dr. Flavia Luwede. She can get it from you. I will inform her. Thank you. So thank you very much for bearing with us. We have not done such an activity in a long time, but we want to start doing such activities of appreciating and recognizing people. And those of you who have not received today, we are making for everyone an award. Yes. For attending, you get a certificate, isn't it? Attendee certificates. So thank you for bearing with us and thank you for making it today. We are still happy. Dr. Chung has gone. I wanted him to tell you about Samsung City. He's the one who told me it's not called Samsung. It is Samsung City. Has he told you about Samsung City? It is very nice. I think the toilets are smart toilets. He tells you stories about Samsung City and you're like, I should do my internship there. Until he tells you that there's no hospital for internship. So thank you very much for bearing with us and thank you for keeping with us this long. Dr. Kakungulu, I think my work is done. Just a reminder, the paraphernalia there, the caps, the jackets, the caps, the scrubs, the jumpers, these are all for you to enjoy and look smart in a Sao attire. So, Dr. Kakungulu, thank you for this opportunity and enjoy the evening.
Thank you so much, Dr. Chigonya. Dr. Chigonya works at Chivuli Hospital as a general surgeon. I want to recognize the presence of Sister Dr. Najuka. She has just gotten off the airplane this evening, but she said she has to be around for the AGM. Thank you so much for coming. All right, I would like to invite the General Secretary to take over the AGM.
Thank you so much. Kindly allow me invite the Executive Council to the stage. Please occupy these seats. Members of the Executive Council, kindly take the stage. We are really behind time. Thank you. Dear members, once again, you're most welcome to this gathering. I'm Dr. Christine Namugenyi, and I'm truly humbled and honored to be your General Secretary, a role that was bestowed on me when I least expected it. I think I was in shock for like 2 weeks. And then I had to kind of take it in and take on this huge role. So thank you for trusting me, and thank you for trusting this Executive Council to lead you. Right now, I'm going to request to move a motion to convert the meeting into an AGM. Could we have someone seconding the motion? Thank you. The agenda of this AGM is, we'll have a review of the previous minutes. We'll have remarks from the COSEXA Deputy General Secretary, Dr. Olivia Chituka. Then we'll have remarks, we'll have the General Secretary's report, we'll have the Treasurer's report, we'll have the ASAU President report, and we'll have key amendments made, we'll have a discussion and resolutions passed. Any other business, and we'll adjourn the meeting. Do we adopt the agenda, or do we wish to add something to the agenda? Could someone adopt or add or reject the agenda? We've adopted the agenda. I will request the members to forgive us. We didn't share these documents early enough, but the previous minutes could be shared. We don't have them right now. I'll just move to give my, I give my report. I'll go ahead and give my General Secretary report, then we proceed. Email. I shared it on email. I think you can use the PDF document, it's easier. Yes. As I mentioned, Dr. Christine Namugenyi, yes, and the General Secretary for the Association of Surgeons of Uganda. I'm recently adding something new to my CV. I'm doing an executive leadership in global surgery program with the University of Cape Town in conjunction with the Harvard program for global surgery. Yes, so who are we? I think most of us know about us, but it's good to always remind ourselves of really where we've come from. ASAO was established in 1987 by our founding fathers. I would like to believe it was Professor Sebastian Kecharazi. And our vision is to achieve a healthy society through quality surgery. So when you look at our conference themes and things that we really push towards our vision, our mission is to provide equitable quality surgical health care to Ugandans. And we have over 500 surgeons here in Uganda and in diaspora. This number was as of 2022, I think. So for the last 2 years, we've actually had more surgeons join. And that's why one of the things we are doing is to clearly have our database that shows exactly how many, what are the subspecialties and all that. I think we'll get into that later. We have 4 training institutions plus the COSEXA institutions. And this mother is mainly made up of these subspecialties. So, yeah. What are core values? Oh. Yeah, so our core values are professionalism, equity, accountability, and innovativeness. So we really want to encourage this among our members. That is the Executive Council that was inaugurated last year, March 2024, and it will serve you up to 2026. That is our 5-year strategic plan. We shared it with on the platform. So we have our long-term, our mid-term, and our short-term goals for ASAO. You can also refer to the documents on our ASAO forum, if this can't be seen very well. Our membership is, for full membership, it's 350,000 Ugandan shillings. It had been set at a rate of $100. So right now it should be around 380. But yeah. Our associate members pay 100,000. So kindly, please, all residents, we encourage you to subscribe and join and support this mother. We rely a lot on your subscription. We managed to establish, I think the finance will give you that report, so I won't include it, but we have our payment modules established. We have an activity calendar. This is something we developed in 2022 to set for the next 5 years so that we know what we are going to do for the subsequent years. So currently we do a 2-year activity calendar. So this one will end in 2025, and then we'll set for 2026 and 2027. So usually we have the pre-camp visits. This is something we are trying to do as early as possible. We were even pushing to do it in December or November, just because when institutions are planning, they all run their budgets at different cycles. So some of them tell you it's Jan to December, and then some of them it's June to July. And sometimes we miss that window of submitting or getting support because we submit late. And then in March, the last week of March, we have the annual scientific conference, surgical landscape exhibition, the Charazi Memorial Lecture, and our AGM. This is a non-voting AGM, so we won't be doing any elections. At least I think the executive is still comfortable in their seats. And then we established something called the South Fund Day. This is usually in the first week of June. So everyone remember Heroes Day. So that's when we wanted to have our South Fund Day. So please turn up and support. Then we have the annual surgical camps. We have the surgical skills training sessions. Mostly they take place from Zambia. The Zambia team and the Kuseksa team usually take lead in that. And we have the surgical camps that are in the last week of September. The Registrar Symposium, which is attached to the Professor Stephen Chijambo public lecture. And I think for this lecture, we said we'll be adopting different lectures and honoring our elders and all the achievements and accomplishments they've done for ASAO. So it will be rotating. So next year we might have a new, this year actually, yeah, we'll be having a new. Last year we were supposed to have the Professor Kakande lecture during this meeting, but he was unable to make it. So the motion was the proposal was to have his, now it will be a memorial lecture, unfortunately. Yes. Then we have the Women in Surgery High Tea. This is usually in the last week of October. And the annual Surgeons Dinner. This one usually is in December. The date is not decided because we have a lot happening in December. We have COSEXA, we have weddings, we have families. So I think this is something we can also discuss from this AGM and see when exactly we can have this kind of event. The proposal for this dinner was, this is when we get to thank our sponsors, thank people who have done things through the year. This award ceremony you're seeing, we wanted to be doing it in that time. This is when we wanted to be inviting the next region we are going to do the camp, and then we invite the previous region we've been in so that they can hand over the mantle, and then we get the champions for the next camp. Usually when you get them earlier, the resource mobilization, mobilizing people, mobilizing the health facilities becomes easier. So we thought that is something that we'll be doing during that dinner. I think members will give their opinions. Yeah, that was this year's fun day. Dr. Jackie, you can see Dr. Jackie there being very flexible. She's still very steady. Yeah, so it was really good. Sister Dr. Najuka gave us some press-ups. It showed us and challenged us. Yeah, Dr. Tendo, you can see her there enjoying. We had filled our bottle of water, so yeah, unfortunately, your president was on the losing team. Yeah, I had to declare that. Yes, this was the pre-camp visit. It was fun. Our team that you've seen awarded there. By the way, these people, I'm informed, because I didn't even know some of them, they've served for over 20 plus years or 19 years of service in camps. If you know the work that goes into camps. So every single time we go knocking at their doors, you're even feeling embarrassed. You're like, we are going for the pre-camp visit. Do you have a week? And none of them is paid. Not even 20,000 for probably border or what, nothing. So it's all their effort and work. So yeah, that was us with Dr. Mark Kasumba, the anesthesiologist. We usually go a full team, the lab, the radiology. Yeah, and it's usually fun. It's like a road trip for us. We enjoyed Buhoeju last year. Then we have the surgical camps. I wanted to just highlight and congratulate members of the SAO, all our past leadership, that as of now, I think as of the last camp, we've totaled a total of 15,245 operations done over the last 25 years. So, ladies and gentlemen, kindly, thank you so much for all this hard work and your dedication and time that you put into this. Yeah, this was just a brief about where we were last year. We were in 13 districts, 25 facilities, 4 schools, and 1 mammo van. Each team had a minimum of about 25 people from our team. So on site, on average, a day was around probably 25 to 35, and a few exceptions were in 40s. And we had excellent team leaders. There's no way you can pull off a camp in such a huge region without excellent team leaders, coordination, even the members being cooperative. So it was really, really a success just because of all your hard work and dedication. So thank you. People are still asking, when are you going back for the mop-up? I think they still disturb Dr. Nyai, the Rugazi people. So, yeah, that is something to ponder about. These were our highlights. We screened about 7,300 patients. We booked 3,100 surgeries, and we managed to do 2,356 surgeries. So you can calculate the deficit there. So that was a huge gap, because if you look at the history of our surgical camps, those have been our numbers. We had 500, like we've been fluctuated. Then we had a huge jump when we went to Lango, Lango sub-region, 1,400. And then in the Ankole, we doubled that number. So it's really a huge achievement for the association. And then we onboarded other disciplines this time. You can see we still had radiology, so they still managed to do a lot of screening tests. We did a total of 17,956 lab tests were done. And then those are the scans. I think we shared the highlight of the camp, so we can go through it when we have time. I also wanted to highlight the next event, which is what we are right now. And this was one of when we introduced this idea, it was hard for people to contextualize or understand the thing of landscape. What is it? What are you talking about? And basically it was to showcase what we do, to showcase the surgical services in this country, to showcase the innovations. People are doing a lot of amazing things out there and they're not sharing. And we showed the first exhibition, this video was played and we showed it to the ministry, top management, and everyone was shocked that this was actually done here. Like, is it actually possible? The video can't play right now, but these fingers were actually working. Like, they regained full function just because of our plastic surgeons. And it highlighted the importance of increasing access because this patient came early, they knew what to do, and then they were managed by the right team. So when we call you to these things and to partner and for us to work together and to make sure we execute these things, it's us trying to advocate for surgery to improve every specialty and every associated discipline. So this is more of a proposal. It's something we suggested last year and something that we've discussed on the forum. For us to work better and to work more efficiently, the Executive Council can't do all the work by itself. You realize this council or committee changes roles every 2 years, and you need a form of continuity of things. So if we start like a project, and a project that's going to go more than 2 years, and yet you change that council completely. If you have a new council that probably doesn't believe in that project, it means that project will stop, even if it was a good thing, right? But if you have working groups and committees that are committed to particular aspects of the different things ASAO does, then you can efficiently deliver. And then we have our members engaged. So the members are involved, you make the decisions, you discuss them, and then that committee presents it, and then it's passed on. And it also means you have more people engaging in the association. And if we have about 10 to 15, and we have 10 committees of 5, that gives you how many people actively participating. So I think it's a way that it's something we could adopt and work with it and see how to really better this association. We keep talking of Batasao. We are the members, we are ASAO, we are the ones who make this organization. So if we don't participate and commit, then we will really just be admiring all those other becoming fellows of American College of Surgeons. It's not bad to be a fellow of those surgeons, but you know, one day it will be a prestigious thing for someone to be a member of, actually right now, I think it's a prestigious thing for someone to be a member of the Association of Surgeons of Uganda. You've heard talks from the minister, you've heard from the PAs. People know you when you say, I'm a member of ASAO, somewhere in the corridors, someone knows you. So I think it's really good, and I applaud the members for that. So we already have the Executive Council, which is governed by our Constitution. So that one stays standard. And last year we proposed to have a Council of Presidents. And this was purposefully for, like I said, we have our presidents and they rule 2 years. They're with us. We run the term for 2 years, but then they have to go. And most times, what someone has done or started or built on, once they are out, it's like they're out, okay? And yet, probably they had brilliant ideas. So we thought this Council of Presidents would actually be, one, the governing body for SAO or advisory body for SAO, and then whatever collaborations and things they had, because sometimes when someone steps out of a role, whoever they were collaborating with, sometimes even the partner might pull out just because it was a personal collaboration. So we want to institutionalize ASAO and even its collaboration, so that even if Dr. Kurigamba steps out of its role, Smile Train doesn't walk away. They will still work with whoever is coming in. And yeah, so our Council of Presidents will always have all our past presidents. And I think you've seen them, and yeah. The other thing we wanted to have was the Association's Liaisons Committee. And this one basically has all the current presidents and general secretaries of the different subspecialty associations. Because we have different subspecialties, so SUJES, PRASU, NSU. So when we are discussing things, and even radiology, lab, so when we are discussing things with regards to surgical care, we've just been going through the whole ENSO process, how do we improve surgery? So if we don't have such a forum where all the leaders meet and discuss, and then we can find out ways of working together and even synchronizing our activities and events. It's not like ASAO is taking over these, the subspecialty associations. Everyone retains their autonomy, but it's to improve our working relationships and collaborations, especially during the activities as well. I think it will be a good thing, and it will help us plan better. And even, you can see just for this conference, imagine if we had all our subspecialty conferences or AGM, and we say, this is the uniform date, we have it in June, this is the National Surgical Conference, so SUJES meets, you come to that everyone passed Renzori, I hope. We were hoping we'll even have a group photo in front of it just for aspiration. So if we had SUJES in that meeting, NSU, you had PRASU, you have lab, you have radiology, and then we have joint sessions where we actually discuss things like advocacy, policy, what. And people can even move between rooms. I go and attend a SUJES session, I go attend a PRASU session, you know. And that is done on the, like we all synchronize and agree on the same day. The nitty-gritties can be worked out, but I believe this is possible because that's what even other societies are doing. So if we aspire to be that big, that's how big we have to dream. And I believe we are all humans and we are all working in these communities. So it's possible. We can actually do it. So I really request that that is something we should take on seriously and discuss it and hopefully work out a plan. Like today we have the Orthopedic Society having something similar like this. So why would that happen? Why wouldn't they have been here in probably in this room or that room, and then now we have our joint discussions? It doesn't make sense. The ministry, the politicians, the government, they won't listen to us if we're not connected or united. Then we have the scientific committee. This was already established in 2022. We have the education. We want to introduce the education and training committee. And this has two working groups, the surgical skills training working group. This was already also something that had been established before. They've been working on something. And the mentorship working group. This one still needs members, really, if you see what I shared. Then the research and grants committee, we think we will work better when we have such things, and like being able as a national association to secure grants that can run big projects, and that way we can even secure funding. I think we can, if we establish this well, it is something that we can really do. And our research even goes, would grow. And I would go to the Ethics and Professional Standards Committee, which has a working group of the indemnity scheme. And then we have the Welfare Committee, which was also established. The Global Affairs and International Relations Committee. And then the Finance and Resource Mobilization Committee. This committee particularly will be left to the Executive Council. So this, but under that we wanted to have a committee that specifically just deals with membership. So the ASAO membership committee encourages people to subscribe, all that, the regional representatives, how they engage the regional members. That committee will be doing that work. And then we have the ASAO Development Fund. We are still really focused on getting that ASAO land, building that ASAO house, and establishing our surgical skills lab. I will use our neighbors like the ICAD. So that's the dream. And then the ASAO Circle, it was established, the paperwork is in process. And then we have a camp working group, which I think will be changing based on the leadership. It's usually, this one helped us a lot. We had a control hub for Ankole, and that really helped a lot to coordinate this camp. Where we are now, it's usually good to acknowledge if anything is missed out here, kindly forgive us, and it can just be added and edited, but we managed to capture a few. Achievements, our wonderful Dr. Charles Olalo got promoted to Acting Director General Health Services. Our past president, Dr. Olivia Chituka, was elected the Deputy General Secretary for COSEXA, so she sits on the Executive Council. Dr. Rosa Leño became the COSEXA country representative, and she was also promoted to a senior lecturer position. Dr. Mbine Ronald was promoted to a senior lecturer position. Zambia Hospital got its COSEXA accreditation for MCS and FCS, and also to have a name-made orthopedics program running. Dr. Wambi David was the overall best candidate for COSEXA FCS, so we produced, the Ugandan was the, yeah, please clap. Yeah, was the overall best. I could not get exactly how many people graduated, the total number, but the COSEXA rep will inform us about that. We had people getting married and all that. Something, this is not my presentation. Okay. Celebrations, Long Service Award. Professor Kicha was recognized. Yeah, he had been informed he had retired, so he was recognized for Long Service Award, and you've seen all the other awards. And yes, unfortunately, we lost a legend, the late Professor Ignatius Kakande. I want to thank the association for standing with the family and friends during that tough time, and those who continue to still go and support the family. The family requested the association of some pledges, and we should follow them up and execute them. So we really salute a legend. When you move around, people talk about this man. Our keynote speaker just said they respect surgery because Uganda was the mother of surgery in Africa. That was one of his first statements he said when he talked to me. So that really hit home. So Ugandan surgeons, we should be very proud and carry this mantle and champion things, because we've championed things that have become big. You can see COSEXA, you can see what Professor Kakande did. So let's take that pride and stand on our shoulders of our giants. And then we unfortunately also lost Mr. Mugaru's dad. I was yet to get the rest of the information, but it will be included and shared on the forum. Our future plans, most of them I've talked about them really, but one of the key things we struggle with is to functionalize the secretariat. This is something that has always come up. We need help, we need assistance. Madame Immaculate was just awarded, but we can tell you many of these things, you ask for them and it's like a favor. So getting things done in time becomes very hard. Sometimes you forget to send letters where they were meant to send. You forget to follow up things where they were meant to follow up. And then we are surgeons. We don't know how to follow up some things. I'm not an accountant. I'm not, to know how to deal with the tax, a tax clearance certificate, all that stuff. You need someone who does it. Otherwise, I'll come back and tell you, oh, the association owes 500 million, and I don't know how I got you there. So, yes, please, this is something, and I believe the president will also talk about it. I've mentioned the SAO committees, so I hope they are adopted in this AGM. The NSOP, you can see that it cuts across. Oh, the split is our short-term, mid-term, long-term. Yeah, and so we want to actively work on the NSOP. We've got support from the professors we've had. Our keynote speakers, they are readily available to help us deliver our NSOP. They've worked on previous ones and succeeded. So this is something we are going to reactivate and make sure we deliver, and we'll have something. We want to conclude our MOUs. We've been very lucky that the Ministry of Health opened his wide doors to us and also requested us to have an MOU with them. It's drafted. We can have inputs, more input from the members, and then we submit and have that process done, but it's pretty much done. And then also, when we invited a deputy speaker in Ankole, one of the highlights was that he requested us to have an MOU with Parliament. I think Finance will tell you this is his docket, but I'm still excited to announce it, that he promised Parliament will give us 100 million every year for our surgical camps. How we plan for it is up to us. So let us take up these things. Let us continue to show up and doing these things. We'll get more, yeah. And then also we have a pending MOU with UNICEF, and other parties are also proposing the same, because everyone wants to associate with you. When you do good things, people want to associate with you. And then we also want to increase our income through the different avenues. The paraphernalia, please support us. We are just trying to mobilize funds, yeah. Surgical education, the Makere curriculum is something that the team has been working on, and we believe that the education committee will help to deliver this and really look into surgical education in Uganda. ASAO has the mandate, actually, to supervise education. We have the mandate to oversee. So anything to do with education, we should determine how our surgeons are trained, the quality of the people we are producing, or the quality of the people we are trusting with the community to work with. Yes, so that is something we are really focusing on a lot this year, surgical education and research. Yes, I'm an optimistic person. I'm a dreamer, and I dream big. Someone in this room can tell you, she says, go big or go home. So, yes, we still dream that we will have the Sao land somewhere on a hill.
And Dr. Jombo is awake. So he's my mentor, Sam also. So when he becomes minister, he may become the catikiro. All right, so we are going to go through the report. Okay, so the General Secretary has gone through the activities of the association, which we have in this calendar year, from the pre-camp visits up to the ASO annual dinner and awards. I don't want to go back to that. However, in the pre-camp visits, I'm going to talk about it in the financial sense. We assess the facilities, but on top of that, we also look at the facility that is going to host our Registrar's Symposium. And in the Ankole sub-region, we used KIU because we had originally used Mbara for a previous one. So we want to use all teaching hospitals in the regions where we carry out our surgical camps. So trending-wise, the camps, pre-camps have been costing us about around 10 million per pre-camp. And the reason is that now we are using more sites. So when we go to 25 sites for the camp, that means we have gone to over 30 or 40, and then we eliminate some so that you can use the 25. Then we have a pre-conference workshop. Now, the pre-conference workshop has always been through partners, and Zambia, Uganda Matters has been taking on this mantle, and we as a soul have been volunteering our members to take on this responsibility. I hope and pray that other teaching hospitals can take up this responsibility, and we have it around the same time or the same week of the year. But then as a soul, I hope this AGM can approve a substantial budget towards this pre-conference workshop, because I believe the training materials, most of them are donations, but if we can get a little fund as a soul, we can be relevant to the residents that we want to be members of a soul in future. Then the surgical landscape exhibition. For last year, we had 2 venues, and you look at the records, we had an increased cost compared to the previous years. Now, that was in Kololo, where we had the first part of landscape exhibition, and then we had the second one in Entebbe. So the 2 venues stretched us a little bit, but it was important, as we agreed earlier, that let us put ASO on the map. Let the world know about ASO. So when you market ASO, through that input, you can be able to generate the funds that we get back to run the activities of ASO. So we also had the Registrar Symposium and Professor Chara's public lecture. And this time around, the Registrar Symposium was in KIU, as I alluded to earlier. And for this particular year, most of the funding was with the generous contribution of Professor, name is jumping out of, remind me? Basa Jabalaba, as told is a professor, yes? I'm not sure. But with the generous contribution from him, we had such a successful event. So this also waived some of the money that ASO had to invest in last year's Registrar's Symposium. So we had, of course, the surgical camp, and I would like to thank the ASO members for the work we did in that camp, and also Professor Galkande for the vision of having us do a remote site-controlled camp. Basically, we were doing it under control, but we're not directly on ground, but we're on ground. But we had the bird's eye view of making sure that we have a good outcome. But still, this camp, when you stretch the multitude of facilities, you have to invest more in feeding and accommodation. But the Ankole team of members of parliament had a support they gave us. But here I will have to also have a little disclaimer. We got challenges because some of the people who proposed to accommodate us in those facilities, the politicians later turned down. So it affects our accountability and our budgeting for these events. And then we had the WISA Haiti. I'm highlighting some of the things the General Secretary has already mentioned because they are reflected significantly on our side financially. Now, this is one of the self-sponsored events whereby the women in surgery pay money and they attend the event. And we always push some of the established surgeons like you to sponsor residents, female residents, so that they can mingle with you. But why I've added the dames for her, I think we need to support as a soul this activity, because whenever they come to the treasurer, I tell them that is a non-funded what? Activity. So we need to put a vote aside from this AGM to fund the projects they're developing. Breast cancer survivors, probably in future they'll also support tuition for residents or scholarships. So we give them a boost as a soul so that they can also use that to mobilize more resources and then they can support for more women in surgery so that we have more female surgeons on board. Then the Soul Fund Day, yes, still this is a self-sponsored event. I'm putting these things here so that you know the events ASO doesn't have to invest money. But there's certain nitty-gritty details that require us to give a contribution to this event, but it had never been passed by this AGM. So I hope this AGM will allow to create a small contribution towards this event. And when it picks up, it will then contribute back to the Soul Fund. If you look at the expenditure of 2023, we had total funds of around 372 million, and we spent 357. So we had a surplus of around 14 million, but in the bank, we had 33 million. What this means that we had some money that was always kept as petty on our accounts, on mobile money with the Secretariat. The subscription money, some of the monies that would come in as contributions. It was not yet institutionalized to have that money always immediately transferred to a SOU account. In the following year, we had a leap of, we had a total fund of 422, but we spent more than the funds that we came in to collect. So we had to utilize some of the previous funds. And then when donors came in, our cash in the bank increased from such events like this AGM. So by the end of 2024, we had 56 million, 936, 523,000 shillings at bank by the end of last financial year. Now, the implication of this is to give us what we have as a statement of financial position. We have what we call the non-recurrent assets, the paraphernalia and the ASO van that we have that keep on recurrent. So in auditing, they depreciate. So when we depreciate, the value from 2022 was at 26 million, but as of last year, we went back down to 24 million. However, if we look at the total asset value, it increases because it also includes our cash at bank by the end of the financial year. So we increased from 26 million, and by end of 2024, it was 81. That is the 56 plus the value of the assets we have at hand. Now, the project funds liable, this is the capital fund. Now, the capital fund is the money you're generating, and also the money, less the money you're supposed to pay back to the datas we have in the particular year. So that gives us, since we had significantly no datas, the total funds and liabilities we had by 2024 was 81 million and 61,000. Now, we have expenditures that go within the ASO budget. I have to let you know that from the time I think I've joined ASO, we have never had a budget, an annual budget as ASO. Now, when you don't have an annual budget, you will run programs depending on the money that is coming in. Now, that may give you use of resources unlimitedly, or it can help you control the resources. But it becomes more difficult when it's not planned for. So when we audited our books from as far back as possible, most of these activities, we couldn't get the actual audits, as I told you last year. But when we moved on to 2023, 2024, we realized that our total expenditure was from 107 million to 491 million in 2024. You realize that the more we stretched out the camps in particular, and the more we created the landscape exhibition 2023, 2024, we came from what we're doing at Fairway of 20, 30 people at a cost of around 15 million, 10, to moving to something that is costing hundreds of millions. So that means that our expenditures were escalating year in, year out. Now, in my mind, I think let's keep it at having access. We can see, we can know how the account is moving, but if we are going to pay, we still stay with our local approach of using a checkbook. It makes it better for tracking and control, and also avoiding financial fraud that can go on. Now, we introduced MomoPay, Airtel Money, and merchant codes or pay. And the essence of this is that we have celebrated Mrs. Chiza Immaculate, for helping us run our soul in the background. And most of you were used to giving her money to pay your subscription. We have anything we need to pay for, you send to her phone. And we now thought it would be better, since mobile money is easier for most of you, to send to Airtel Money, MomoPay, or use the merchant. Now, with this approach, between 5 to 10 million, when it gets to your account, to our account as Osau, to the Momo accounts, the money is transferred directly to the bank account. Because now what we want to do is to have all our transactions bank initiated, all our payments bank initiated. Even if I need to pay for something little, I have to pay it through the bank. Now that makes the generations of leadership in ASO make it easier for them to audit us and also track how the finances were carried out. Now, we also propose to have an ASO annual budget, and I've put a proposed budget which we shall go into the nitty-gritty and then also possibly approve it or reject it. But the essence is that we need to have a framework through which we move. For the past 3 years, we have managed to see how much money we are spending at every activity of ASO. So now, given that trend, we have an estimate of what we can budget for and what we can possibly achieve when we are looking for those finances. I also suggest that we have a specific bereavement fund and an awards fund. You realize silently we have had some of our colleagues we have lost, and you'll find on some of them the collection is through the roof, and then some it passes by like as if we haven't lost that person or their father or mother. In some of the circles around us, people are not extremely happy. So, but if we have a fixed fund suggested here by the AGM, we can stick to that as a soul, and we can be able to account for that. But we should bear in mind our limitations, because if 30 of us lose a father or a mother or a brother or a sister, then the amount of money we shall spend on our soul from the soul account will be. Or we can reject it altogether, and we say for whichever person loses, whoever feels they can contribute can be what? Can get the contribution. So I also suggest that we limit the petty cash we have at hand. It's a tedious process to pay people through the bank, the check, and those modalities, but that controls your treasurer and the secretariat, so that money has a clear tracking pattern. We are tracking it very well, yes, but we are improving it over time so that it is solid what? Solid. Now, we also suggest that we pay all suppliers using the bank or our mobile money systems that we have created, so that makes the auditing also easier for us. And then I also encourage all members to pay using our what? Our merchant code and our MomoPay and Airtel Money that we have created. So that here it will be easier to have these statements than money being received by Setavi, Immaculate, and the rest, and then we begin accounting backwards. I remember Professor Sime last time there to tell you to go to MTN Center to print out your call, you know. It is not something good when I'm asking my good boss to go and do that, so that I can give you the accountability you want. And then these are the proposed budget items in what I think we can have as a budget. The pre-camp visit has been at usually a range of 10 million. We stick to that, and then if we have any adjustments, we give the power to the Executive Council, or we stick that that money should not be increased. So we work to reduce the amount of money that we spend on the pre-camp visit. The pre-conference training, as looking at the different training institutions, we can give them around 10 million each. We make it a serious activity so that we can be able to have our residents learn from these surgical skills workshops. So all these teaching hospitals, the heads of departments can come in handy to push their universities to give us that fund so that we can be able to have it annually taking place. And then the landscape exhibition, by and far, if you look at the accountabilities for the last 3 years, we are ranging around that amount of money, 250 million. However, we are working with the less and less resources. And most of the resources here, I have to state, are coming from funders, the Ministry of Health, and it's because of the strategic partnerships we are looking for, the MOUs we are looking for, so that we can be able to achieve this. If we are looking at our contributions as members of ASOU, we cannot be able to pull off such a fantastic event that we are all enjoying. Then the Registrar's Symposium, around 30 million, and that is to a specific facility. If we drum well, these institutions can also help us, and if we also as ASOU have an input, we can have that achieved. The surgical camp, it's becoming bigger and better. And we are having national medical stores, the Ministry of Health coming on board, and we want them to put this activity in their budget. So if we get like supplies worth 200 million from national medical stores, we can have a camp without the limited resources we are having and the constraints we are having. And they're believing in what we are doing because of the outcome we are having, and are hoping that we'll be able to offload most of the budget costs. Also, as surgeons, I think when I came into the Treasury and on Council, I've always pushed that when surgeons go to the region, any region, we sleep in the best accommodation facilities they're having. We have the best meal they're having in those areas. Because you are giving a service, you should live and stay as comfortable as possible. But we get limited because we don't get those funds. Then the WISA Haiti, I've alluded to that because I think we need these projects. So an input of around 10 million for every year, and also contribution from the women in surgery or the ladies in surgery will go a long way in giving us what we want. Now, the annual dinner and award ceremony, I'm thinking from past experience of the few dinners we have had, I think this should be an ASOU-funded activity where we have paid up members and invited guests attend. We have had a challenge that there are so many activities carried out in December, so there are so many priorities going on. If this is an ASOU-funded activity and we're inviting people to come, I think the attendance will go a little higher. And it's also a way of thanking ASOU members for the activities you'll have participated in over the years. Now, finally, I have to talk about the Secretary General mentioned it, and definitely have to talk about it. We have land. It was given to us. The question that has always been asked as we work on the nitty-gritty, and then what? We have a national development fund that has 11 million shillings. So when we get this land, what are we going to use this land for? I submitted to them the plans which were shared on ASOU, and I convinced them that we as ASOU, we have the money, we have the membership, we are ready. And they are yet to give us the final documentation and the signing to be done. But the question that I still ask members of ASO, and then what? So we have to be ready that when they give us, we are ready to start the next step of the constructions, the nitty-gritty that we want to do. But right now, with the 11 million on the account for the development fund, we have no step ahead we have. So one of the suggestions I have is on top of the committees you have given us, the Secretary General, I wanted to pull out one of the committees from finance to have a specific committee for the development fund. And this committee should look for funds specifically channeled to the development of a soul house, the training facilities, and also the specific offices that we want to have. And then also, on top of having that, I'm suggesting for every activity we do as a soul, we agree as the AGM a specific percentage of money that we have collected without fail to go towards the what? The development fund account. So if we had this activity and we manage to collect maybe 100 million, even if we have a deficit, we make sure that, say, 20 million goes to the development account, then we struggle to find a way of fixing the what? The balance. With that, by the end of the year, our account will grow and it will encourage more members of our soul to contribute towards the development account. So those are our bank details for those who want to pay. Please reflect that. Those are the bank details for those who want to pay through the bank, and the mobile money, the details for MTN and Airtel. And I hope and pray that we can all get encouraged to be part of this very great adventure. Thank you very much. Have a lovely evening. I think I take, Secretary General, I think you have to take this privilege to invite our President.
As you can see, me and this man, he just wanted to torture me and have my seat so that I can sit on the floor. Yes, at this juncture, we were supposed to have, I think, Ms. Chituka as the COSEXA Deputy General Secretary to give us a COSEXA report, but unfortunately she had to leave, and I'm not very certain if yes, I don't want to be on any wrong side of Mr. Jombwe, so I will not do any offense. Yes, allow me to invite the one and only president for the Association of Surgeons of Uganda. He's also the COSEXA country representative, the new representative, so I think we'll be getting the COSEXA report as well from there. Thank you.
Good evening, ladies and gentlemen. I'm trying to find my report. Where is Immaculate? I can't see the report. Was she paid yet? Thank you very much. I have 8 parts to this report, but don't be worried, they won't take too long. The first one is thank you very much. Thank you. Thank you, the council. Thank you, the council, for the hard work. You can clap for yourselves. Thank you to the sponsors. Thank you to the Minister of Health. Thank you to our collaborators. Thank you to our vendors, the service providers. Even if we pay them, we can't take it for granted. Thank you, other associations, like radiology was here. Thank you to the surgeons. And thank you to the students. When we are together, we can do this. What's the saying? Agalumenyam. So the second part is activities, and I think they've been said. I won't spend much time on them, but I've just been looking at the numbers. Maybe we should keep the numbers in our write-ups. It will sustain some history. Maybe when we write a saw there, we could write established in 1987 to include on there. I think this is for Chigonya. I just counted, I'm the 20th president of the association. So you can keep putting the facts and figures. It will say a story, that we have a tradition. I've tried to estimate, JJ, is this the 20th scientific conference? Because camps we've done about, I think camps we're a bit ahead. Camps we've done about 24, 25. So camps, we can give it a higher figure. Maybe we shall, our history and archives committee, we should be tasked with this to confirm the number of camps we've done. We missed a couple because of COVID. So tentatively, we can say 25 camps, 25 major camps. There have been some minor ones. We can put a figure to the conference. This could have been the 20th. Even though a long time ago there would be 5 papers presented, 6 papers presented, but all the same, there were scientific conferences. So we could say this was the 20th. The third exhibition. And so some facts and figures. I've been trying to judge at what capacity are we operating? What is our potential? And I'm thinking maybe we're operating at 20% of what our cell could be. So if you use your imagination, suppose we're at 100% capacity, so multiply what you're seeing by 5. Everything you've seen so far, multiply it by 5. I think that is our maximum potential. So we still have a long way to go. So that's about a little bit about activities there. I've talked about support. So I'll leave that. The third one was obituaries, but the General Secretary has talked about that. We need to figure out, and we have another committee on welfare, we need to figure out what do we do when we lose people. How should we respond? Should we let people respond the way they feel in that moment, or should we have some guidelines on how we should feel? For some people, we may feel too much and express it. Other people will feel too much and not express too much. So, immediate past president, are you chairing that committee of welfare? we need to put our heads together. What do we do? How do we respond to catastrophes? And you know, when catastrophes happen, to overcome those catastrophes, you need personal resilience, but you also need collective resilience. So our resilience as a group helps us to overcome group challenges and individual challenges. And our capacities as individuals also helps us to overcome those challenges. So should we have a shared group resilience? And if we do that, we need to figure out how that will play out. And I think the committees can take the lead in doing that. I've also been reflecting on, the other fourth point was celebrations and awards, and that has been talked about, so I won't go to that again. And then there is a question of involvement and engagement. So what are our markers of engagement? One of the markers of engagement is subscription. And Treasurer, what is our subscription like percentage-wise? So it's barely 20%. So maybe I'm right about our potential as well. So as far as subscription is concerned, we are at 20%. But I was trying to reflect on that and say, how much money for you as an individual you're going to fork out for SOA activities. And it is anywhere between 1.2 to 1.5 million a year. If the scientific conference is 450, if the subscription is 350, if the fund is how much? 200,000. And if a couple of people are going to die or lose people, and you contribute some money. So predictably, about 1.2 million, 1.5 million. So we have to judge that. Is that too much? Is it too little? But in terms of pocket commitment and engagement, that is the ask. That's what's likely to happen. So if you're talking about budgets, that's about how much you're going to be spending. But we also hear feedback that some people are waiting to engage and they're not being engaged to engage. So we're spreading out this responsibility and involvement. So this committee that's going to support the regional representatives to engage people about subscriptions, about contributing in ways that they think they can. So it's really widening the involvement. And I think the committee is about 12, and we still urge you to join them because there are so many things that we can do. So moving on to growth. How much have we grown? I think we're growing. It's always a good sign that we're growing. There's evidence that we're growing. We're growing from the number of graduates. We're growing from new specialties showing up. We're growing in the scope of activities we're doing. We're growing in the magnitude of them. Evidence from the last 2 surgical camps, the numbers have just blown up. We are growing with the relationships with our supporters, like the Minister of Health. It feels like it's grown so much, our relationship with the Minister of Health. The way they talk about us now, I think many times I've said we are the best association. I need to be in the other association meeting to also hear if they are telling them they're the best. But I've heard that many times, that they think we are the best association, organized, more organized, and impact-wise. Our relationship with Parliament, I think, is also growing, and the sign that the Speaker can send someone to represent her, I think that's says a lot. The Deputy Speaker being at our last symposium, or just a symposium, that says something. And I don't know what is responsible for that. It's maybe they are seeing what the association is doing, they are seeing our engagement. And we have to remember the call and challenge the PS was saying. I think it was the PS said that they want to see us more united. I think we need to ask, what did she see that didn't look like united? As how? What was she seeing that is not united? We need to know that, so that we can work on that as well. The list of our supporters is growing. It's also growing, and we need to be intentional about maintaining it. So when there is this much growth, it also means there is more work we need to do, a lot of work to sustain growth. Growth won't be sustained by nothing. Natural growth is sustained by more calories. The bigger you grow, the taller you grow, you need more calories. So you need more work. So you need more work to sustain this growth if you are to get it to where it needs to be. And we are convinced there is no way we are going to do this if we don't think innovatively. Every surgeon has a day job, and a so is now demanding of your time like you don't have a day job. So we need to be innovative about how to manage this growth and sustain it. And I think one of the answers lies in strengthening the Secretariat, getting some full-time individuals, maybe 3, maybe 4, maybe 5. But the trouble is, where do we get the money for that, to sustain that Secretariat? Yet, if we get it and sustain it, then we'll be able to reach out to these potential sponsors and so on and get the support we need to get. I can tell you there are people who have asked us to go and engage them so that they can support us, and there is no time. Because this is pooling, and this is pooling, and this is pooling. And you go back a few months later, they say, but we've been waiting for you to come. So we need to do that as soon as possible. Just know that the engagements are going on for us to get a predictable pot of money to support the Secretariat. And we know once it starts, it will start generating even its own resources to stay. Should we be able to crack that, a strong Secretariat, and improve our individual engagements, then we'll be good. But it's also important that we should have the same aspiration as an institution and for also individuals. If the individuals grow and they're healthy, the institution is also likely to be growing and healthy. And which gets me to the point in growth of the fact that we should look after ourselves as individuals, our personal health, our mental health, and maybe our spiritual health as well. The survey we did last, we had 134 of you responding to this survey, and the time we conducted it, 53% of you said, of the 134, say that you feel often or always overwhelmed with work. 53%. 60% of you say you are sleep deprived. And if you know any psychiatry or psychology, those are not normally good things if you're feeling overwhelmed all the time and if you're sleep deprived. So self-care should be an important theme. It will show up in our activities. We missed self-care today Professor Laboka. But what also Kamalegia talked about is also an aspect of self-care. So we should pursue that theme, because our resilience as a group is impacted by our resilience as individuals, and we must be healthy mentally, physically, and spiritual as well. So the last part, which constitute the next steps, and these ones we are picking also from this conference, we should take this opportunity to present the NSOP's plan and have as many components of it included in the National Development Plan. And once we achieve that, it means it will have implications of government committing to some resources to the association or to the associations. And that institutionalization is what everyone is saying. The PS is saying it. Honorable Bayume said it, that once you put your foot into, or your footprint into government plans, then it will be accompanied by a budget. And therefore you have predictability of existence, because you always know some resources are going to come because they are officially acknowledged. The second thing about what I hope we do and is to continue generating evidence in a targeted manner that advocates for our needs. Continually, people say, present the evidence that what you're proposing is going to work. Now, politicians are politicians, they're not scientists. I think they are not, are they? They're politicians. We are the scientists, we should be generating that. Now, as so we are positioned to generate the evidence, we should deliver to the Minister of Health to use to help us meet the surgical needs in the country. So that's a call. We need to engage, and one of the platforms is our research committee. And I think confidently say that, are you aware of any national research agenda for surgery in the country? Anyone seen it? The research agenda for surgery in the country? Anyone seen it? Who should produce it? Who is best positioned to produce it? I think it's us, then we present it, then it is approved and owned by government, but we generated it, and then it meets our needs. So that's the second thing that is in the next steps. And the third one I think I've talked about already is to strengthen our secretariat so that it can facilitate our ability to tap into the resources and collaborations and the goodwill we are generating. I have a sense we've generated a lot of goodwill. And when we left the Lango sub-region, the Honorable Minister was feeling so good about us all. And when we left the Ankole sub-region, people are feeling so good about us all, generating a lot of goodwill, and we need to tap into that goodwill. The last one is about finances. The treasurer is I'm hearing from the treasurer that we are running a budget of about $100,000 a year, approximately. And I think that's a lot better than it's ever been, but it doesn't sound very serious. We've been around since 1987. We run an annual budget of $100,000. I think we need to repackage it in some other way, depending on how we're talking, because what we calculated in the Ankole sub-region, the value of the work we did was about 7 billion shillings. So are we really a $100,000 budget institution? Maybe not. Maybe that is the hard cash that someone is seeing, but maybe we need to repackage it differently. Because you judge how serious or how impactful an organization is by asking for their annual budget. If they tell you we are very, very serious organization, we have a $50,000 budget a year, I think you will judge how impactful they are. I think some diplomacy and lobbying tactics there. Thank you very much again for your patience and resilience. One of our biggest Achilles heel this time again is timekeeping, but I hope we'll be able to have a solution to that. Thank you very much.
Yes, thank you so much, Mr. President. I would kindly like to open the discussion to the forum. Yes, Mr. Sekavira.
I think the executive needs really a big round of applause for a job well done. But maybe my submission and suggestion, as we are growing bigger and bigger, we realize that we need big stakeholders to finance our activities. And as our activities have become predictable, I think we have been advised by even the guest speaker, Professor Makasa, and even the PS, that we need to synchronize our activities with the budgeting cycles. I think this will help us because, as we all know, we have always been chasing funds. You reach there, you go to knock the ministry, they say, you are late. How I wish you had come earlier so that your activities are synchronized, because we have started demanding for big monies. And you go to the ministry, they throw you maybe 10 million to run a surgical camp, which is not possible. And you start going around, like moving like a headless chicken. So I would suggest that the executive do it intentionally so that they bring out now that their treasurer has already produced the budget, so that we have our activities, they are predictable, and we synchronize with the government. But because government, as we realize, is the biggest funder, and all government agencies, not alone the government per se, but all agencies, they run on budgets, even if any parastatal. So that, and the government cycle, budgeting cycle starts, for example, now, they have already started the budgeting for 2025, 2026. Now, if you go to an MDA and asking for money for next financial year, they will tell you it is already done. So we have to go intentionally so that we produce our budgets to synchronize with all activities. Thank you very much.
Thank you, Mr. Sekavira.
I'm speaking.
Yes, Dr. Okello. Oh, yes, Dr. Kurigamba.
Yeah, I also want to thank the executive. I think it's work well done. And personally, for every activity that they have, of course, done and the arrangement, I think they deserve another round of applause. Yeah. My submission, one, is we are lucky we have the eye and ear and heart of the parliament now. I would think as we lobby probably for an MOU with them, we can try and push them. I don't know what takes to have this made like an act of parliament, because I think that will be one of our biggest strengths, especially for, like, if ASO is directly in charge of surgeons across the whole country in terms of practice, in terms of registration, because all those will come easily as the act of parliament. So if we can push and have an ear along that line, I think it will now somehow indirectly cause people to belong. Now, people don't belong because they feel, even if I'm part or I'm not part of a soul, it doesn't matter. And so you find that's maybe one of the links. That's something we'll need to probably push along. That's one. And then two, for the scientific conference, I think rightly said, we have the different societies now under SOU, which are strong. And of course, now we have grown as a SOU. So I also imagine if we are to have a conference for maybe GI, a conference for neurosurgery, a conference for ophthalmology, still in the same year, it doesn't make much sense as a society, and maybe the PS was right to say that we need to be more organized. So I agree with the point that you passed. If we can have these conferences merged together, we can have this and maybe breakout sessions. But I think it will have to start with like intentionally having meetings, either of the presidents of the different societies, but also for the scientific committee, I would propose that these societies should have a representative on the scientific committees. One, it will help us not to struggle a lot even asking people for abstracts. Somehow the societies will be intentional on research that is along their lines. That is my second submission. And maybe the last one is to implore us to subscribe, but also be a part of the ASO indemnity. Someone rightly said that the lawyers are going to start reviewing our files soon. Of course, for some, they have started reviewing, but I would implore us, if you have not gotten indemnity in a year, let's get it. I think it's about 40. I saw it's now the payments is about 40, so it's something that we need to strengthen as a society and association. Thank you very much.
Yeah, thank you, Dr. Gideon.
Maybe something I forgot to say. I think at the beginning when we are registering with URA, I used my email, which really makes me a bit exposed to URA scrutiny. I would beg the executive maybe to pass it here so that we change the URA and other email, which is registered with URA, so that I'm the one who gets all this information with URA, and give the exposure for me is a bit higher. And as we start getting big monies, I think the Secretariat should start taking it up, and so that we get an official email which is changed and put it to URA. Thank you very much.
Yes, thank you, Dr. Sekavira. I think I forgot to give you an update, and I'm really sorry, but because sometimes you gave us the mandate as the executive to carry out some of these duties that need urgency, we had updated that, I think, as of 2 weeks ago. So we requested for that update where it comes to the institutional email. But I think because you are the director of that team, that component cannot be taken out. I think they still send you a copy, and then they send a copy to the ASAO email. So unfortunately, I think you're tied to ASAO. We will, but we will consult the URA team and see how to handle that. Thank you.
Yeah, thank you very much. I wish to raise a suggestion also.
First of all, I want to thank the General Secretary, the President, and the Treasurer for the reports that we have received. I feel like there was something crucial that was left out in the budget, the proposed budget, and it's an appeal I want to make. If you remember, there was a student here. She did so well, she presented so well, and I think, in my view, she had one of the best presentations. But then thereafter, we had a session where she poured out a lot of anger and frustration to the point of even threatening to leave the country. Now, such frustration, I think we shouldn't take it lightly. She represents a number of students with similar frustrations, and as you can see, she already left because she said she had no car, and for us, we are lucky we have cars, that's why we're still around. But the point I want to make is I have been in touch with many of these students, and they struggle a lot. So I want to make an appeal to the AGM, to the members here. You know, they say a church without Sunday school is a dead church, because the Sunday school is the future. Can we set aside a fund, however small it is, it may be, for the beginning, a fund to cater for students' affairs? The details will be worked out on how they access those funds and they use them. But I want to appeal to us as the AGM to pass a budget to cater for students' activities. There are a number of surgical societies that are coming up, and many more. We shall see many more coming up, but that's a request I want to make to us this evening, that going forward, they should be included in the budget. Thank you.
Thank you. Let me first allow Dr. Okello. I think he's been waiting for some time, then we'll take Mr. Asimwe.
Thank you very much. I would like to start by thanking the ASO executive for the nice work done. I just wanted to thank the Treasurer, Setavi, for the presentation. It was very well written, and I just wanted to suggest one thing, especially on the expenditure column. He nicely wrote how we are spending, how much we are going to spend on the camp, on the exhibition, on the rest. But I would suggest that he adds also on the sources of the income and how much we expect from each, so that you're intentional about this. If you are expecting 400 million from Parliament, put it there. If Parliament is giving us 8 buses for the camp, put it there and cost it. If these people give us food, or petrol station, you have to put those sources of income and how much you expect from up, and so that you see how much will come in and how much you're spending. I see the expenditure is over almost $1 billion, but the sources of income, we need to see that. Is it also $1 billion or less? Just that bit. Thank you.
Thank you very much, General Secretary. Thank you, Mr. President and the executive. 2 things. One, I want to thank the surgeons, the members of ASO, for their continued support. I want to again just emphasize the need for us to have a functional secretariat. But quickly, our Achilles heel is at revenue at hand to run these activities. You can see most of our activities run when we collect funds. Of course, that is obvious. We are doing big things, but only when we gather money from sponsors. We encourage you to pay. We encourage each other. We all know how slow we pay. But if we can avail our subscription in time, either at the beginning of the year, and then be able to hire someone full-time, really hats off and big hats to Immaculate. But the amount of work she does for us in the midst of her routine work, is immense. We need people who are employed, who can be hired and be backed at and be told to call the team in Barara, call Dr. Simwe. Not even just tell them, but they are doing it as part of their routine. If we can establish that secretariat and hire people to do this work, you people were busy. I have, like all of us, we put off 3 days of work. I know all of us are now broke and in trouble. Not only do we have day jobs, we have evening jobs, we have night jobs, we have weekend jobs. Then on top of that, you ask Christine to write letters, Kakunguru to come and check on the people of Land Media. We need people who are employed to do this work. In order for us to do that, we need money. And these people's work will generate the money that we need. So I beg that we take it upon ourselves. The appeal is made. Professor Kakande has died. In no time we have 20 million. This camp, in no time we've got 70 people subscribing. I mean this exhibition, and so on and so forth. So our annual subscription comes in time. We are sure we can hire someone whom we are paying, and we'll be up on our feet. I thank you.
Maybe, sorry.
Thank you. Let me allow Dr. Setabi. I think he wants to respond to Dr. Okello.
Yeah, maybe. Thank you very much, Dr. Okello. That's a very good suggestion, and it's what we ought to do. But right now, apart from, and that's why I never mentioned it in my report, apart from the Deputy Speaker, who told us he will give us 100 million for every camp. It is not in ink. It is, tomorrow, he's a politician, sorry to say, tomorrow things may change. And then too, if you still look at the funds we are getting from the Ministry of Health, they are not specific. We don't have a budget line that is for us all. Last landscape, we received around 70 million. This landscape, we haven't received that amount of money. So now you realize that you can't put a fixed figure onto any of those activities as a source of funds. If, for example, we knew that on average you get 100 surgeons subscribing, we would fix that probably 35 million or 350 million is coming from what? From the surgeons. That we don't have right now. So we budget, we put our budgets across, then we make sure that our MOUs come to pass, then we shall be sure that Parliament will always give us 10 coasters with the fuel, with the driver, and 100 million. Now, when I put it in my budget, I'm sure in their budget line, it is also part of it. Right now, I would be lying to us all and to myself that I expect money that I won't even get. Thank you.
Thank you, Dr. Setabi. I also want to add to someone who suggested something, Dr. Bua, who mentioned about the Students' Fund. There's something we forgot to propose. When we took office, one of our key things was to establish a residence research grant. And we thought as a SAO we would start small. We can just say probably, we can work out how we do it, but probably at least maybe a resident from each institution, maybe the best proposal or what, they get funded, and then that person is even pushed to publish. Or they all submit in a pool, and then the best papers get funded. So we wanted to also inform or present it to the AGM and see if it is something that could be adopted. And this would be one of the things that is announced at the annual dinner, because it coincides before their defense. The other thing is what Dr. Gideon, I think I'll come back to that later. There was a hand. Oh yeah, there was a hand. Oh yeah, Dr. Tendo, you're welcome.
Thank you, Dr. Christine, and thank you so much, Executive. And thank you all for making the time for AGM. It's very important. My submission is, and I discussed this with the GS, that we need to, I'm making an appeal for us to be intentional as surgeons in owning up these activities. For example, the conference is annual, every year around the same time. And if we set aside some money in our budgets, like you have your budget, like I'm grateful that we had a session on NSSF budgeting. I believe we all budget in our houses and in our homes. And one of the things that should come out is what is your contribution to ASAO in your budgets. If we say you put aside $350 for the subscription, and then going forward, you have a surgical conference, and one of us was even suggesting a higher figure. But if between now and the next year, for example, you set aside 50,000 or less per day, by that time next year we will have this money. And the other thing, we have delegates traveling in, and I want to thank Dr. Epodoy and Sister Jiku for purposely traveling every annual conference. They are always here. I don't know where they stay, but they are very intentional, and they have been examples to the rest of us here in Kampala. And going forward, I was thinking that if we can have a pool of like even accommodating delegates who come from up country, so that if we have a conference in such an area, the money we contribute also includes their accommodation. We need them to be catered for and comfortable. Right now, we don't know where they are, but they know. And there are many out there who want to travel, but the challenges are accommodation. So can we be intentional? Maybe generate a pool of having this money. Of course, there is subscription, but also, you know, surgeons, we always pay last moment. That's the challenge we have, that us not being intentional, we pull things to the last moment, and it's quite a challenge on our side. But if we can be intentional in our budgets, set aside something for subscription, this is a recurring conference every year. We have even the self-fund is upcoming. We have the pre-camp right now. We are going to start over, and we don't even know where we are going to start. We need this money. And this is for us, you know, as the association. And then lastly, we have quite a number of, on the platform, there are other people from other sister associations, and the challenge is, you know, they are following all the activities. They are following well, people from obstetrics, orthopedics, they are online. But yeah, I think someone talked about presidents meeting together and having suggestions and agreements to this. I think it also help us a lot with our, because ideally ASAO is the big umbrella, and then we have these other ones, orthopedic, ophthalmology coming in, and then we have the SUJEs, urology also coming in, and so if we can own it up, it would be a very good thing. Thank you.
Yes, thank you, Dr. Tendo. I think I really want, at this moment, to applaud Dr. Okello. I remember at the beginning of the year, they had their SUJEs planning meeting for the year, and he purposefully asked me for the SAO activity calendar so that they can align their activities along with the SAO calendar, just so that we don't have competing events or, you know, and we had done that even the previous year with the mentorship series. Our mentorship series used to run every Friday of the last month, and then that's when the SUJE's meeting would be. And we are the same members who attend these meetings. So we were able to work out a plan and align. And if we could do this with all the other institutions or organizations, it would really help to bring harmony. So thank you so much, Mr. President. Yes, Dr. Brian.
Thank you. Thank you so much, Dr. Namunga. I have two questions. Maybe the first one is to thank the ASAO executive for organizing such a very excellent event, I think, for the 3 days. I think all of us can attest to that. And maybe my first question is about, thank you for designing this very beautiful abstract book. I also have the one for last year. My question is there a database for conference proceedings for the last 20 years? And if yes, how can we access this rich resource? Because I see plenty of abstracts. And if no, when I got an opportunity to move with the team to Harare, I saw that they had archived their abstracts, and actually you can find them online on the websites of COSEXA. Probably it would be a good thing to also attach this on the ASO website. Then the last question is, I was with a fellow resident, and she talked about her experience with, I didn't want to bring it up, but I have to say it, with WISA. The conversations they had, the camaraderie and everything. So there are some things that I'm not going to ask. For example, if I want to talk to Professor Simwe about some things, I'm not going to go to his office and ask him about some things. But in a conference like this, I can ask him about other things besides surgery. Why I'm asking is that some residents told us that they got insights of how, for example, surgeons balance different things. And for us as male surgeons, of course, we have these careers we are chasing and so on. So I was wondering, could there be something, maybe not this year or the next one, but probably in future, something like a men's tea where probably people think that we men, when we meet together, we only discuss Arsenal, Man U, football, but probably and money, maybe. Yeah, probably there could be other things that we can learn from our seniors like Professor Galukande, Professor Simwe, and so on. Yeah, thank you.
Yes, thank you, Dr. Brian. I think Dr. Kakongulu took on the mandate to execute that. He said, give him a day, a time. There is someone, one of our seniors, who's very eagerly waiting for the men's high tea. Is it Dr. Sebale? I've forgotten. Yeah, but I think we wanted to leave that to the men to decide what they would like to do, how they would like to bond. But we think one of the things about this is mentorship. The women's high tea is not just the dressing up and the eating. That's really just that exciting bit about it. Women love to dress up and look good. But we purposefully, we were getting a lot of complaints from residents, and I think, I will use an example of Makerere because that's where I trained. They would assign you or tell you to choose a mentor. So it was your initiative to choose, or if you didn't have, they assign you. But again, mentorship is a two-way journey. You follow up with your mentor, they check in with you. So you kind of have to develop the relationship. So for the WISA thing, we said, okay, we will purposefully assign people. If you don't have, or you say, I like so-and-so, I like they do this, but I can't approach them. So we talk to them, we link you up, then we check in at regular intervals when you're attached to someone. Like, it's a thing we are also developing, and we hope it will work. So we check in at 3 months, at 6 months, and what did you set, where are you? So it's kind of helping building that mentorship thing. But of course, also give back to the community, and then give women confidence to step into spaces that they are, like leadership spaces and all that. So I hope we don't neglect the boy child, and I really request that the men of the house take that up on. Thank you. Two more, right? Okay, we'll take 2 more. Oh, Dr. Felix Soyania will need a mic. And okay. Yes, please.
Thank you very much. And thank you, ASO Council, for the wonderful organization that we are seeing keep improving over and over again. The Finance Secretary talked about partners and new partners. I think this is a very important thing. that we need to look into it a little bit more seriously. And one of the areas that generally has been not taken serious, first by us, but also by the general public, is in the domain of emergency medical services. Trauma is a big thing, but trauma is just one thing that falls mainly under the docket of the surgeons. But also there are other non-trauma emergencies which are surgical in nature. At the moment, there are very many partners that are coming in to support the Ministry of Health in advancing emergency medical services. And the Ministry of Health has been working hard to develop emergency protocols. And being surgeons, we can step in and develop non-trauma surgical emergency protocols that can help the EMS department of the Ministry of Health. In this way, we can be able to get in contact with the several partners. They will be able to know us, we shall know them, because we share the same goals, reducing mortality and saving lives. And in this way, I'm sure we shall have more partners who will be coming to work with us, but also we can work with them and help them spread the agenda of surgical emergencies in the country. Thank you.
Thank you. Let's have Dr. Felix.
Thank you, all protocol observed. Thank you, Council, for leading us tremendously. I have two probably comments or suggestions. One is to do with our finance. I'm glad this has tremendously improved with the online system. But my observation has been that probably you could enlighten us more now that we learned today that everyone appreciates Immaculate has been doing a lot of work. And we are very glad for that. But I will wish that we know what Treasurer does, what Immaculate does, for example. Sometimes we get confused. Some of us who are not within Kampala, that will help us in knowing when do I go to the Treasurer, when do I ask Immaculate. Probably also help us to know what Immaculate does for us, an administrator, or they are working together with the Treasury. That will help us. Second issue is the annual surgical scientific conference. It's great. I wonder if we could probably do the way, let's say, everybody knows where COSEXA is going to be. This year it's announced in the previous conference. So if we can know next year this way it's going to be, if we can probably rotate it, instead saying next year we will come to Kampala, or if say next year it is in Eastern, okay, Eastern region, you're in charge of that, I think will help us in some way, because I know many colleagues of mine who are even within Kampala have attended this conference less than some of us who traveled. Thank you.
Yes, thank you so much, Dr. Felix. Yeah, maybe the president wants to respond to that.
I think the calendar should help a little bit, the activity calendar. I think we had issued one that was running up, what, 2026?
This is for 2025.
Yeah, so the idea of For example, the next surgical camp is in the last week of September. The next scientific conference is in the last week of March. So we're trying to have the same month, the same period of time, so that it sticks. Now the question of away from Kampala is extremely desirable, but I think we still need some years to realize it in terms of logistics and so on and so forth. Shall we be able to get the photo exhibitors come to Mbale and that kind of thing? There's a nervousness about that, but there is a commitment to that. It is just the timing of it. But I think we'll get there. At some point, we'll be truly regional in terms of getting it around the country. But in terms of the ability to predict the activities, I think we're doing our best to fix them in very, very predictable times. IT is when? October. The fund day is supposed to be May, so that is kind of same month, about the same time, that kind of thing.
I think if I'm to add to what the President is saying, this discussion has come up on the forum several times. And when you look into organizing, because now we really want like an international platform. And I'm not saying our regions don't have the means, but when you look at the logistics of even planning and coordinating, sometimes we do groundwork, like he'll leave theater, I'll leave theater. We've been going home at 4 a.m. And just that logistics of even just planning and then getting the facilities. And remember, we don't just want local collaborations. We are really targeting international and global partners. So you have to be able to bring them to and I'll first pause there, but again, we are moving in this new direction of where we want to even first synchronize just as the association, for us to even first synchronize as societies, like SUJEs, orthopedics, ophthalmology. We want to even first get that together so that we can have a joint thing. If I'm to just refer back to our constitution, it says the conferences that will be within the Kampala Metropolitan. And I remember when we first went to Entebbe, it was such a challenge to take people because they're like, no, the AGM says. And we're like, people must travel because we also have people who actually travel from farther. So if they can sacrifice and come, you who is in Kampala and you want us to put for you the conference at Sheraton, honestly, you know, so we had to kind of have a middle ground. So now it's baby steps. And I think for now, maybe my proposal would be we first build this idea that now we want to harmonize, have the joint scientific conferences with the different institutions. Then we also get to know what their programs are, and then we can start thinking of the regional thing. We've done the regional approach for the camps. So the camps are regional, and we insisted on the surgical camp, we conclude it with a registrar symposium so that that region owns the symposium. And I think that will be a better way to prepare us now to this, that we are thinking of into moving that conference into that. Let's try it with the symposium and see how it's working out. Thank you.
A small question.
Dr. Chigonya wants to respond to Dr. Brian Kasaga.
Dr. Brian mentioned something about the gents. Orthopedics. Now, as our team, we were 2, 3, then we go to Bachuba from orthopedics. Now, orthopedics had a team and Bachuba. Now, it was a problem. So, and among the three, only one was a certified footballer. So you can see how difficult it was. But you can suggest anything, because I think what you're trying to say is that there is more to life than surgery, the forces of life. And those forces of life are real. You see, for example, many times we can be in groups and we're always like, that guy doesn't attend activities, he's very quiet, he's lost. 2 years down the road, they tell you the man was arrested, he went to prison for 1 year, he lost a job. So you get shocked that you didn't even know that the man was in prison. So you don't know why he's keeping quiet, you don't know why he's hiding from everyone. So we need to start that issue of looking out for each other and looking for where people are. And I was glad that this time round for the conference, the president took it upon himself to give people personal phone calls. And he was actually calling people in person. So we had talked about this earlier, and I think it did something great for this event, the turn up. Otherwise, it would have been bad. So I think if you have something in mind, you suggest. The ladies like doing their things. We also have our things we like doing. You can suggest anything so that we build on that benchmark and we start. That's what I think.
Oh, sorry. Thank you, Dr. Victor. I've remembered, I think I wanted to respond to one of Dr. Setabi's proposals about the online banking. And I think from my experience, my proposal would be a request that, because we know the mandated signatories, and for online transactions, we limit them. Usually banks give you an option of who can do the transactions. So the suggestion I would have is, if it has to be an online transaction, especially if we are in a place like you've gone to do a surgical camp and you can't access the bank, or we need urgent money and then we are stuck, because we've been in those situations. Then they give you a code. There is a system. So they give you a code and all three of you receive the code at the same time. They give you the time limit, like feed it in within 2 minutes, so all of you are on. And if even just one of you doesn't feed in the code, it means the transaction cannot be approved. So all of you who have access to the account, you will know when a transaction is being made. So if that control system is in place, we may not necessarily limit an emergent online transaction. That's what I would respond to that bit of the finances. Thank you.
Yeah, I think it's a balance between giving the members confidence that their money is safe, having strong systems, and the unlikely event that you have a crook on the crew, they can't fleece you. But practically, like the GS is saying, there are those situations where if you anticipate spending and you carry cash, it may be more risky carrying with you 30 million than using the available digital platforms. And thankfully, the banks know about risk, so they engage those kind of mechanisms that protect. But otherwise, carrying cash or not carrying money at all and conflicting with vendors is more troublesome. So I agree with taking advantage of the digital platforms that are available, but also be aware of the safeguards in there.
All right, Dr. Jackie, yes, I think at this juncture, I would want to bring the discussions to a conclusion, and we get the resolutions, right? What we've passed and what we are rejecting. So, the deputy GS, you've been taking notes. You've been taking notes. I can. So from our discussions, I think one of the things from my report, maybe I can use that example, that was to adopt the committees. And are we all seconding that? It's a yes? Thank you. Let me just look.
So there was NSOP, there was the Secretariat.
Yeah. So are we adopting to functionalize a secretariat? Yes, that is passed. So we also wanted to really take, not lead, but like reactivate the NSOP journey and work on that project. Is that passed? Thank you.
There was also a need to synchronize our activities with budgeting. And the men's high beer or porridge. No? Okay, that one is for planning.
There was an appeal to support students. Yes?
My submission about that is that the budgets are still many, and I suspect that project requires some big input. So I was thinking maybe we task you with the planning of how that project will be run as we plan to actually execute it, because I'm suspicious if people are staying in Busabala and in Ol Salama and the conferences in Munyonyo and they don't show up, will they give us money to support students? So it is and it needs some good amount of money. Maybe we plan to get partners to support us with such activities. But if we are talking
Mr. Chigonya, it's not just about how much the money is. Remember, the appeal I made is however small the budget is, but we have to be seen to support students. So the details of how big or small it is, I think the council can decide. But are we seen to be in support of the students who are our leaders tomorrow anyway?
I think at the moment we are trying and we are doing a good job. I will give you an example. Right in this conference, our ushers that you've seen doing an amazing job, they are students of the Makerere College. They applied to be ushers. They were selected, went through the duties, and ASAO decided it will sponsor 5 of them. That's just a small example. And
So
it
the
has
answer is
sponsored,
yes, anyway.
yes.
Exactly.
And you've had individual surgeons sponsoring the ones who have attended. We've sponsored presenters. Most people you saw presenting, some of them didn't pay. That's like sponsorship because they will tell you, I'm a medical student, I'm this. And then the other way is the resident sponsorship that surgeons really have embraced on different activities to support residents, half payment, full payment. I think that is building up. Yeah, so I think we are not doing so badly, but it's really a good idea. I wouldn't kill it out. Yeah.
We are sounding vague. Sorry for mentioning it many times. We are sounding vague.
I could add to assure Council Member Boyce. I think the principle of supporting students is a no-brainer. There is evidence that there's been that action, and what is currently our finance model at the moment is you present the activity to execute and you mobilize money around it. That's how we're operating at the moment. I'm sure you know that. A camp is coming, then we mobilize money around the camp, then the camp is done. You may save a few millions, but then the conference is coming, you mobilize money around it. The subscription definitely is not enough to fund even one activity. So I'll be a bit nervous about committing 10 million, 20 million to the students, but I'll be very happy to, if you like, to cement. We are pro-student, we shall support student activities, and when those activities show up, then we rally around mobilizing money for that activity. If it's fun day, we mobilize for fun day. If it is education, we mobilize. And actually, we may even mobilize more than if you committed 10 million. But maybe at some point when we are running $5 million assured budget per year, I would say $500,000 is for the students.
Thank you, Mr. President. I think that reminds me of my proposal that I had. I think it's an executive council proposal because we agreed upon as executive to present it to you, the Residents Research Fund, because we thought that would be very intentional. We first focus on the residents, even if we say 3 million, and that would go to them. So are we in support of that? The Residents Research Grant. That looks like, by show of hands, funding. Okay, we are planning that. The good thing, we've established a research and grants committee, which Dr. Brian is a member of. So I'm really looking forward to the next scientific conference to see what comes out of that committee. Thank you. The next resolution, Dr. Tendo.
So the next resolution was about subscription, encouraging members to sign up for the ASAO indemnity. Oh, okay. I think I'm corrected. That's already ongoing. Just to functionalize it more. I think, yeah, most of the things have been talked about.
All right. So at that juncture, do we have any other business? I take this opportunity to adjourn the AGM. Thank you so much. You're welcome to, oh, that is gone. That was our cocktail, unfortunately. I hope in the future we'll be able to find one. I will invite the ASAO president to officially close the annual scientific conference, the surgical landscape exhibition, the Charazi Memorial Lecture, the AGM, and AGM. Thank you.
This should be in the Constitution, and I should have a piece of paper here that says, by the virtue of the power entrusted to me, I declare this meeting closed. Wish you a good night and safe travels back home. Name everybody.